Good morning, and thank you for joining us for our second day of the Norton Educational Series 30th Anniversary Edition. Here with me this morning again is Dr. Bill Chey from the University of Michigan and Dr. Lin Chang from UCLA. Yesterday, we spent a lot of time talking about a lot of diseases of the GI system, as well as information about the pathophysiology and different conditions that you might find in them. Today, we have another full day packed for you, and we really appreciate you joining with us. This morning, you should have received an email from our team that included a link to the pediatric sessions that you were promised. So this is bonus content from leading pediatricians that specialize in gastroenterology from around the world, dealing with conditions of the GI tract in their pediatric patients. That bonus content is available by the link that is in your email and will be live and publicly accessible tomorrow morning for everyone else. Thank you for registering, and we hope that you enjoy that pediatric content. I also need to thank everyone, not only for joining us today, but all the speakers who have made this event possible, and then especially for our supporters. We received educational grants from AbbVie, Ironwood, and Takeda that has made this program possible that we could bring to you this weekend. Thank you to them for their support. We also have an exhibit hall. I mentioned this yesterday, and if you didn't have a chance to go check it out during breaks, please try to do that, or maybe next week. It will be live, continuing on with all of the educational content that'll be on the website. We have two exhibit halls for you. One is an industry exhibit hall, which is filled with different companies that specialize in the GI medicine, but then also we have an entire exhibit hall of patient resources. And this includes various patient advocacy and education nonprofit organizations that can help you with specific disease states or specific medical needs for your condition. Please check that out and look at those resources and see if there's any that might meet your needs. But before we continue, just a further reminder of who we have with us today. Dr. Bill Chey is a professor of medicine and the Timothy Nonstrat Collegiate Professor of Gastroenterology and Nutrition Sciences at Michigan Medicine in Ann Arbor. He is also the director of the GI Physiology Laboratory, the Digestive Disorders Nutrition and Behavioral Health Program, and the Michigan Food for Life Kitchen, which for those of you who were able to attend our Norton Educational Series in October of 2020, we held that one in the Food for Life Kitchen with Shanti Ezron. He is also the medical director of the Michigan Bowel Control Program. Dr. Chey has been a longtime friend of IFFGD. He is on our board of directors and is actually the program chair for this weekend. And we are very grateful for all of his support of IFFGD. Dr. Lin Chang is a professor of medicine at the David Geffen School of Medicine at UCLA in California. She is also vice chief of the Yuvat and Tamar Manukian, thank you, Lynn. Manukian Division of Digestive Diseases and Program Director for the UCLA GI Fellowship Program. She is co-director of the Oppenheimer Center of Neurobiology and Stress and Resilience. I apologize. Both of these amazing physicians are experts in the area of functional GI motility disorders. They both specialize in learning more and doing research in irritable bowel syndrome, other functional GI disorders of the entire GI tract. We're so lucky to have them with us. Dr. Pandolfino was with us yesterday, and he is an amazing researcher, clinician, and educator at Northwestern University. Unfortunately, he is not able to join us today, but we really were thrilled to have him with us yesterday. So, as I mentioned yesterday, we talked a lot in the morning. So our morning session was about pathophysiology. It was about diagnosis. It was about how the GI tract works and what sort of conditions might pop up in the different sections of your digestive system. Today, we want to take that a little bit further. We want to talk about treatments. So if you have a disorder or you have discomfort or pain or symptoms that are affecting a certain part of your GI tract, what sort of things you might, doctors might be looking to treat the disorders that were discussed yesterday. But because we're talking about treatments, and treatments for the most part are FDA controlled or approved, there's going to be a lot of terminology and talk about research studies. And some of you may not be completely comfortable or understanding a lot about what that might mean. And so some of the terminology might be foreign to you. So before we start today, I wanted to have you guys maybe explain some of this. So probably one thing that you hear a lot is a really long phrase, randomized, double-blind, placebo-controlled trial. And that's a mouthful, but what does that really mean if a drug has been through that type of trial?
So that randomized placebo-controlled trials are the gold standard for conducting a research study where you're comparing an active intervention to a placebo intervention, or an intervention that looks identical to the active intervention, but doesn't actually contain the active drug. Double-blind means that neither the patient or the investigator knows which patients get the intervention and which ones get the placebo. And all of these things in aggregate are done with the intention of reducing bias. In other words, unconsciously, we may influence the results of a trial, or patients may report their symptoms differently depending on whether they think that they're receiving the active drug or the placebo. So the truest estimation of the impact of an intervention can be achieved through this randomized placebo-controlled trial.
Fantastic. So it's good to understand that when one of our speakers today say randomized, double-blind, placebo-controlled trial, that means they're talking about a trial that is very rigorously designed.
Yeah, and then the randomized part is that it's decided, you randomly are assigned to one of the two groups, whether it's the active medication or treatment or the control arm. So, just by chance, you may get assigned to one and Bill would get assigned to a different one.
Okay.
So everything that is done is trying to decrease the risk of any bias.
Okay.
Or impacting the study in a way where you're studying something other than the active treatment.
And one of the things, and we talked about this, Bill, yesterday, was just touched on sort of clinical trials and the FDA approval process. And you mentioned phases. And so we will hear that a lot in today's sessions. Can you briefly just touch on what are the phases and what those phases are intended to do?
Yeah, so very briefly, there are phase 1, phase 2, and phase 3 trials. Those are really the ones that people need to know about. Phase 1 is all about safety, just proving that the compound is safe in humans and is safe to go on to phase 2. Phase 2 is usually dose ranging. So we'll actually administer several doses of a drug to figure out what the optimal dose is. And that leads into phase 3, which is the randomized double-blind placebo-controlled trial in a large number of patients to make sure that the drug is efficacious and safe in a large group of patients with a particular disorder. So another thing you'll be talking about in the talks is that studies are adequately powered. Okay, and what that basically means is that the study contains enough patients so that you can see a differentiation between the active intervention, i.e. the drug, and the placebo.
Okay. And Lynn, yesterday you talked about, you used the word sample size. And so we're going to hear that a lot today. So when we talk about sample size, what is that? What is it? How does that matter? And what would be considered like high powered?
Yeah, usually that's calculated statistically based on some pilot or previous data so that you are making an educated decision on what is the number of patients you need in each group, whether it's the control placebo group or the patients who are receiving the active treatment. And if you study too little, a small number of patients, you may not really be getting an accurate assessment of the efficacy of the agent. And usually for like an IBS trial, you need 600 patients. And often they do 2 big, large phase 3 trials like Bill was mentioning, where there's 600 in each group. So it's actually 1,200 because sometimes the effect of the drug and the placebo is not that large, and you need a larger number of patients to really accurately assess whether it works or not. So that's really important.
Okay, great.
And in fact, just so people know, that phase 2 study, you figure out the dose, but the phase 2 study also provides the estimation to power the phase 3 study. So in other words, if you see 70% of patients get better with the active drug in the phase 2 study versus 50% with placebo, then you calculate the number of patients you need in the phase 3 study based on that 20% difference that you saw in the phase 2 study.
Fantastic. Okay, so this is all great. So the other thing is, so when we're talking about clinical trials and drugs, we talk about endpoints. So primary endpoints, secondary endpoints. What is an endpoint, and why is that important, and how is it determined? I know that's 3 questions, but who wants to start?
You want to start?
So endpoints are the outcomes or the measurement by which you're going to determine if the treatment was effective. So for like a high blood pressure medicine, a good endpoint would be, did I bring the blood pressure down to a normal level? And the endpoints for these conditions are based on what's the most meaningful symptoms and bothersome symptoms to the patient. So for IBS, the primary endpoint, which is the main endpoint you're looking for to determine if a treatment is effective or not, is reduction in abdominal pain, because that's a hallmark symptom of IBS, and an improvement of bowel habit, whether it's constipation or diarrhea. So that's what the main outcome measure you're going to determine if the treatment is efficacious. And that's based on previous data of what is important to patients, and also by the phase 2 trial.
Yeah.
Like you'll determine how the treatment works, and you'll look at different outcome measures, and then you'll determine how does that medication work? How does that, what symptom is it really improving?
Yeah, and the nice thing is, this isn't true for all conditions, but for many conditions, the US FDA and the European Medical Authority, they have established primary endpoints for trials in patients that have gastroesophageal reflux disease, irritable bowel syndrome, chronic constipation. So for a lot of these conditions, people have gone through this very thoughtful exercise that Lin has outlined, and they've established standard endpoints for trials in these conditions. And the reason why that's important and good is because it allows us in some way to go back and compare the results of trials with different drugs. It's not a perfect comparison, but it gives us some idea of a more apples to apples comparison, as opposed to 2 studies with drugs for the same condition, but using completely different outcomes.
Yeah, I would also want to add that the FDA and other regulatory agencies, they have a guidance of how you determine a proper endpoint or outcome measure. And it really starts with understanding the literature, but understanding what patients feel. So they start with patient focus groups. So it really starts with the patients, where they will say what is important to them, what symptom is bothering them, what do they want improvement in.
That is fantastic. And the FDA is always open for patient feedback in order to help them with these. And so please know that you can visit fda.gov and leave comments and emails with them. They always want to hear from those of you at home who are actually living with these different disease states. Also, here at IFFGD, we have a patient panel, and that patient panel can offer you, by joining, can offer you the opportunity to get involved in some of these patient focus groups and in some of those feedback on what are your most bothersome symptoms. So that is fantastic. We need to move on to our first session, but before that, the word baseline came in. So there was some of the speakers would say compared to baseline. And real quick, what is baseline?
So what happens in almost all these trials is there's a period of time where patients are not receiving either the intervention or placebo, but where their symptoms are being recorded. So like for irritable bowel syndrome, you'll be recording the level and frequency of pain that you're experiencing, whether you're having constipation or diarrhea. Usually that'll go on for a week or 2, and that provides a sort of baseline level of symptoms to which you can compare symptoms after the intervention.
Fantastic. So we hope that this has given you a little bit of background information on some of the terminology that you will hear. If you have any questions at all, please drop those in the chat. We will be monitoring that chat internally. Those questions will be answered at the end of the session when we come back together to talk and recap the previous session. So our next session, session 6, is going to come up. Lynn, would you like to introduce that?
Yes, so you will be in for a treat because there are 2 highly respected, well-known experts in the field of functional GI and motility disorders. The first speaker is Dr. Michael Camilleri. He's professor of medicine, pharmacology, and physiology at Mayo Clinic, Rochester, Minnesota. And the second speaker is Dr. Ronnie Foss, who's the chairman of the Division of Gastroenterology and Hepatology at Metro Health in Cleveland, Ohio.
We hope that you enjoy this session.
Thank you for the opportunity to participate in the IFFGD education and particularly the Norton Education Series. So what I plan to do is to review the pharmacological and surgical treatments for disorders of the stomach. And specifically, the objectives are to review some of the candidate drugs for gastroparesis, specifically neurokinin-1 receptor antagonists, the ghrelin receptor agonist relomorelin, and a new 5-HT4 receptor agonist felcicetrag. I will then briefly cover medications for dyspepsia that are associated with a reduction in gastric accommodation. And finally, review surgical and procedural approaches for gastroparesis, including peroral endoscopic myotomy of the pylorus and laparoscopic sleeve gastrectomy. So let's start off with medications that have been tested recently for the indication of gastroparesis. And the first among this group is tradipitant, which is a novel neurokinin-1 receptor antagonist, and it improves nausea and other symptoms of gastroparesis. Let me take you through some of the data. You can see that this was a randomized double-blind placebo-controlled trial conducted in a fairly significant number of patients and comparing tradipitant with placebo. The primary endpoint of the study was nausea, evaluated on a 6-point scale, adjectival scale, from none to very severe. And as one can see on the left side, the intention to treat analysis population showed a beneficial effect of tradipitant compared to placebo in terms of the change in nausea severity. And this difference was even greater in patients who had a baseline symptom of vomiting among the patients with gastroparesis. Indeed, if you look at the data in some more detail, the definition of a complete responder analysis was a patient who has a nausea score of 0 for the last week of treatment, and the gastroparesis symptom index analysis. So if the responder status was defined as a subject having 1 or greater point improvement in the gastroparesis symptom index, and if you look at the data at 4 weeks, you can see the benefit of tradipitant compared to placebo in the intention to treat analysis for nausea, for complete nausea response, and also for the gastroparesis symptom index. And this improvement was actually even better for the patients who have baseline vomiting. And this is also illustrated, and I won't go into this in much greater detail, but basically, if the patient's nausea improved, there seemed to be also an improvement in the other symptoms that were being assessed. And this was particularly true in the patients who received tradipitant and had a response to nausea. So the presence of vomiting at baseline, the improvement in nausea, seems to be a very good predictor of responsiveness to tradipitant. Now, tradipitant is one of the 2 currently studied NK1 receptor antagonists. The other was aprepitant, and this study preceded the tradipitant paper by about 2 years, and it came from the NIH Gastroparesis Consortium. So this study again compared placebo to tradipitant. The primary endpoint was not actually significantly altered in this study. As one can see here, the response rate was 46% in the aprepitant group, 40% in the placebo group. But if you then look at the cardinal symptom index of gastroparesis, and you look at the total score, the nausea score, and the vomiting score, there was an improvement with the aprepitant shown in the light blue histogram bars compared to the orange bars indicating placebo. And this is also illustrated on the next plots, which show the improvement with aprepitant for nausea, vomiting, and retching. So even though the primary endpoint was not achieved, several of the individual symptoms, as well as the total gastroparesis cardinal symptom index, seem to be improved with aprepitant. Ghrelin agonist relamorelin. This is a pentapeptide ghrelin receptor agonist. And many years ago, Andrea Shin, working in our lab, had shown that there was an acceleration of gastric emptying with relamorelin compared to placebo. So here you can see, for instance, at 4 hours, there's still residue in the stomach, whereas in the relamorelin group, this was a crossover study, the same individual, you can see that there was none of the meal remaining in the stomach, and all is in the small intestine. And so there is certainly an improvement in the symptom, in the gastric emptying rate. And in this relatively small single center study, we were able also to show that there was some improvement in the average daily diary gastroparesis cardinal symptom index, as well as the scores for many of the symptoms of gastroparesis. And further studies, phase 2A and phase 2B studies, have confirmed the benefits in a much larger cohort of patients than in our single center study. And here you can see the improvement in symptom scores for all of the 3 doses compared to the placebo. And all 3 doses were associated with an amelioration of gastric emptying. Now, ghrelin receptors are also present on the nodose ganglion, the sensory neurons from the stomach. So this appears to have 2 potential benefits. First, reducing the symptoms going from the stomach to the brainstem to the dorsal motor nucleus of the vagus and the nucleus of the solitary tract, which are involved in reflex responses, as well as in the efferent pathways that are involved in stimulating gastric emptying. So this looks very promising, and it is my understanding that it is currently going through phase 3 studies. One of the adverse effects with relamorelin, which was noted in those diabetic patients with diabetic gastroparesis, is that there was an increased likelihood of having hyperglycemia if you had a response to relamorelin. And this is perhaps understandable because the dose of insulin or other anti-diabetic treatment was not modified while this prokinetic, this very effective prokinetic, was given. And so it's conceivable that some of that postprandial hyperglycemia was secondary to the acceleration of gastric emptying. And so one of the things that should be done if a potent prokinetic is going to be used for diabetic gastroparesis is we need to make sure that the patients are instructed on how to manage the postprandial hyperglycemia. For instance, it might require a higher dose of pre-meal insulin in the patients who actually benefit from the relamorelin treatment. And that is being instituted in the future trials of relamorelin. The next drug is felcicetrag, which is a 5-HT4 receptor agonist. And this appears from all studies done to date to be very safe from a cardiac standpoint. It does not have the propensity to stimulate pro-arrhythmic pathways in the heart. And this was a single center randomized controlled trial. You can see about 10 patients in each of the treatment arms, and we performed pharmacokinetic studies as well. But let's focus on the transit measurements. And the transit measurements show that there was an acceleration of gastric emptying. So if you look at the stomach in the 4 treatment groups at 120 minutes, you can see the amount within the stomach, and here below you see the amount that's been emptied. So in the patients with gastroparesis, these were about 75% idiopathic, 25% diabetic. You can see that there is an acceleration of gastric emptying, and this is illustrated for each individual both during the baseline and after just 2 days of treatment with subcutaneous felcicetrag. And here you can also see the benefits of the medications from the perspective of percent change. But here you see the entire gastric emptying profile. And I'd like to point out that this is starting at 0% emptied at 0 time and 100% emptied, evaluated over a period of 4 hours. And here you can see that the placebo arm is the slowest to empty, but the 3 doses of felcicetrag appear to accelerate gastric emptying, particularly the higher doses of 0.3 and 1.0 milligrams subcutaneous injections. This was also associated with an acceleration of small bowel transit, as you can see here, and also with an acceleration of colonic transit. So this 5-HT4 receptor agonist appears to have the ability to stimulate motor function and transit throughout the gastrointestinal tract. And of course, clinical trials are now awaited to see what is the clinical benefit. And since this was a subcutaneous injection, it would be nice to have an oral formulation of the drug. Let's move on and consider there are some patients with dyspepsia who have impaired gastric accommodation. Certainly in our clinical practice here at Mayo Clinic, up to 50% of patients with upper gastrointestinal symptoms suggestive of dyspepsia have impairment of accommodation, and 25% have both impaired accommodation and impaired gastric emptying. So again, the two treatments to be considered, one is the NK1 receptor antagonist, and the second is a dopamine receptor antagonist, traspiroben. So these are data which were published in the American Journal of Physiology, and it was a proof of concept study which we did in healthy volunteers. And here we showed that the same drug, aprepitant, which was used by Dr. Spasrika and the NIH consortium, and showed that it had a reduction in symptoms like nausea and bloating and vomiting. This was associated with an increase in the size of the stomach during fasting and an increase in the accommodation response, the postprandial response of the stomach, suggesting that if we have patients with impaired gastric accommodation, this might be a medication that could relieve those symptoms. Of course, further clinical trials are required. Traspiroben is a dopamine D2 and D3 receptor antagonist, and these data are just virtually going to be published in the next week or so by Elementary Pharmacology and Therapeutics, and Brad Coe is the lead author on the paper. And what this shows is the change in the volume to fullness during an Ensure meal test. So the way this is done is the patient drinks Ensure at a rate of 30 milliliters per minute. We do this at baseline. We do this following treatment of the patient with the medication, and then we can see what has been the change in the volume that the patient can drink after taking this medication. And you can see that the volume to fullness is enhanced by some of the doses of traspiroben that were tested. This is working predominantly, we think, on either the symptoms, the sensory pathways, or the central mechanisms that are associated with fullness and nausea. As in this particular study, there was no enhancement of gastric emptying measured by the 13-carbon breath test. And of course, the study was too small to actually ascertain its efficacy from the perspective of symptom improvement. But it certainly appears to be very promising for relief of the symptoms as a dopamine D2, D3 receptor antagonist. As I said before, the composite score was not significantly different, but you'll notice the relatively small sample size in this first study. Finally, I want to spend some time talking about surgical and procedural approaches for gastroparesis. As you know, peroral endoscopic myotomy is a treatment of choice for achalasia, and in the last 3 or 4 years, it has certainly been applied widely by several centers to relieve any obstruction that is produced by the pylorus. So pyloromyotomy is performed endoscopically by tunneling the endoscope and cutting the pylorus and then clipping the opening in the mucosa in order to ensure safety. So this is an endoscopic view of the pyloric muscle after tunneling into the submucosal space. Here's the intra-procedure image with complete visualization of the pyloric muscle. Here it is prior to the division. And then after the muscle has been cut, and there is a vision from the submucosal tunnel. Now, how efficacious is GPOEM? Well, there have been many, many studies, and these are just presented just to illustrate to you how many studies there were. These have looked at mostly patients with diabetic, post-surgical, or idiopathic gastroparesis. They have evaluated gastric emptying, they evaluated symptoms, as well as adverse effects. And in general, the procedure is safe. Very rarely you can get a mucosostomy, which typically heals spontaneously or with conservative treatment. There's improvement in gastric emptying, as you can see here. Several are normalized or significantly improved, and there is improvement in the symptoms of gastroparesis. These are, of course, all open label studies. There's never been a sham controlled study. And so, you know, we have noticed the improvement, and really the most recent paper published in Gut by the Hopkins group with Kia Vasoki as the lead author and Muin Kashab as the senior author shows that at 1 year, approximately 58% of patients have continued to show improvement, but that, of course, is lower than the 75% or higher. In fact, you know, for gastric emptying, sometimes it's even up to 70% improvement or normalization. So, in essence, we think that there still is the opportunity to understand the benefit of this procedure with sham-controlled studies. There are data, there are multiple meta-analyses, and here in this caption up here, I'm showing an example of a patient with significant pylorospasm as antropyloroduodenal manometry. And incidentally, this patient was on high-dose opiates, which, as you well know, causes spasm of the pylorus and many other gastrointestinal sphincters. That's to contrast with normal antropyloroduodenal coordination, which you see below in a healthy person. But to cut a long story short, several systematic reviews and meta-analysis show clinical success, improvement in symptoms, and improvement in gastric emptying. And as stated, we do need sham-controlled studies. How might we predict the responsiveness to endoflip procedure? Well, one of the ways is to measure the pyloric distensibility and diameter with this device called an endoflip. And data from Michigan, from Dr. Watts and Dr. Hasler, shows that the pyloric diameter improves, although, you know, relatively small numbers in the change in pyloric diameter, and also data show that the distensibility of the pylorus becomes greater. And there are controversial information, or contradictory rather information, in the literature regarding the ability of this device to predict responsiveness to GPOEM procedure. One of the things that we are doing is trying to clarify who might be the best candidates for this procedure. So we perform gastroduodenal manometry with 13 sensors across the anteroduodenal junction, which you can see here, and you can see more sensors in the small intestine. And I'll take you through this very quickly. We're trying to differentiate who has anterohypermotility causing the gastroparesis and who has pylorospasm. So here's a patient in whom, in an approximately 25-minute period, has only about 10 contractions. We should expect up to 3 contractions per minute in the postprandial period. So this patient has anterohypermotility and very minimal pyloric contractility, which is well coordinated with distal anterocontractions. On the other hand, here's another patient in whom there's very prominent pyloric tonic and phasic pressure activity. We recognize the pylorus by the antral and duodenal events. And here you can see a pretty consistent pyloric signature, if you wish. And we wonder whether this might be a better candidate for GPOEM procedure. Sleeve gastrectomy is being performed for gastroparesis, particularly for patients following prior partial surgeries performed on the stomach. And there are at least 2 papers, which I'm citing here, which show an improvement in gastroparesis cardinal symptom index, quite a dramatic improvement from 33 to 15 on average post procedure, and rarely complications that might be unrelated to the gastrectomy itself. And here's the last slide of data that I'm showing, illustrating that in patients with delayed gastric emptying, these are patients who have particularly problems with emptying of the fundus from the stomach. So it would be perhaps helpful to have more detailed analysis of the gastric emptying profiles. These studies used a barium sandwich emptying radiography to illustrate the retention in the proximal stomach. This was particularly applied, as I said before, in the post-surgical or idiopathic patients, but there appears to be some benefit in those patients who underwent the sleeve gastrectomy following problems of gastric emptying. So in conclusion, there are several medical and procedural approaches to relieve symptoms in patients with gastroparesis. These are, of course, medications not yet approved by the FDA, other than aprepitant, which is approved for the treatment of radiation or postoperative nausea and vomiting. We do need sham-controlled studies to further validate the utility of GPOM. And it is our perception that we need to study further predictors of GPOM efficacy, particularly the measurement of pyloric cross-sectional area or diameter and distensibility index. And we also believe that antral hypermotility would be an important cofactor, which may not be completely resolved by the pyloromyotomy, and which would indicate the need for additional prokinetic medications rather than pursuing a direct approach to GPOM procedure on its own. So it is possible that patients with antral hypermotility may benefit from GPOM, but they may also continue to require prokinetic agents to facilitate gastric emptying. Thank you again for the opportunity to be with you today and for giving you our thoughts on novel treatments for gastroparesis.
Hi, my name is Ronnie Foss. I'm a professor of medicine at Case Western Reserve University. I'm also the medical director of the Digestive Health Center and chair of the Division of Gastroenterology and Hepatology at Metro Health Medical Center in Cleveland, Ohio. And I will cover the topic today, pharmacologic and surgical treatment for esophageal disorders. So first of all, let's look a little bit at the esophagus. What is the esophagus? So the esophagus is the organ, is a tube that connects the throat to the stomach. The length of it is about 7.8 inches. And at the top of it, there is a sphincter called upper esophageal sphincter. This type of sphincter is a barrier that helps, for example, to prevent from air flowing from our throat into our GI tract system through the esophagus. At the bottom of the esophagus, there is another sphincter called the lower esophageal sphincter. And that sphincter is also a barrier. It's the barrier between the esophagus and the stomach. And it helps, for example, to prevent from stomach content from flowing back into the esophagus. Now you have to remember, the esophagus is a very active organ. That means that the esophagus, whenever we swallow anything, it contracts and moves the content that we swallow from the upper part of the esophagus down to the stomach. That's why I can hang from a tree with my head down and have a 3-course meal without any problem. So let's look a little bit at some of the common disorders of the esophagus and see what kind of pharmacologic and surgical therapy we have. Let's start with the most common one. This is gastroesophageal reflux disease. Many of you are familiar with this disorder. It commonly presents with heartburn and sometimes with a feeling of sour or bitter taste at the back of your throat. Commonly, we use antacids. Antacids are available over the counter. We can buy them in any pharmacy that sells over-the-counter medications. They were actually the standard of treatment for gastroesophageal reflux disease during the 70s, until new medications were introduced, the H2 blockers and later the proton pump inhibitors. It's very effective in controlling mild symptoms of gastroesophageal reflux disease. And people tend to take it after meals when they have symptoms or in order to prevent symptoms or at bedtimes. Now, they're very good for an immediate effect. That's why when we develop heartburn as a result of a spicy meal, for example, or a greasy meal, then we commonly use one of these antacids in order to control that specific heartburn. But they're not good for prevention. If you take them in order to prevent heartburn, they're unlikely to work as well as the other medications I'm going to talk about. And they're not good for healing inflammation in the esophagus, that is the result of gastroesophageal reflux disease, or prevent complications for gastroesophageal reflux disease. The next type of medications are called histamine 2 receptor antagonists, or H2RAs. Now, the H2RAs, or the histamine 2 receptor antagonists, they block the action of a substance called histamine on cells in the stomach, cells that make acid, called Poyel cells. So they reduce acid production. We use them as first-line agents for patients with mild to moderate symptoms and inflammation in their esophagus. They're very good for fast effect. So if you develop already a heartburn, they're very good in controlling that specific heartburn. It can also heal mild to moderate inflammation in the esophagus. And unlike antacids, they've been shown to prevent symptoms. They're also available over the counter. Proton pump inhibitors are probably the most commonly used prescribed medications for gastroesophageal reflux disease. They reduce the production of acid by specifically blocking the site on the wall of the stomach that produces acid. So they specifically go after the pump that makes acid in our stomach. Now, there have been concerns about side effects when these medications are used long-term. But studies have shown that they are overall safe, and the risks of all these side effects that have been reported appear to be relatively small. But at the end of the day, they should be used for the right indication and in the lowest dose that control their symptoms. We have about 7 proton pump inhibitors in the market, and you can see some of them are mentioned on this slide. They consider to be the best medications for symptom control and for healing esophageal inflammation. Doesn't matter what the severity of that inflammation. They're also very good in preventing symptoms, preventing inflammation, and preventing complications from gastroesophageal reflux disease. In fact, they've changed completely the landscape of complications that we used to see as a result of long-term gastroesophageal reflux disease. Now, what about surgery for gastroesophageal reflux disease? These type of surgeries are called fundoplication. And we have some of them that are full fundoplication and others what are called partial fundoplications. Now, what is fundoplication? As you can see on the left side, they take the upper part of the stomach and they wrap it around the lower part of the esophagus. That's called fundoplication. And obviously, how tight it's going to be determine if it's a full or partial fundoplication. The purpose of the fundoplication is truly to bolster the lower esophageal sphincter effect or the effect of the barrier between the esophagus and the stomach. Here is another surgery that is relatively new. It's called LINX, or reflux management system. And the LINX is in fact a ring that is composed or is made from magnetic titanium beads. And the surgeons, what they do, they place that ring around the lower part of the esophagus at the location of the lower esophageal sphincter, the barrier between the esophagus and the stomach. Now that ring stays there for the duration. And what it does is that whenever the patients have reflux, the beads that are magnetically attracted to each other, they touch to each other, prevents from reflux from occurring. But they do spread whenever we swallow food, allowing food to get into the stomach. Now, we talked about pharmacologic and we talked about surgical treatment for gastroesophageal reflux disease, but we have also to remember that there are also several what we call endoscopic techniques to treat gastroesophageal reflux disease. So like you do an endoscopy, the regular endoscopy where the gastroenterologist will go through your mouth into your esophagus, stomach, and look inside. Well, you can use that endoscopy to perform certain procedures from inside the esophagus and the stomach that will give you something as close as possible to the fundoplication that I just mentioned that you get during surgery. Obviously, the advantage here that we don't make any cuts. You basically go through the endoscope and you perform this type of procedure. One of them, as you can see here, is called the transoral incisionless fundoplication, or the ESOFIX. There's another one that is called Medigas, which is similar, but has different type of equipment. And then we have this type of technique, which is also an endoscopic technique called the strata techniques. And you can see that there is a basket there that is placed, again, at the lower esophageal sphincter level, the barrier between the esophagus and the stomach. And a balloon is inflated, and that balloon pushes electrodes into the wall of the esophagus, and then radio frequency energy is delivered, creating reorganization of the muscle in this area and tightening of the barrier. It's called the strata technique. Here is another esophageal disorder called the eosinophilic esophagitis. Eosinophilic esophagitis is more common in young adults, more in males than females. And it's an immune response to a food trigger, commonly milk and wheat. As a result of this immune response to a food trigger, certain blood cells called eosinophils are moving from the blood vessels into the wall of the esophagus and creating local inflammation. That inflammation may lead eventually to changes in the esophageal structure, resulting in swallowing problems. So the treatment for this patient would be elimination diets, where you're trying to remove the certain type of food that the patient is allergic to. The most common ones by far are milk and wheat. Another way to treat these patients is to use acid suppression medication, like the proton pump inhibitors or the PPIs that I mentioned for gastroesophageal refluxes. They can improve symptoms in about half of the patients. You can use steroids, topical steroids. The common ones are fluticasone and budesonide. And then in patients that develop eventually narrowing as a result of this inflammation, then they may need dilation of the esophagus, stretching of the esophagus in order to improve their swallowing abnormalities. Now we'll talk about disorders of esophageal function or disorders of esophageal motility. And these disorders actually affect the esophagus itself, the esophageal body, or the barrier between the esophagus and the stomach. As I mentioned, the esophagus is an active organ. It's not a passive organ. And so whenever we swallow anything, it creates contractions in the esophagus that help to push whatever we swallowed, food, liquids, into the stomach. And so I'm going to talk about 3 types of disorders of esophageal function. One of them is esophageal hypermotility disorders. These are disorders where the function of the esophageal body is weak or absent, or the barrier, the function of the barrier between the esophagus and the stomach is weak or absent. Treatment for this. So first of all, these patients are more exposed to reflux. So anti-reflux treatment, PPIs or surgery, should be considered. Lifestyle changes in patients that now don't have strong contractions of their esophagus. So decrease food consistency, sufficient chewing, and trying to eat in the upright position. Don't eat while lying flat in bed. Or some people tend to eat while they're watching TV lying in bed. There are some medications that are supposed to help in improving the function of the esophagus, like buspirone, bethanechol, and pyridostigmine. Your physician will talk to you about them if they consider them. They may help to improve the function of the esophagus. And another type of medication is called prokinetics. These medications help to move the GI tract, like metoclopramide, cisapride, tegasertib, and others. And again, you should discuss them with your physician. There are others, disorders of esophageal function, like esophageal hypermotility disorders. So patients that have esophageal spasm or strong contractions of the esophageal body, really the opposite of the other disorders. Also, anti-reflux treatment should be considered in these patients because sometimes it's reflux that generate those spasms or strong contractions. So PPIs or surgery should be considered. Lifestyle changes, trying kind of to relax the esophagus, the muscle of the esophagus, using warm water with meals, not hot, warm water like tea or just regular water, which you warm. Avoid ice, cold, and carbonated beverages, which may trigger spasms. Use medications that are considered to be muscle relaxants, like peppermint oil solution, calcium channel blockers, nitrates, and even sildenafil, which is a Viagra. In some of the patients, we may need to do Botox injections. Yes, we do Botox injections in the esophagus. In this case, we will do that in the lower part of the esophagus. And sometimes this patient may need surgery that helps to loosen the muscle. And so there's not going to be spasms or strong contractions, which cause patients pain or swallowing abnormalities. Another important disorder of esophageal function is achalasia. And achalasia is a very interesting disorder. We don't know what causes it in most of the patients. And it's lack of normal contraction of the esophagus, and the sphincter, the barrier between the esophagus and the stomach, does not relax when food reaches there. So it's always tight. And so it's also lack of relaxation of the lower esophageal sphincter due to damage to the nerves that innervate the esophagus. So how do we treat these patients? Usually we're looking at more definitive treatment, but in some patients that we cannot give them definitive treatment, maybe because they have many other medical problems, then we can use muscle relaxants. I mentioned them already before, like calcium channel blockers, nitrates, sildenafil. And in this situation, also some that called anticholinergics or antispasmodics, like one of them that is mentioned here, like dicyclamine. We can do Botox injection in these patients, again, in those that are not candidate for a more aggressive or definitive treatment, patients that have a lot of underlying severe medical problems. The three definitive interventions are the ones that are mentioned here, like pneumatic dilation, which I'll show you a picture of that, POEM, peroral endoscopic myotomy, that I will show you a picture of that, or surgery. The surgery is called helemyotomy with door fundoplication. And what they do is they make a cut through the muscle, the lower part of the esophagus muscle, and then through the sphincter, the lower esophageal sphincter, into the upper part of the stomach. That helps to eliminate the barrier effect between the esophagus and the stomach. So then food can easily move from the esophagus into the stomach in these patients. And the fundoplication is, as I mentioned, is to try and wrap the stomach, although just part of it, around the lower part of the esophagus. This is the pneumatic dilation that I mentioned. And what they do here is they put a balloon. You can see here the balloon that is placed in the area where there is the barrier, the lower esophageal sphincter, the barrier between the esophagus and the stomach. They inflate the balloon and they try to weaken the barrier, the lower esophageal sphincter, so it's not going to be tight and will allow food to move from the esophagus into the stomach. Here is the POEM, which is peroral endoscopic myotomy. It's done through the endoscope, and they go with the endoscope and they make a cut of the innermost muscle of the esophagus in the lower part of the esophagus through the barrier, the lower esophageal sphincter, into the upper part of the stomach. And again, they're trying to loosen the sphincter and allow for esophageal content to move into the stomach. And I'd like to finish with disorders of gut-brain interaction, what we call functional disorders, GI disorders. They're relatively common, and these are disorders that can present with a variety of symptoms, but we don't have the classic disorder behind that symptoms. For example, patients can present with heartburn, but they don't have gastroesophageal reflux disease as the cause of it, but they have another disorder called functional heartburn or reflux hypersensitivity. Or patient can present with chest pain, or patient may present with swallowing abnormalities. In these disorders, the abnormality is primarily because patients have high sensitivity at the level of the esophagus. So something in the past led to now increased sensitivity of the esophagus to whatever is going on inside the esophagus. And so patients develop a variety of symptoms as a result. Treatment of these we are trying to reduce this high sensitivity. The main type of medications are called neuromodulators. These are medications that can reduce pain. They reduce the sensitivity of the esophagus. And most of them are actually antidepressants, like tricyclic antidepressants or selective serotonin reuptake inhibitors, SSRIs or SNRIs. And you can see a variety of them, but we don't use them here for the antidepressive effect. We're actually using them here in order to reduce the sensitivity of the esophagus. Also, a lot of these patients may require some type of psychological intervention because many of these patients appear to have depression or anxiety, hypervigilance. One of these abnormalities is also making the symptoms worse. And so they may need intervention like cognitive behavioral therapy, hypnotherapy, mindfulness, and others. So I'd like to thank you for giving me the opportunity to talk to you about pharmacological and surgical treatment for esophageal disorders. Thank you very much.
Thank you. I hope you enjoyed that first session on this Sunday morning on treatment options for the stomach and esophageal regions. My name is Ceciel Rooker. I'm the president and executive director for the International Foundation for Gastrointestinal Disorders. And we are at the beginning of our very first part of the second day of the Norton Educational Series 30th Anniversary Edition. With me are Doctors Bill Chey and Lin Chang, who are helping to moderate these sessions. So with this, there was a lot of information, lots and lots of information that was just given to us by Dr. Michael Camilleri and Dr. Ronnie Fast, both great friends and just wonderful physicians, experts in the field. So we have a few questions that have stemmed from all of this. And of course, I'm sure some of you may be still processing. Please keep those questions coming in the chat feature, and we'll try to address them as we go along throughout the day. So one of the major questions that we received is with gastroparesis. Michael Camilleri talked about all these great studies that are ongoing right now, but are there any medications now? I know that there's a lot that's in the whole FDA process, all that clinical trials that we talked about earlier today. But where do we stand now? If someone is diagnosed with gastroparesis, what can you do for them now?
Well, so, you can start with dietary recommendations that are probably fairly similar to reflux, disease too. But the medication, the only FDA-approved medication in the United States is metoclopramide, which helps to reduce nausea and helps the stomach empty faster. It does have a boxed warning, though, of getting something called tardive dyskinesia, where you can get these involuntary movements that you can't control, and they're not always reversible. So you really need to be careful and limit the duration, the dose of the medication. Also, outside the United States, we have domperidone that works similarly to metoclopramide, but it doesn't cross the blood-brain barrier to this. It doesn't necessarily have these central effects of this tardive dyskinesia, but you also still have to monitor your heart rhythm. So people usually get an EKG to make sure the heart rhythm is okay. You can use some medications off-label just to treat the symptoms. If there's nausea, you can use medications to reduce nausea. There's another medication that you've probably heard about, which is prucalopride. And this is a serotonin agent that will help the stomach empty and reduce symptoms of gastroparesis. It's been shown to be efficacious in a small study. And it's off-label. It's not an FDA-approved indication, but it can reduce symptoms of gastroparesis. So often in clinical practice, particularly if patients have constipation, because many patients with gastroparesis also have constipation, and the medication can help kill two birds with one stone, which is nice.
Yeah, absolutely.
Yeah, I think the diet stuff is really important for patients to think about and try to adhere to. So smaller, more frequent meals, low-fat foods, low residue. So not a lot of difficult to digest or process raw vegetables, for example. But those kinds of measures for patients that have mild symptoms can be very, very helpful.
Right. And again, the IFFGD does have our dietitian listing. So we can help you to find a dietitian who has been specially trained and has an interest in working with us, the GI illness community. And I know, Bill, you have a great staff of dietitians at University of Michigan, and you also at UCLA. So a lot of the major medical centers do offer this. So it's something to speak to your healthcare professional about and just say, I'd like to work with a registered dietitian. If they cannot help you to find one, please contact us here at IFFGD, because that is very helpful for people with gastroparesis. Okay, so moving on to GERD. So there was a question about surgical options. So Dr. Fast mentioned some of these surgical options, and that surgery always seems to be sort of extreme in the eyes of a patient. So when would you begin to consider referring to your patient to have one of these surgeries done?
Yeah, so the first thing to say about surgical options for gastroesophageal reflux disease is that the outcomes are highly dependent upon the experience of the surgeon. So you want to make sure that you have your surgery done at a center that does a lot of these anti-reflux surgical procedures. And patients shouldn't be embarrassed about asking, the level of experience and the number of procedures that a surgeon does, because that is critically important to how good or how not as good the outcomes are following surgery. The second thing is, in general, we talk about doing surgery for patients that have persistent evidence of persistent reflux despite the medication, and so by the way, that means, as was discussed in the video, doing detailed testing to make sure that there's evidence of ongoing acid or even non-acid reflux, but also for patients that don't want to take long-term PPI therapy. There are patients that just make the decision for whatever reason that they don't want to commit to long-term medical therapy with the PPI. If they have documented evidence of acid reflux, they would also be a very reasonable candidate for at least a consultation with a surgeon to discuss what the options might look like.
Fantastic. And so just to ask a question that was asked about endoscopy. So endoscopy, what would you expect? So endoscopy is very common, the upper endoscopy with people who come in with esophageal issues. And I know that it's ordered quite often because it gives us a wealth of information, right? But what can a patient expect? If they're told that they have to have an endoscopy, is this something that should be scary to them? And what would they expect in the procedure?
There's two different ways of it's done with sedation, unless someone chooses not to have it, but most people would choose to do that. There's a term called conscious sedation, where they are sedated, but they're not completely asleep. But now it's becoming much more increasingly common to have an anesthesiologist there and to have general anesthesia. It's a short procedure. It's like, few minutes, 5 minutes, 10 minutes, depends on what they're looking for, if they're taking biopsies or pieces of tissue, to sample. But it's a very short procedure that can be quickly done, and all gastroenterologists know how to do that.
And is there any special prep that is done if you're like, I know with the colonoscopy, you have a lot of prep that goes in. With endoscopy upper, do you have to do any prep at all?
Yeah, just nothing by mouth after midnight. You really want to make sure that you fast for the specified time that you've been instructed to. Like, one thing that leads to unnecessary canceling of procedures is if on the morning of the procedure, the patient drinks or eats. That is 100% going to lead to cancellation of your procedure. So make sure you review the instructions that have been given to you and you fast for the period of time prescribed in the instructions. Usually it's going to be NPO, nothing by mouth, after midnight.
Okay.
I mean, that's actually really important for patients with gastroparesis, where the food doesn't empty out of the stomach as fast. That would be, highly important.
Okay, very important. So we're going to go ahead and move on to our next session, which is more treatment options. And we're going to be moving further down the GI track and talking about the small and large intestine, and also working into the pelvic floor. So,
Well, great. And so in this next session, we're really excited to hear from a number of world experts. The first talk is going to be on pharmacological and surgical treatments for small and disorders of the small and large intestine. And it's going to be given by a good friend of ours, Dr. Brian Lacey, who's a senior consultant and professor at the Mayo Clinic in Jacksonville. Brian is also the recently retired co-editor-in-chief of the American Journal of Gastroenterology and on the board of trustees of the college, as well as being so involved with IFFGD. The second talk is going to be on current novel treatment options for pelvic floor disorders. And that's going to be given by Satish Rao. And Satish is the head of the Pelvic Floor Center at the Medical College of Georgia in Augusta, Georgia, and really an international expert on disorders of the pelvic floor. And then finally, we're going to hear about behavioral treatments for gastrointestinal disorders by Dr. Lori Kiefer, who's at Mount Sinai University and really widely regarded as the grand dame of behavioral therapies in the United States. Many would argue in the world, actually. So we're looking forward to hearing those talks.
Absolutely. We hope you enjoy these, and we'll be back with you on the break to discuss.
Welcome. My name is Brian Lacey. I'm professor of medicine at the Mayo Clinic in Jacksonville, Florida. I'm delighted to be a part of the IFFGD 30th anniversary lecture series. And over the next 15 minutes, I'm going to discuss pharmacologic and surgical treatment for the small and large intestine. Recognizing that there have been a variety of other really great lectures, I will not really be focusing on the diagnosis of these disorders, nor will I cover dietary interventions. So my objectives today: to review the most common functional motility disorders of the small and large intestine. I'm going to discuss current pharmacologic treatment options and discuss the limited surgical options available. The topics we'll cover today specifically will be irritable bowel syndrome, or IBS, small intestinal bacterial overgrowth. Some patients refer to this as SIBO, other disorders of the small intestine, chronic bloating and distension, chronic idiopathic constipation, and colonic inertia. Let's begin with IBS, or irritable bowel syndrome, because that's really the best studied and probably the best understood disorder of gut-brain interaction, also called functional bowel disorders. And when I think about the treatment for IBS, treatment really depends upon disease severity. So as a patient, some patients have kind of mild symptoms, meaning that the symptoms are present, whether it's pain or diarrhea or constipation or alternating constipation diarrhea. And of course, bloating is so common as well. But if those symptoms are not burdensome, are not affecting your home life, social life, professional life, that for many patients, simple interventions, including a great explanation about what IBS is, reassurance that this never turns into anything bad or dangerous, using over-the-counter medications, and maybe some lifestyle interventions such as changes in diet, better sleep, and physical exercise, well, all that's required. However, patients with moderate or more severe symptoms generally require pharmacologic treatment, meaning prescription medications, and may also require other treatments involving coexisting anxiety or depression, which frequently goes hand in hand with any disorder that's chronic in nature. When I think about medical treatments for IBS with constipation, when the constipation symptom is predominant, there are a number of options available. I won't cover probiotics or complementary and alternative medication, abbreviated as CAM, or osmotic agents, because they've been covered elsewhere. I'm going to focus on the 5 medications approved by the Food and Drug Administration for the treatment of IBS with constipation. The first group are those that we call secretagogues, and they're called secretagogues because generally these 3 medications, when they work in the GI tract, cause the GI tract to secrete fluid into the GI tract, which increases transit through the GI tract. The first agent is lubiprostone, also sold as Amitiza. This accelerates small bowel and colon transit. It's approved for the treatment of both men and women with chronic idiopathic constipation and women with IBS and constipation. Speak to your doctor about this medication. It's safe and it's effective. It comes in 2 different doses, 8 micrograms and 24 micrograms. Linaclotide is a medicine called a GCC agonist. It acts on the guanylate cyclase C receptor. It too improves movement through the GI tract. It also has been shown to act on the sensory nerves in the GI tract to improve abdominal pain. It's approved again for both IBS-C and for chronic idiopathic constipation, and it comes in 3 different doses, 72, 145, and 290 micrograms. The new kid on the block is plecanatide, sold as Trulance. It comes in one form only, 3 milligrams, and it too is approved for both chronic idiopathic constipation and IBS with constipation. The other two agents both begin with T. One is tenapanor, the other is tegaserod. Tenapanor acts quite differently. It acts on a different receptor involving the sodium hydrogen exchanger. There's very good data from a large randomized controlled trial showing benefits compared to placebo. It was approved by the FDA in September 2019. Distribution has still been a little bit tricky, so it's a little hard to get, but it is available and it's very effective for IBS-C symptoms. And then tegaserod acts on the serotonin receptor system. In this case, it acts on the 5-HT4 or the type 4 serotonin receptor, and it stimulates that receptor to improve motility in the GI tract and improve visceral or gut pain. There's a bit of a storied history where it came out and then was withdrawn voluntarily due to some safety concerns, but it was reapproved for the treatment of IBS-C in women less than 65 years of age without a cardiovascular history. And this is very safe in that population. It's sold in a 6 milligram form. Let's shift gears now and talk about medical treatments for IBS with diarrhea. And I'd like to show this slide because it shows there are so many different treatment options. Once again, in the interest of time, because the topics are covered elsewhere, I won't talk about diet or probiotics or some of the simpler agents. I just want to mention that the 5-HT3 antagonist, allosetron, that acts on the type 3 serotonin receptor. Very good data from large randomized studies showing it improves urgent diarrhea, it improves urgency, it improves pain and bloating in patients with IBS and diarrhea. It's approved by the Food and Drug Administration for women with symptoms that persist despite using either dietary interventions or Imodium, loperamide. The gut-selective antibiotic rifaximin has been shown in 3 very large randomized placebo-controlled trials to improve IBS with diarrhea symptoms, including gas, bloating, urgency, diarrhea. Finally, eluxadiline is sold, and this improves IBS diarrhea symptoms. It acts on the opioid receptors in the GI tract to slow the GI tract a little bit, but not causing horrible constipation, and it improves symptoms of urgency and diarrhea as well. In terms of eluxadiline, if you've had your gallbladder removed or you have had a history of pancreatitis, you should not take that medication, but I am sure your healthcare provider will know that. Let's talk about small intestinal bacterial overgrowth, a common question that comes up from patients when they have symptoms of gas and bloating. And the treatment for that involves first thinking about the underlying disorder. We look at the medication list because some medications slow small bowel transit. By eliminating those medications, we can increase transit, get rid of the underlying problem, and thus improve symptoms of bacterial overgrowth. And then sometimes, in some patients, we accelerate small bowel transit to improve symptoms. Or we can target the bacterial overgrowth directly and use antibiotics. I'm going to come back to that in a second. In the occasional patient, long-standing bacterial overgrowth leads to nutritional issues, and your healthcare provider will want to investigate that and treat appropriately by replacing fat-soluble vitamins and also B12 and calcium and magnesium. Which antibiotic might you want to use for small intestinal bacterial overgrowth? This slide shows treatment options available. I wish I could tell you that one was significantly better than the other, but there have been no head-to-head comparisons. And thus, it's really important that you have a nice discussion with your healthcare provider about the risks, the benefits, and the cost of each of these agents. What about small intestinal dysmotility and chronic intestinal pseudoobstruction? If you've listened to some of these other lectures, you're now comfortable with those topics. The most common cause of small bowel dysmotility or slow transit is the connective tissue disorder scleroderma. Other connective tissue disorders can cause symptoms including SLE or lupus or dermatomyositis or polymyositis, but those myopathic disorders are much less common. Treatment options, we could think about a prokinetic agent, and a prokinetic agent is a medication designed to increase transit through the GI tract. Generally, we think about the 5-HT4 agonist, coming back again to the medications that act on the serotonin system. 5-HT4 stands for serotonin, and this acts on a type 4 receptor, so we use prucalopride. This is sold as a prescription as Motegrity, or as I mentioned, we can use Tegaserod, that's sold as Zelnorm. Both of these agents are safe and effective. Some patients require injections, and that's octreotide, and that's the one medicine that's been tested to really show that it helps small bowel transit. Can be very effective, although many patients don't like to take shots. As I already mentioned before, sometimes we use these agents called secretagogues, such as linaclotide or plecanatide, sold as Linzess or Trulance, to accelerate small bowel transit. And occasionally we use medications that block acetylcholinesterase. That's the enzyme that breaks down acetylcholine. And we may use pyridostigmine or rarely neostigmine, because by blocking that enzyme, it accelerates small bowel and colon transit. What about the problem with bloating and distension? This is so common and is found in patients with IBS and chronic constipation and bacterial overgrowth and even functional dyspepsia and gastroparesis. When I see a patient and I start thinking about the pathophysiology of bloating and distension, I like to think about three major processes: things that stretch the bowel wall, causing tension and discomfort. I think about being too sensitive in the GI tract, this augmented conscious perception of wall tension. And I think about an abnormal viscerosomatic reflex. That's an abnormal gut muscle wall reflex. Let me go through those briefly. When I think about patients who have increased bowel wall tension, what treatment options do we have available? The first is dietary modifications. I'm sure you've heard this before from other lectures. I won't go through that, but it's nice to see this on the slide for your own knowledge. We can modulate the microbiome. So as we've discussed for SIBO in the past, we may use antibiotics. Some providers use probiotics. I generally don't do that because the data is not very strong, and many times probiotics makes bloating worse. Or as we've already mentioned, we can accelerate gastrointestinal transit using a prokinetic agent or a secretagogue. If I believe the underlying physiology and pathophysiology leading to gas and bloating is a visceral perception, remember that many patients with disorders of gut-brain interaction are overly sensitive in the GI tract. We have a host of options. We may use a very low dose neuromodulator, such as a tricyclic antidepressant. Don't think we're treating underlying depression. What we're using is to block these pain receptors, and very low doses can be effective. We may use other antidepressants. There are two big categories. One are called SNRIs. Duloxetine is an example, or we may use SSRIs, and those can be helpful if you have some anxiety as well. Other agents are available, such as gabapentin and pregabalin. Of note, opioids should not be used in any of these disorders because opioids or narcotics will slow the GI tract, make symptoms worse, and it's very easy to become addicted. Finally, that big category of this abnormal viscerosomatic reflux, viscero means your gut. Normally, when gas stretches the small intestine or colon, normally, if we look at the upper right-hand corner of the slide, your abdominal wall muscles contract to keep your belly flat, and your diaphragm, your breathing muscle, ascends to increase the size of your abdominal cavity. But some patients actually have a wiring problem. They have an electrical problem in their GI tract where this reflex is reversed. And what happens, as shown in the right lower corner of the slide, is the diaphragm abnormally descends. That makes your belly cavity smaller and your abdominal wall muscles inappropriately relax, and that's why you get such marked distension. How is that treated? We actually teach patients diaphragmatic breathing, and this slide illustrates how you can do this. Sometimes we use biofeedback. By the way, there are some great YouTube videos on diaphragmatic breathing, and you may want to look at those. What about chronic idiopathic constipation? Chronic means that symptoms started at least 6 months ago and they've been active in the last 3 months. Treatment options, I briefly mentioned osmotic agents, and I know you've heard other lectures about something like polyethylene glycol sold over the counter as Miralax or Glycolax. We've discussed the secretagogues. They increase fluid secretion into the GI tract and thus increase intestinal transit, lubiprostone, linaclotide, plecanatide. And we've discussed these prokinetic agents, these 5-HT4 agonists such as prucalopride and tegaserod. All are very effective and can be very helpful. Lastly, what about that uncommon patient with colonic inertia? These are generally women. Men can occasionally have it, but much less common. And these are patients who may have a bowel movement every 4 weeks or 6 weeks. If you fail medical therapy, and that's the key phrase, if you fail all of these therapies for weeks at a time, and if you do not have a pelvic floor disorder, pelvic floor dyssynergia or a large rectocele or something else, that should be carefully investigated. Then some patients respond to sacral nerve stimulation as shown here. That's done only at specialized centers. The data is okay, in my opinion, not perfect, but okay. And rarely, when symptoms are so severe and patients have failed every single agent we have available and they do not have a pelvic floor problem, then we may recommend removal of the colon. But remember, that's really the last thing that should be done. And once the colon is removed, it's irreversible. And of course, for most patients then, when that's done, they have frequent bowel movements, sometimes 6 to 8 per day. So there is a trade-off. As we wrap up here, as an audience, I think we all recognize that these motility or functional disorders, now called disorders of gut-brain interaction, are common. They affect about 40% of the population overall. Fortunately, in this day and age, multiple treatment options are now available. And when you see your healthcare provider, discuss these individualized options, because really it depends on who you are, what your symptoms are, what tests you've had to date, and what treatments you've had. One size does not fit all, but fortunately, again, we have so many different options that there's a treatment out there available for you. Thank you so much for listening today, and thank you for participating in this great IFFGD lecture series.
Hello, I'm Dr. Satish Rao from Augusta University. Thank you so much for inviting me to be here with you. It is an honor to speak in Nancy Norton's celebration symposium. Nancy is a very good friend and has been a tireless worker for patients with bowel disorders and functional bowel disorders and fecal incontinence. So it is indeed an honor to join all my colleagues to honor this distinguished colleague. The title of my presentation is Current and Novel Treatment Options for Pelvic Floor Disorders. These are some of my disclosures. The objectives for my talk are to discuss with you what is the pelvic floor, what are the common pelvic floor disorders, and discuss advances in the evaluation, diagnostic workup, and treatment of 2 common pelvic floor problems: constipation with dyssynergic defecation and fecal incontinence. Now, this is the pelvic floor. All right, what do we mean by the pelvic floor? Well, this bone or the hip bone is called the pelvis, and the structures that are housed inside the bone is what we call as pelvic floor structures. And problems that arise from these pelvic floor structures lead to pelvic floor disorders. Now, if you stand up a person and look at the individual sideways and you really do a section, this is how the anatomy looks. Here is the front, here is the back. This is the little bit of the backbone or the sacrum bone. And if you go from front to back, this is the pubic bone. The first organ in the front is the urinary bladder. The next organ in a lady, you have a uterus and the vagina and the vaginal opening. The third organ is really the rectum and the anus opening, and behind it are the bony structures. These are the principal components of the pelvic floor. What is its function? Well, the pelvic floor is an important organ in itself and performs a number of functions. First of all, with regards to bladder and bowel control, it facilitates passage of urine and stool. It is an important organ for sexual function, an important organ for breathing because it's part of the diaphragmatic breathing process, and a very important organ for pregnancy and childbirth. Therefore, multiple key functions are performed by the pelvic floor. Now, what are the very common pelvic floor disorders? We have a number of disorders that are part and parcel of the pelvic floor. For example, a person with stool leakage, otherwise called fecal incontinence, a person with difficulty with evacuation or bowel movement, also called dyssynergic or incoordinate defecation, patients with anal pain caused by a fissure, patients with a condition called solitary rectal ulcer syndrome, where they have an ulcer in the rectum and they bleed and excessively strain. There is pelvic pain, there is rectal prolapse, there is rectocele, which is like a small protrusion in the front of the rectal wall. There is excessive movement of the perineal muscles on the wall so that there is weakness and descent. There is anorectal pain, also called levate ani syndrome or proctalgia fugax, and there are hemorrhoids. Some of these, some of you may already know, some of these, some of you may not know, but this is just a list of the very common pelvic floor disorders. But for time purposes here, we will only focus on the two important aspects, which are the more common and more difficult to manage and treat problems, which is constipation with dyssynergic defecation and stool leakage. So let's talk about constipation. A very common problem, affects up to a quarter of elderly population, but about 15% of the younger population. More prevalent in women than men. It leads to about 2.5 million physician visits per year, more than $1.4 billion of over-the-counter laxatives are consumed annually in the United States itself, not globally. Now let's talk something very important here. We as physicians, unfortunately, speak a language which is alien to our patients. And it is very important that physicians and patients connect with the right language so that we can understand our patients. Now, this is something that I've been teaching for the last 25 years and will continue to do so. But if you are a patient listening to this, please be patient and try and help to make your physician understand and make sure they truly understand your problem. Because many times people use certain terms that are misunderstood. Here, patients were asked a simple question, what is constipation? And you can see 27% of patients thought it was having a bowel movement every 2 days or less frequently. None of the physicians believed that was the case. Having a bowel movement 3 days or less often, 25% of patients felt this was so. About a quarter of the physicians believed. But look at this. Having a bowel movement every 4 days or less often was reported by 13% of the patients, but almost half the physicians believed that this was their definition of constipation. Look how disconnected we are when compared to what our patients are reporting. Hard stools alone, quarter of the patients believe that's constipation. Only 6% of the physicians thought that was constipation. So there is a major disconnect between us physicians and you patients, and we need to connect better. And this really, the onus is more on the physicians, but I just want you to become aware of this. So today, how do we define constipation? We have now learned that constipation is not a one problem, one symptom, one mechanism disorder, but it is multiple symptoms. And we have 6 important symptoms that we now use. And if a patient has at least 2 of these symptoms for 3 months or more, then we say that the patient has constipation. The symptoms are, number 1, excessive straining, hard or lumpy stools, feeling of incomplete evacuation, a feeling of blockage, or use of physical digital maneuvers to disimpact or remove stool, or stool frequency of less than 3 bowel movements per week. Any 2 of these makes you constipated. Let's turn to this interesting case story. A 51-year-old school teacher came to see me with a 5-year history of constipation. Began during college days. Now bowels move once every 1 to 2 weeks. So severe constipation, hard stools, pellet-like stools only after fleet enema, suppository and laxatives. She uses digital maneuvers and describes excessive straining, a feeling of incomplete evacuation, and occasional bleeding. She tried a number of over-the-counter laxatives, including prescription laxatives such as linaclotide and Miralax or PEG. None of them gave relief. Now, this is a very classical presentation of a patient with dyssynergic defecation. So when I see patients like this, we use a number of tools to actually help. First is really take a good history, just like I've given you, then try and perform a careful, meticulous digital rectal examination. I know many of you are shy of this kind of examination, but this really informs us significantly about some of the mechanics that people may be using. And then we use various tools to confirm the abnormalities we pick up in the rectal examination. And one thing that we've also learned recently is there is a disconnect, as I just shared with you, between patients' history that they provide and the physician's ability to extract the history from the patient. One way to bridge this gap is by using prospective stool diaries, or more recently, we have developed with the help of a company some apps. Here is an app for constipation, and here's an app for fecal incontinence that patients can keep. These are just like 10 to 12 questions. It takes about 2 minutes to complete the app, and this kind of an app record will provide an accurate recording of bowel symptoms, removes any bias, and provides a very good way of understanding the patient's problem. So I would encourage all of you to use it. With regards to testing, we have a number of tools. Anorectal manometry, we put a probe in the rectum with pressure sensors, endosonography is an ultrasound test, nerve function test, and a balloon expulsion test, etc. These tests can be very useful in really providing us with accurate information. Here are some of the various screens on the app. For example, stool consistency on a Bristol scale. Did you have a bowel movement? Did you strain? Did you have to use finger stresses stooling? And you just have to answer yes or no, and you can generate a table and a report at the end of it. We also compared in a scientific study how good is the app, and also looked at its functionality. Suffice to say that the app compared very favorably with the paper, and about 58% of patients preferred the app to the paper form of diary. So when we look at patients with constipation, we broadly categorize them into 3 common groups. IBS with constipation, where pain or bloating is an important feature, along with altered bowel habit. Slow transit means the colon has become lazy, not able to move stool. Evacuation disorders, multiple disorders, but dyssynergic defecation is the key, where the act of moving stool out of the rectum has become incoordinated, leading to difficulty with evacuation. If you identify dyssynergia, a common pelvic floor disorder, what can you do? Well, the best treatment is what we call as biofeedback therapy, a technique of conditioning and retraining the mind and the body, particularly the body, to normalize bowel movement. And these are the principles of biofeedback therapy. First, we teach them diaphragmatic breathing exercises. Then we teach them posture and how to relax the pelvic floor. If patients have impaired sensation, we improve this by sensory training, eliminate sensory delay, and lastly, we provide simulated stools to facilitate expulsion of this in the laboratory. This kind of a teaching session takes approximately 1 hour, and we do this once a week or once every other week, and usually 70% of patients are successful in correcting their abnormal behavior. The patient I just described to you had classic dyssynergia, and after 5 sessions of training, now she can generate a good push, and then nicely relax in the anal canal, showing normal coordinated defecation. And that is the way I would normally manage a case with dyssynergic defecation. Let me switch gears and talk about another case. A 42-year-old lady, gravida 3, para 2, first developed fecal incontinence 2 months after her first delivery, had her second baby, and then this leakage became worse. Now, when she's come to see me, she reports 2 bowel movements a day and about 4 to 8 leakage events per week for the past 10 years. She can sense the stool coming out, sadly cannot stop it. Sometimes she's walking in a store and this happens, and this is really very embarrassing. Also has leakage of gas, no urinary incontinence, a back injury. She has some hypothyroidism. She tried taking psyllium as advised by her doctor, tried taking antidiarrheals such as loperamide. They have not afforded any relief. So what can you do for this patient like this? Now, fecal incontinence is a devastating, embarrassing problem that affects 14% of the American population. A very recent study of surveying 71,000 Americans, 1 in 7 Americans suffers with this problem. It is slightly more common in women and significantly more common in older age individuals. So why do people develop this, and what are the predisposing factors? Now, if we have urgency and diarrhea, all of us are potentially at a threat of developing stool leakage. Fortunately, we are not, but in a FI patient, this can be a problem. As we age, our muscles and nerves age and potentially predispose us to us. But one of the important factors, which was also a cause in the patient that I just described, was obstetric injury, unfortunately caused by use of forceps during the birth of baby. This somewhat traumatic delivery causes significant damage to the pelvic floor, including muscle and nerve damage. And in this case, there was damage to the muscle that was torn, leading to this. Patients who unfortunately have a spinal cord injury where the nerves have been compromised, although they may recover from the injury, the nerve damage may persist, giving rise to both urinary and stool incontinence. Older patients and sometimes young kids also, there is significant retention of stool. It's called fecal impaction. And then there is overflow leakage, which is another common reason. But what I think is the most important message here is fecal incontinence is rarely caused by one mechanism. In 80% of patients that we have studied, we've shown more than one mechanism, such as muscle being torn or nerve being damaged or rectum not able to sense or rectum is too sensitive or there is inability of the rectum to hold stools. Rectum is a reservoir for stool and can expand itself. But if that expansile ability is compromised, then unfortunately, a patient can have leakage. Clinically, we subdivide them into three types. Passive means like this lady, walking in a store cannot sense stool and it's leaking. Or you have an urge to go, but you can't make it to the restroom, urge incontinence. Or you have a normal evacuation and then you feel some wetness, and that is because small amount of stool has seeped. And these have different mechanisms, and that is what physicians will be interested in finding out and treating. Again, in terms of evaluating them, we talked about the constipation app. Here is the FI app, which also asks if you've had a leakage, how much of leakage you had, and so on. And this can be very useful in documenting the story. Manometrically, when this is a healthy manometry, you can see when the person squeezes, very nice red here. Whereas in a patient with stool leakage, there's a big gap because the muscle is torn and defective. Ultrasound, intact muscle here. And here you can see, instead of being like a round, it is a crescent because the muscle is torn in the upper part. Some new tests that we've developed are for studying nerve function non-invasively. We can now apply a magnetic coil to the lumbar region or the sacral region, and then we can use a neurophysiology recorder and a magnetic stimulation device to nicely study the neurological function. Here is an example of a healthy individual with normal conduction and a patient with fecal incontinence having very prolonged conduction of the nerve function. In terms of treatment of stool leakage, well, fiber supplementation and antidiarrheals can be helpful in about 15 to 20% of patients, along with Kegel exercises. But in the vast majority of patients, this is not successful, and they will need specific therapy. One of the most effective specific therapies is biofeedback therapy, where we teach the patient to strengthen the anal sphincter muscle, improve sensation, and improve coordination, and those with dyssynergia to correct that. Here is an example. Here's a patient. We ask the patient to squeeze. Here is the muscle pressure from 0 to 100 millimeters. You can see that the person can squeeze up to 80, but only lasts for 1 or 2 seconds. It drops a very weak squeeze. After 5 sessions, now the same person, very good squeeze up to 100 and sustain the squeeze. This is what we can achieve with biofeedback therapy. In addition to this, there are some other more surgical procedures. Dextranomere injection is an injection which is inserted just into the anal canal. It forms like a nice buffer and forms a protective coat inside the anal region. Surgeons will do sphincteroplasty. If the muscle is torn, then you can bring the muscle edges together and suture it up. And there is sacral nerve stimulation, which is like a pacemaker to the sacral nerves, which stimulates the muscles and improves stool incontinence. And in some selected cases, we may have to do a bag or a colostomy, especially in those with spinal cord injury, as this is problematic. There are some new devices, such as that has become available. We have just done a control study with this device, and we found this to be very effective. Lastly, I want to touch base on a brand new treatment called TNT, or translumbosacral neuromodulation therapy. We've identified that 70% or more patients with stool leakage have nerve damage. Therefore, in these patients, we can apply a simple magnetic coil in 4 regions in the back, as you illustrated in this patient, And this magnetic energy flows and stimulates the nerves. And the nerves have a unique property called neuroplasticity. In other words, nerves have an ability to regenerate, regrow, and reconnect. So we capitalize on this property of the nerves. Very few parts of a body can do this, but nerves can do it. And that leads to improved connectivity of the nerves, leading to improved function and improvement in stool leakage. Does it work? Yes. In our pilot study, which we reported last year, 91% of patients who received 1 Hertz therapy improved, 36 and 55% in the other treatments. So in summary, my friends, first of all, thank you for listening. Pelvic floor disorders are very common. It affects 25% of population, as I mentioned. Detailed history, physical and digital rectal examination is important. Electronic stool diary and apps provide an accurate history and severity assessment. The two most common problems, dyssynergic defecation is very common, missed by most physicians. So it is important to bring this to your doctor's attention. Manometry, balloon expulsion tests provide accurate diagnosis. Biofeedback is the preferred treatment. And hopefully in the future, home biofeedback will revolutionize this treatment approach for many of us. Fecal incontinence, a multifactorial problem. There are wonderful diagnostic tools. Ideally, if you can understand the mechanism and tailor the treatment to the mechanism, that will lead to greater success in management of the patients, including lifestyle measures, antidiarrheals, biofeedback, selected cases surgery or SNS, and novel treatments such as home biofeedback or translumbosacral neuromodulation therapy. I hope you found that very useful, and hopefully this will help you get better care, and good luck for all my patients. Thank you.
Hi, I'm Dr. Lori Kiefer, and I am a GI health psychologist and professor of medicine and psychiatry at the Icahn School of Medicine at Mount Sinai, and I'll be talking today on behavioral treatments for GI disorders. So today I'm going to answer 3 questions. 1, why do we use behavioral therapies in the management of GI conditions? 2, what are some of the brain-gut psychotherapies that may help me? And 3, how do I go about finding somebody in my community if I'm interested in it? So first, why do we use behavioral therapies in the management of GI conditions, right? These are medical disorders, they're not psychological conditions. So why would we recommend a behavior therapy? First, we know that GI conditions, especially because they are unpredictable and uncomfortable and stigmatizing, really affect patients' well-being, and many patients need support. Secondly, GI disorders are some of the most stress-sensitive disorders. Even people who do not have GI conditions experience symptoms under stress. And third, the gut-brain axis is really responsive to the brain-based interventions as much as it is to the gut-based ones. So GI disorders clearly affect more than our guts. Many patients report a wide range of emotional and physical symptoms associated with their condition, including things like pain and shame and stigma and sadness, loneliness, isolation, loss of potential, fear of symptoms, fatigue, medical trauma, sadness, worry. All of those things are part of that experience of having a chronic GI condition. Secondly, GI conditions are stress-sensitive disorders, and we know that stress affects the gut-brain axis, as well as the gut-brain microbiome axis, which can in turn affect concentration and emotions. Secondly, early life stressors that patients have can sometimes affect, even as children, the development of their gut's nervous system and how their body reacts to stress in adulthood. So some people might be predisposed to being stress sensitive in their GI tract. Furthermore, what we do when we are stressed may also make our symptoms worse. People might eat more than usual or less than usual. They might increase their alcohol intake, worsening their heartburn and reflux. They may get less sleep, less exercise, or eat things that bother them. Stress may also increase the amount of air that we swallow, causing gas and bloating during the day. It can increase muscle spasms in the intestine. And then finally, I would just say that gastrointestinal symptoms themselves are stressful and sometimes breed themselves. One thing that I often recommend to my patients, and many of my gastroenterologist colleagues do as well right in their visit, is to teach diaphragmatic breathing. More than 50% of US adults actually have chest breathing. And even though our lung capacity in our lower lungs is where most of our air can be harnessed, we often don't breathe with that belly that we could be doing better. So because our disorders of gut-brain interaction are so influenced by the sympathetic nervous system, deep breathing allows us to sort of activate the opposite, the antidote, the parasympathetic nervous system. We know that GI conditions are often particularly beneficial in diaphragmatic breathing. It increases time in that rest and digest mode. And so many patients who practice this breathing feel that their GI tracts are more efficient. We know that it can also improve gastric accommodation after meals. So if you have dyspepsia or gastroparesis, it may be helpful to breathe for a few minutes after, during or after a meal. We also know that diaphragmatic breathing can improve the pressure gradient at the lower esophageal sphincter. So if you have reflux or if you have rumination syndrome, there are definitely techniques that you can use with your diaphragmatic breathing to help that. We also know that diaphragmatic breathing decreases bowel urgency and cramping, fear of incontinence or vomiting, and even when you're sitting on the toilet and anticipating discomfort from having a bowel movement, breathing can really kind of offset that process. So I'm a big fan of breathing, and many of your GI doctors have also been trained in how to teach you to do that, so be sure to ask. Now, brain-gut psychotherapies are a little bit different than what you might see in regular therapy in the community, and I wanted to spend most of my time talking about that. So brain-gut psychotherapies are targeted behavioral interventions that have been adapted or personalized to really reflect their impact on the underlying drivers of your GI symptoms, so brain-gut dysregulation, basically. And there's growing evidence from neuroscience and brain imaging research that these therapies do indeed target the very specific, either cognitive, or emotional, or behavioral factors that are associated with the way the brain and the gut communicate in that bidirectional way, including things like an overactive nervous system, or fear conditioning, or pain catastrophizing, or hypervigilance, or overattention. So when I talk to my patients about brain-gut psychotherapy, I often describe what they're experiencing as a software problem, not a hardware problem. So the problem that causes many symptoms is that your brain is overworking. It's like having an app or a series of apps that are tracking your background location. They are constantly refreshing and they're draining your battery because they're kind of on in a setting that is inefficient. So when the brain is overworking, as in the GI conditions, it's often paying unnecessary attention to what's going on in the GI tract. And so that's one way in which brain-gut psychotherapies might be able to help. And I'll explain that in a minute. And then the second example is that, alerts from your gut to your brain are supposed to be informative. They're supposed to tell you when you're hungry, when you're full, when you need to have a bowel movement, when you're stressed. But instead, many of the times, the alerts can actually be uninformative. They can be false signals, false alarms. So that would be the example of you picking up every single spam or robocall that comes into your phone instead of just answering from known callers. So I like to think about behavior therapies as sort of decreasing the number of apps tracking your location so that your brain is not working so hard on and letting your gut sort of do the heavier lifting. And secondly, reduce your spam and unknown callers by teaching you skills so that there are less concerns about knowing the difference between a real threat and a false alarm. I'm going to talk about a couple, the two primary therapies for brain gut. One is gut-directed hypnotherapy, which, for those of you who don't know, is a medical therapy, medical hypnosis, in which you are placed into a very relaxed and focused state using physical relaxation and guided imagery. And once you're in that state, so if you think of that initial relaxation state as an IV needle going into your arm, what the really therapeutic piece is the dose that is put into that needle, right? It is the idea or the suggestions that are specific to your GI tract that are going to be the most effective ingredient of the intervention. And many of these therapies are offered over 7 to 12 sessions. There are some really straightforward protocols that can be provided by a hypnotherapist over 3 to 4 months. And there's home practice in between visits so that they can really kind of help you cope throughout the week and not just during your scheduled sessions. CBT, cognitive behavior therapy, is the other one that I highly recommend with the most data in GI conditions. It is a theoretical orientation that sort of understands that the brain and the gut become intertwined in unhelpful ways, often conditioned responses from having experienced symptoms, and patients end up developing behaviors and coping strategies that may have been helpful at the beginning of their disease, but no longer are. And so the GI CBT therapist can really help patients retrain the way that they think and respond and feel to their symptoms in a very collaborative, personalized way that can influence the way gut sensations are even experienced in the brain. So here's an example. Let's say that a patient is on their way to go on a road trip with their friends. And they have the following thoughts. I'm worried that I'm going to have to stop to use the bathroom. I'm going to inconvenience my friends. I'm going to be embarrassed if I have to ask the Uber driver to pull over. Or if there's no place to pull off and I have to go to the bathroom, I might have a bowel accident. Now, this patient is not wrong necessarily that these things could happen, but they're making some huge assumptions that might not be helpful. They're assuming that it's definitely going to happen. They're assuming it's going to be catastrophic and embarrassing, that they have no control over it and they wouldn't be able to handle it. And so CBT might pose some different questions. What is the realistic likelihood that you're going to have to emergently stop along the way? What is the realistic likelihood that your friends would be upset that you're going to have a bowel accident? And even if you did, you wouldn't be able to handle it. And then the other side of that would, if it happened, let's assume it did, what would it be as bad as I think? Would your friends like you for who you are? Would you judge another person if something terrible like that happened? How much do you really have control over your bowel movements? And finally, is it really worth getting yourself worked up about increasing the likelihood that you actually do have a problem? So lastly, just to wrap up, I wanted to talk a little bit about accessing this GI behavioral care for any of those reasons, whether you're having trouble coping and have intense feelings about your symptoms and struggles, whether you are looking for stress management strategies because stress is very sensitive your disorder, or whether you really are interested in a more comprehensive brain gut psychotherapy approach. The key to brain gut psychotherapy is that it works best when we, the therapists, are in contact with your gastroenterologist. And so it's really important that you have a doctor that you trust who can talk to you about your brain gut dysregulation and the factors that are really driving your particular symptoms, so that when you go to the therapist, to the behavioral person in your community, you're able to explain to them why you're looking for cognitive behavior therapy or gut-directed hypnotherapy or what have you, and that your GI doctor can communicate with them if they have any questions around your physical condition. And this is really, really important. The other challenge is obviously in identifying those suitable providers. And so here is a list of some places you might be able to find therapists in your community, and you can often filter by insurance and gender and those in location. But I wanted to point out that, it's not necessary to find somebody that has GI specific experience. Instead, you may want to just look for people who have language in their profiles about working with patients with chronic illness or chronic pain. Usually those providers have specific training in behavioral medicine, health psych, medical social work. Then you also can look for therapists who say that they do cognitive behavior therapy or solution-focused therapy or gut-directed hypnotherapy. And then if you find a therapist that you do like, who's like, what is IBS? What is GERD? What is gastroparesis? You can always refer that therapist to our Rome GastroPsych group for training and consultation. So just to remind everyone of the key goals today is that GI conditions really affect well-being, and behavior therapies may help with coping and social support. They may also brain gut psychotherapies are very personalized and target brain gut dysregulation and GI symptoms. And finally, I didn't get a chance to talk about this, but in the future, there are a lot of other positive psychology interventions that may also be useful in promoting well-being with a chronic GI condition. Thank you.
Hello and welcome back. Thank you for joining us today as we are in our final day of the Norton Educational Series 30th Anniversary Edition. We just listened to some great presentations and really wonderful talk about the small bowel from Dr. Lacey, and then Satish Rao with the anorectal, and then Lauren Kiefer with behavioral therapy. So we got some questions in from the audience on this session. So we're going to go ahead and talk about those. And the first one is really and truly about some of the terminology used with Dr. Lacey. And so Dr. Lacey mentioned some words that we did not define earlier this morning. So let's talk a little bit about, he used the word receptors, antagonists. Can you maybe talk to us a little bit about what that is?
It's hard to actually describe receptors in lay terms, but I guess the way I would put it is it's a part of the body, the tissue in the body that receives signals or from a stimulus. And if you act on that piece of tissue, that receptor, then it'll trigger a biological or physiological or chemical reaction for something to occur. So if there is a medication that acts on those receptors, that specialized piece of tissue, then it'll create a reaction. If a medication blocks it, they're called antagonists. So against it. So it's agonist means it acts on it and the antagonist blocks it. That means it'll inhibit, it'll block the effect that you normally would see when it gets triggered.
You know, a good way to think about this is a lock and key kind of
Mhm.
analogy. So if you think about the chemical mediator like serotonin, for example, being the key and the receptor being the lock, the key opens the lock and then leads to a downstream physiologic effect. Maybe it's triggering motility, maybe it's having an effect on sensation. But if you think about the chemical and the receptor as a lock and or as a key and a lock, that'll sort of help you to understand what's happening.
That's a really good way of putting it. So the agonist
Mhm.
would open the door,
Exactly.
but a blocker would make sure it's shut.
Exactly.
And it won't open the
Exactly.
door.
Yes.
Okay,
Yeah.
well, that is great.
Yeah.
Thank you so much. So much easier to understand that now, especially when you are talking to your healthcare provider and he's talking about these. That would definitely be helpful. So let's talk a little bit about Dr. Rao's presentation, because we had a lot of questions about the apps. So he talked a lot about some of these apps that are out there that are great for constipation and the fecal incontinence. And so but there are a lot of apps available. So how can a patient maybe go about knowing what is a good app, what is not a good app? And I know this is a long conversation. We don't have a lot of time, but just really quick and briefly, I know, Bill, you spent a lot of time working and researching in this area.
Yeah, so it's really difficult to answer the specific question you posed, the meaning like how do patients sort through this, because this is moving so quickly. Like Ceciel, even like in the time that you and I have talked about this several times over the last few months. And even in that time frame, new apps are coming online. So what I would say is it's really important for the patient to look at the app and then determine whether or not the interface is user-friendly and easy for them to be able to actually impute their information, and also whether it dovetails with the information that the physician is going to find useful, if that is indeed the end game to sort of help the interaction. So having a discussion with your provider about what apps they like to use, can be very helpful if the provider is tuned into this whole digital health space. I think patients should be prepared in this transition period for the fact that a lot of docs aren't quite used to this yet. But the one thing I'll say, and you guys both know I feel this way, is that there's absolutely no doubt in my mind that this is the way we're going. Like, I think going forward, what's going to happen is that providers or health systems will choose applications that they're comfortable with and that ideally would interface with their electronic medical record. We'll be collecting data that way. It's really gonna open a whole new world to enabling patients and providers to communicate more effectively, because right now, let's be honest, oftentimes we're not on the same page.
Right. Yeah, absolutely. So we don't have a whole lot of time for our next session, but I just want to, we had some great comments about Lori Kiefer's talk. And even like you said, she's the expert in this. But and now both of you use behavioral therapists within your university system. When do you consider sending a patient to a behavioral therapist? Just really quickly.
We both probably have comments, but it has to be someone who's open to using and utilizing it for the management of their symptoms. They're not really open to using behavioral approaches like gut-directed hypnotherapy or cognitive behavioral therapy. That's not good. I think people that have stress-sensitive symptoms, so stress can trigger their symptoms, and then also people who can have some of these negative anticipatory anxiety thoughts of their symptoms, which is completely normal. But if they need some help in managing those thought processes that can negatively impact their symptoms, then I think behavioral therapy is helpful.
Yeah, I think Lynn summarized it really nicely. Just two additional points which I think are really key. One is the symptoms don't have to be severe for you to get better with behavioral therapy. It used to be that we as healthcare providers used to say that only patients with severe symptoms we should be referring for CBT, cognitive behavioral therapy, or gut-directed hypnosis. That's actually not true at all. Any level of symptoms, in fact, you could argue that patients with minor symptoms may do even better than patients with severe symptoms. And then the second thing is to build on something that Lynn said, stress-related symptoms put insight into the association between the stress or anxiety and the patient's GI illness experience is really key. So having that component, but also having insight into the relationship really increases the likelihood that you're going to respond to behavioral therapies like CBT or gut-directed hypnosis.
Fantastic. And that's definitely something for you to talk to your healthcare provider about. Dr. Kiefer had a bunch of resources in her slides about places where you can help to find someone who can help you with your behavioral therapy. Our next session is really exciting. Of course, we are looking at some other treatments that are beyond pharmacological and devices. And so really excited to hear the next session.
Yeah, I'm looking forward to hearing about complementary and alternative medicine for gastrointestinal disorders by our dear friend, Dr. Tony Lembo, who is at Harvard University and has a lot of experience in this space. In fact, did a lot of the foundational trials on acupuncture for irritable bowel syndrome, and then dietary interventions for GI disorders. And that'll be given by our lead dietitian at University of Michigan, Emily Haller, who's really an expert at GI dietary interventions.
Absolutely. And she's been a great friend to IFFGD. So both of them have, and I really look forward to these two presentations.
Hello, my name is Dr. Anthony Lembo, and I'm professor of medicine at Harvard Medical School, and I practice at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. And today, as part of the Nancy and Bill Norton Patient Education Series, I will be presenting to you a talk on complementary and alternative therapy for irritable bowel syndrome. Complementary and alternative therapy, otherwise known as CAM, is used as very common in the United States. In fact, approximately 35% of the adult population in the USA has used some form of CAM therapy within the past year. Interestingly, most, around 50%, do not tell their doctors that they're using these therapies for a variety of reasons. One of them seems to be that they think that doctors may not understand or agree with their use of these medications, which is quite interesting because we are very interested in these therapies, and we're going to talk a little bit more about them as time goes on. Its use is more common among younger people than older, women more so than men, those with higher education, those with more severe symptoms, and those with poor satisfaction with standard therapy for their IBS. Now, CAM is based on a holistic approach. It looks at in the idea of CAM medicine, it looks at diseases that result from disturbances based on physical, psychological, and sociological and spiritual levels. The CAM modalities that we'll talk about in upcoming slides are all attempt to restore the balance and facilitate the body's own healing. There are two main categories of CAM, those of natural products, and these are most typically dietary supplements such as herbs, vitamins, minerals, and probiotics, and I'll touch on each of these in the upcoming slides. And there's another form of CAM medicine, which is known as mind-body therapy, and these include yoga, acupuncture, and Tai Chi, among many others that are available. This slide lists even more of the ones that are available. We won't be talking about all of these, but I just wanted to touch base on them. So you can see the number of natural products these are probably the most common that are used for IBS, as well as the number of mind-body treatments that are being used for IBS. In general, the evidence is relatively poor for CAM therapy. Most studies lack well-controlled, large, multi-center trials for their data. So I'm just going to say that now because I won't have to repeat it after each of the following slides that we'll be talking about. So just remember that in general, these are not large, well-conducted trials like we would see in the FDA-approved medications. So let's first talk about prebiotics and probiotics for IBS. So prebiotics are high-fiber foods that act as food for the microflora with the intention to maintain balance of these microorganisms. So in other words, these are foods that we do not absorb, yet they go into your colon where there's multiple bacteria, and the bacteria will digest these foods. The most common are the fructooligosaccharides. These are found in garlic, onion, asparagus, among most of the vegetables and fruits that we eat. And studies have shown with fructooligosaccharides that there is slight improvement over placebo, but the NS means that the studies have not shown statistical significance. So just an FYI, there are other studies, but they're really with other types of oligosaccharides, but not yet showing strong data for them. Probiotics are live microorganisms that promote health benefits. The effects are strain specific. So what that means is that there are specific strains of probiotics that are being studied. And it doesn't mean that all of the probiotics in the same class would have the similar effects. There really should be strain specific. The guidelines that were recently published in the GI associations, the American College of Gastroenterology, the ACG, and the American Association, American GI Association, the AGA, both recommend against the use of probiotics for the treatment of IBS due to the lack of significant studies showing significant difference in the fact that there are some differences that are found, but really not consistent data as of yet. There are some that I've listed here, including lactobacillus and some bifidobacters that have shown some improvement in IBS. But again, these are not large multi-center trials, but these are probably among the best studies that have been done in IBS. But again, they're not up to the rigor that's considered acceptable for at least for the ACG and the AGA for treatment of IBS. That doesn't mean we don't use them in our clinical practice. Some patients feel very strongly about them, and they have a strong rationale for why they may be helpful. And I don't think there's a lot of harm associated with them. Just remember that there's not a lot of data associated with it. I get a lot of questions on cannabis from patients these days, particularly with regards to its effects on IBS symptoms. We know that THC, which is the active component in marijuana or cannabis, it has an analgesic effect. But unfortunately, there haven't been a lot of studies in IBS specifically. There's one study with 10 IBS patients that found no difference in the threshold for a rectal distension protocol, so the extending a balloon within the rectum using a synthetic THC called dronabinol. But as it's suggested, that it may not have significant analgesic effects, at least at the doses that were given in this relatively small study. And another small study with 36 IBS with diarrhea patients. These patients were randomized to dronabinol, which is again the THC, a synthetic THC, 2 different doses. And patients underwent a scintigraphy, and that's a method to measure the transit within the GI tract, and also genotyping for some polymorphisms that are involved in the metabolism and in the activity of THC. They found no changes in the transit, but patients that did have one of the polymorphisms did show some delay in transit. So again, not a lot of data. And I wish I had more data for patients to recommend for or against the use of cannabis, but really there's very little information for it. And I think you have to be careful about the long-term side effects, which we don't necessarily have a good understanding of quite yet. Aloe vera is an old treatment. We know that topically aloe-based gels can improve acne. They may help reduce pain as well. And some people with a variety of skin issues, such as herpes, lichen planus, and psoriasis have shown some improvement. You should know that before 2002, aloe was found in a number of different laxatives, but it was removed from the over-the-counter or the OTC market due to lack of safety data, not of known side effects or complications, but lack of safety data. There's relatively few trials. I was able to find 3 trials in IBS for a total of 236 patients. 1 trial showed some benefit, and 2 trials showed no benefit over placebo with the use of aloe. So really not enough data as of yet. And I showed one of the studies shown on the right here, showing some of the differences that may be seen with Hallow in this small 4-week trial with it. Some of you may be familiar with iberogast. A number of patients do come into the office with this. This is a combination of a number of different products, as you can see from the list up above, including caraway, licorice, lemon balms, etc. And it's been used commonly for a number of different GI disorders, including dyspepsia, which is probably the most common use that we see. You should know that there have been some cases of severe liver toxicity that have been reported with iberogast. We should really need to be careful about its use with it. There was a trial, a fairly large trial in IBS patients that were randomized to 2 different forms of iberogast, the standard one and then a more unique one, individualized one. And the control was bitter candy tuft as well as placebo as 2 different types of controls. So really a well-conducted trial. And as you can see from the study, if you just look at the IBSS score, which is a severity score for IBS shown on the left-hand side, at day 28, you do start to see some differences with iberogast compared to the placebo and the bittersweet candy tuft. And you can see that at day 28. On the right, you can see some effect on abdominal pain as well. So there is some data to support its use, but again, remember that it has been associated with liver toxicity. Berberine comes from a traditional Chinese medicine. It's been used for years to treat diarrhea in China. Its mechanism of action is to enhance the sodium absorption, which also in turn causes an increase in water absorption from the intestines, and may also have some antinociceptive effects through nitric oxide mediated pathways. So in a study done in China with IBS with diarrhea patients, you can see here compared to placebo, the study had about 130 patients with it, and you can see that there were statistically significant differences for berberine after 8 weeks compared to baseline, as well as compared to placebo. So interesting data with this, but there's just not, again, there's not a lot of other studies. Turmeric sometimes comes up in our practice. It's been known to increase GI motility by activating hydrogen-producing bacteria within the colon. And again, also this formulation that was studied called IQP 101, xanthophen, is a proprietary mixture of anti-inflammatory curcumins, fish oil, as well as peppermint oil. This is probably the best study, and you can see the changes with abdominal pain that were statistically significant beginning at week 3. So again, some data, and there's also the IBSSS score shown in the table above, showing improvement with abdominal pain, but again, a relatively small study with it. This is an interesting study with glutamine, and excuse me, glutamine is an essential amino acid, but importantly, it's a major energy source for the epithelial cells that line the GI tract. And it's been shown, in the past, that particularly patients like in the intensive care unit that may be deficient in glutamine, that they have an increase in permeability within their intestines. And that can be improved by giving these patients oral glutamine. And we also know that patients with IBS with diarrhea, some patients may also have an increase in permeability. So in this study that was done by Nick Byrne's group, they took a group of post-infectious IBS with diarrhea patients that had documented evidence of increased permeability. And they were given either 5 grams 3 times a day of glutamine or placebo for 8 weeks. And as you can see from the table, this is the change in their IBSSS score, which is a severity score for IBS, that there was a marked difference with glutamine and a relatively small difference with placebo. And it also seemed to improve frequency and consistency and most importantly, I think, improved permeability associated with as well. So this is promising data. Again, a very select group of people, that those with IBS-D that have increased permeability, which represents probably less than 50% of those patients with it. Now, moving on to the mind-body type treatments, acupuncture is a common treatment. It's not only used in China, it's used throughout the world. Particularly in the United States, there are more acupuncturists per capita in United States than there are in China, for example. So these are commonly used, and it's based on a long-standing tradition of traditional acupuncture points on these main channels, or otherwise called as meridians, with it. And each point has a defined therapeutic action, and typically they'll use somewhere between 5 and 15 needles in a session, and they may also combine it with heat, electricity, etc. may be used as well. With regard to IBS, it's been well studied. There are a number of randomized control trials and several systematic and meta-analyses of these studies as well. And in general, they show that there's no benefit in IBS or quality of life compared to sham acupuncture. So just to keep that in mind. What's important to note, though, is that there is improvement with acupuncture in sham acupuncture compared to no treatment no treatment. And this was a study that we did a few years ago, and we had an acupuncture group, a sham acupuncture group, and a waitlist group. So as you can see, if by looking at any of these graphs, let's just focus on the upper left. This is the global measure of improvement in IBS, that there was no difference between acupuncture and sham acupuncture, which is what showed in many other studies. There's a numeric difference, and we and others have calculated that you would need to power to do the, to really show a statistical difference, you need to have a very large trial, not an enormous trial, something along the lines we've seen in many drug trials, but usually somewhere between 500 and 700 patients would need to be done to show that to power this properly to see if there was a real difference. What was most striking was the difference between the sham and the acupuncture in the waitlist group. So nothing or no new treatments, doing sham acupuncture or acupuncture is better than doing no other treatment. Yoga has also been studied. It's commonly used by many people, not necessarily just for IBS, but within the group of IBS patients, there are a number of studies comparing yoga versus no treatment, and about a third of patients that are in yoga report clinically significant improvement in symptoms of IBS. They also report other improvements such as decrease in anxiety, decrease in the number of medications used. There are several studies looking at yoga versus exercise, such as in this case was a walking program showing there was no difference between these two groups. We know that walking has also been shown to help IBS symptoms, or any moderate to rigorous exercise has been shown to help as well. Yoga versus medications. There's one study looking at yoga versus loperamide, which is an antidiarrheal medication used for IBS diarrhea, showing again no difference between the groups. And we know that loperamide can improve stool frequency and consistency, but may not help abdominal pain. And a study looking at yoga versus psyllium plus diazepam, which is a benzodiazepine plus an antispasmodic, and again, not showing no differences between the medication group and the patients receiving yoga. So again, yoga may be as good as some of these medications, if you want to look at it like that. Very interesting, yoga is also compared to a low FODMAP diet, and that's a very commonly used therapy, which you'll hear about in a separate talk, and showing no differences between the yoga and the low FODMAP diet in this case. So just to summarize, CAM therapy is commonly used, particularly in the United States, but also throughout the world. Most CAM therapies in IBS lack well-controlled, large, multi-center trials. And as I indicated, some of them are also associated with side effects, as I mentioned with iberic acid, although not very common. You need to be aware of the potential for that, particularly in the herbs, these medications that are potential side effects. Current data suggests that there may be some benefit for IBS for many CAMP therapies, though given the lack of well-conducted studies, further trials are needed to determine the appropriate patients and the potential for risks. Thank you much.
Hi, my name is Emily Haller, and I am a GI dietitian at Michigan Medicine with a division of gastroenterology and hepatology. I'm very excited to be here with you today to talk about dietary interventions for a variety of GI disorders. So today in my talk, I'm going to highlight a variety of diet interventions or therapies for these GI disorders, including celiac disease, eosinophilic esophagitis or EOE, functional dyspepsia, gastroesophageal reflux disease or GERD, gastroparesis, inflammatory bowel disease, irritable bowel syndrome, and short bowel syndrome. So starting off with a gluten-free diet for celiac disease. A gluten-free diet is the only treatment for those with celiac disease. Gluten is a protein and it's found in certain grains. It's in wheat and rye and barley, and these must be avoided. Gluten-free oats must also be used. Oats that are not labeled gluten-free are not considered safe for those with celiac disease. Label reading is really important on the gluten-free diet. Gluten can be in some less obvious sources like regular soy sauce, certain seasoning packets, and even some broths, for example. Dining out can be difficult, but it's not impossible. Knowing what to look for and the certain questions to ask, ways to prevent cross contact are very important. There is a really helpful article by the Celiac Disease Foundation, which can be found here, about dining out and social eating. They have the dining dozen, which is 12 different questions you might want to ask depending on what's being ordered. And again, tips to talk about or think about to reduce cross contact when eating in social situations and dining out. A gluten-free multivitamin may be necessary for those who are not able to meet their nutrient needs with diet alone. And because of the nuances of a gluten-free diet, it is highly recommended to work with a knowledgeable GI dietitian, especially when someone is first diagnosed. It can really help set you up for success. Many individuals with irritable bowel syndrome will associate their symptoms with eating or eating particular foods and restrict their diet to improve gut symptoms. Research has shown that a diet that is low in fermentable, oligosaccharides, disaccharides, monosaccharides, and polyols, or FODMAPs for short, can improve gut symptoms for those with IBS. FODMAPs are short-chain carbohydrates. So they're short-chain sugars or short-chain fibers, and they're found in a wide variety of different foods. The low FODMAP diet is not a forever diet. It is actually done in 3 phases, which you can see here. So the first phase is the elimination phase, where we have someone remove or avoid high FODMAP foods for a short period of time to see if they feel better. If someone feels better, then we have them move forward to the reintroduction phase, which involves adding back in high FODMAP foods in a strategic way to identify triggers, and just as importantly, to identify what sits well. And those are the different FODMAP groups to your right. So the fructans, the GOS group, lactose, fructose, and polyols. And then the third phase is the personalization phase. And this phase is kind of ongoing, long-term maintenance or management of gut symptoms. And what that looks like is going to be a little bit different for everybody, but it involves bringing back in the high FODMAP foods that are not triggers and limiting or avoiding the FODMAPs that do trigger gut symptoms, with the goal being increasing the diet to have the most variety while maintaining symptoms long-term. We may use specific digestive enzymes here or some other tips and tricks based on a person's triggers. It is also important to note that not everybody with IBS is going to feel better on a low FODMAP diet. If someone doesn't feel better in that elimination phase, then we have them come off of the FODMAP diet and add back in those high FODMAP foods. There is no benefit to avoiding FODMAPs unless it helps improve gut symptoms. And then in the case that it doesn't work, we want to go back to the healthcare provider, right? And ask, what are some other options, other modalities, even other nutrition strategies that may help improve gut symptoms? So diet interventions for short bowel syndrome. There's really not one best SBS diet. And what I mean by that is it's going to look a little bit different based on the person's anatomy, how much length they have left in their digestive tract, and how well that is functioning. Some people with short bowel syndrome are going to receive their nutrition partially or fully, or maybe IV fluids through a vein, so total parenteral nutrition. Some general diet tips: if someone has some of their colon remaining, a high complex carbohydrate diet is recommended, versus if someone has a jejunostomy or a high output ileostomy, a higher fat diet may be beneficial and recommended. Chewing foods well to help break them down can be very helpful. Avoiding concentrated sweets and beverages. This one is huge. So think about our juices, sodas, desserts, sweet coffee drinks, some sports drinks. High sugar loads can act as a laxative. They can pull more water into the gut, and that can speed things up and create more diarrhea or higher ostomy output. Eating small, frequent meals spread throughout the day, limiting beverages with meals. So just, starting early with hydration, sipping on fluids throughout the day, and keeping drinks to about 4 ounces or half of a cup at a meal is a strategy to try. And then salting foods liberally can be helpful. An elimination diet can be used for those with EOE in place of medications to manage their disease. So what this can look like is at least 6 weeks of an elimination diet, followed by a scope, so an EGD that looks at the esophagus and takes biopsies to assess response. And the diet protocols that we can use are a 2-food elimination diet that takes out the top 2, main triggers or allergens for EOE, and that's dairy and wheat. The 4-food elimination diet, which adds on no egg or no soy. And then there's the 6-food elimination diet, which is the most restrictive because that is taking out, dairy, wheat, egg, soy, and peanuts and tree nuts, and fish and shellfish. So pending that somebody responds to this, their eosinophils, significantly decrease with an elimination diet, then we have them add back in each food one at a time, followed by a scope to assess, what their trigger or triggers are. Unfortunately, we cannot go by symptoms. We have to do scopes to see what's going on in the esophagus to identify triggers for people with EOE. Label reading is also really important here. I wanted to show you some examples of some less obvious sources of the top 8 allergens. We chatted a little bit about wheat earlier when we were talking about gluten for those with celiac disease. Soy is, of course, in soy sauce, marinades, teriyaki sauce. It can be in different gluten-free products, crackers, breads, baking mixes, some vegan products, dairy-free margarines, and granola bars. Milk can be found in deli meats at times, gluten-free baked goods, protein powders, and granola bars. Nuts also can be found in granola bars, pesto, different, of course, nut flours like almond flour. And then fish can be found in Asian cuisine, usually through the use of fish sauce. So we've chatted about some very specific nutrition therapies for GI conditions. And then now I want to talk a little bit about strategies, who may benefit from these, because it can be more than one condition, and then what to try. So starting with smaller portion sizes and a lower fat diet. Who may benefit from this eating strategy? People who have GERD, people with functional dyspepsia, and those with gastroparesis. So some things to try that may offer symptom relief is eating regular meals and snacks spread throughout the day. Paying attention to portion size, right? Not under eating during the day or skipping meals and having one main meal. Looking at the consistency of foods, focusing on soft, tender foods, foods that have more moisture, liquids versus those like tough and roughage foods. So think like kale, raw kale salads, large amounts of nuts, popcorn, meat with a lot of like fat or gristle. Those would be some examples of like tough and rough foods that might worsen gut symptoms. And then spreading fat throughout the day can be helpful. That sometimes happens naturally when we switch to eating, maybe smaller meals spread throughout the day, avoiding the use of a lot of oils, a lot of butter, avoiding greasy meals and fried foods would also be a strategy to implement here. So a high fiber diet, who may benefit from this? People with inflammatory bowel disease that are in remission, people with diverticulosis, and potentially people who have constipation. So what to try? You want to eat more plant foods. Plant foods give us fiber. So fiber is found in your fruits and vegetables, whole grains, nuts and seeds, and legumes. So beans and lentils. What I recommend here is if and when we're eating a lower fiber diet, we want to gradually increase fiber intake. It's not something we want to do in one day because that can lead to a lot of symptoms. It can lead to more gas, bloating, distension, maybe cramping or pain. And that can be discouraging. That can make us feel like, hey, I can't eat these foods, they're hurting me. When really we have a much better chance of tolerating a higher fiber diet when fiber is increased gradually. With that, we also want to make sure we're drinking plenty of fluids and staying hydrated. So how can we do this? You can try adding some fruit and some nuts or seeds to our morning cereal or yogurt and do that for a couple of days. Let your body adjust. Then layer in another fiber-containing food to another meal. Maybe at lunch, you'll try a whole grain like quinoa or brown rice. You could do oats or trial a bean or lentil pasta instead of a white pasta. You could open a can of chickpeas or white beans and add those to a soup or salad, and then maybe adding some extra vegetables at your dinner meal. And those can be fresh or frozen or canned. All of those are going to provide your body with fiber. On the flip side, we may need to use a lower fiber diet. So who may benefit from this? People with diverticulitis, so active inflammation of the diverticula, people who have gastroparesis, those with inflammatory bowel disease who are in a flare, who are struggling with fiber-containing foods, or people who present with intestinal strictures, maybe have a history of small bowel obstructions. So some tips here to still be able to eat some fiber-containing foods, but in an easy to digest way include peeling thick skins of fruits and vegetables, blending or pureeing, so food processor, a blender, juice fiber-containing foods, cooking produce until tender. While this doesn't remove the fiber, it makes it a lot easier to digest. So think about something that's like fork tender. You can pierce a fork through it or mash it with a fork. Chewing your foods really well can help because it will break down that particle size of the fiber. And then you can grate or chop fruits and vegetables and mix them into other dishes as well. Because we do still want to try to get fiber in the diet. Low fiber doesn't mean fiber free. So we want to try to find ways, get creative to be able to get these nutrient dense foods into your diet. So there have been some common themes or common goals among these dietary interventions. And one is optimizing diet quality through increasing the variety of foods, nutrient dense foods, foods that people enjoy, minimizing and improving gut symptoms, and then supporting a person's overall health. And that includes their relationship with food. So if you are struggling with what or how to eat, you find yourself eating a really limited diet and are not able to successfully expand what you're eating, then I highly recommend partnering with a GI dietitian. GI dietitians are food and nutrition experts who can help you navigate how to eat with a GI disorder. A good place to start is by asking your doctor for a referral. If there is a GI dietitian, present in the clinic that you can meet with, or if your provider has somebody that they can refer out to in the community, maybe a private practice dietitian who specializes in, GI disorders, GI health. You can also find a dietitian online. So IFFGD has a search. The AGA is working on coming out with a vetted GI dietitian list as well. GI On Demand, which is a virtual platform, this is a partnership between ACG and GastroGirl, also has vetted GI dietitians that can meet with people online through virtual appointments. And then they also have online patient education resources, so webinars and modules that people can use. And that brings me to the end of my talk. Thank you so much today for your attention. I hope you found this helpful.
There's our kitchen right there.
Hello, and welcome back to the second day of the Norton Educational Series 30th anniversary event. My name is Ceciel Rooker. I'm the president and executive director for IFFGD. With me today are Drs. Bill Chey and Dr. Lin Chang, who are experts in this field of GI disorders, who are helping to co-host this event from sunny South Carolina. Wasn't so sunny yesterday, but today it is. And so we're really thrilled to have them with us today. So we had these great topics, right? So we're getting past sort of the traditional therapies that people think about, over-the-counter medications, prescriptions. I mean, really getting into what people are very interested in, which is the dietary behavioral therapies and also complementary and alternative medicine. As Bill mentioned before, Tony Lembo is one of the experts in this space. One thing he mentioned in his talk that I found very interesting is that so many patients don't tell their physicians that they're trying some of these other non-traditional therapies or herbs and things like that. And do you find that to be true in your practice as well?
Oh yeah. I mean, I'm sure Lynn will have a strong opinion about this being from California, but even in Michigan, there are many patients that are utilizing CAMP therapies. In fact, I think it was the IFFGD survey from 10 years ago that suggested that upwards of 40% of patients with disorders like IBS are using some form of CAMP therapy. Yeah. So it's incredibly common. I think the big issue is that there's a hesitancy on the part of both patients and providers to communicate on this issue. So providers oftentimes don't ask and patients oftentimes don't tell. And I think it stems from issues of credibility around the veracity of the data for those therapies in patients with functional disorders.
Right.
Yeah, I mean, it's not even part of when you do the intake of the medical history, you have medications, surgeries, past medical history, but you don't have anywhere about the complementary alternative medicine. So it's not asked by the staff or the physician, a healthcare provider, and the patient doesn't necessarily provide that information voluntarily provided unless you ask. If you ask about it, then they do.
Should they be talking about these things?
If they're using it for the treatment of the symptoms they're coming to see you about, I would think so.
I think so. And by the way, as you know, Tony pointed out, some CAMP therapies are evidence-based at this point for patients with a variety of gastrointestinal symptoms, whether you're talking about nausea or constipation or IBS. There are CAMP therapies that look quite promising as treatment alternatives for those patients.
Definitely think patients who have a lot of coexistent conditions, and a lot of them may have a shared pathophysiology cause. You know, when people have fibromyalgia, they have a lot of muscle pain, and they have IBS or constipation or chronic abdominal pain, migraines. They, I think, search for CAMP therapies because they really address the whole body and not just one organ system. Or when they have severe symptoms, they'll use it either to add to whatever treatment they're getting, or they'll even use it on its own. But it's really where we need the integration of Western and Eastern approaches, and not to say you can only do one or the other, but to really be open to utilizing both would be helpful.
I not uncommonly refer patients for acupuncture, for example.
And
Patients with constipation or pain.
what other GI disorders would you consider referring a patient out for some sort of complementary and alternative therapy?
Nausea.
Nausea?
Chronic nausea is a
Mhm.
great candidate condition. And, I think Chinese herbal therapy is another potentially attractive treatment option for some patients. Now, the reality is that all of these things, I don't think necessarily do any better than the things we have to offer in Western medicine, meaning that it's subgroups of patients with constipation, nausea, IBS that get better with any of these herbal therapies, acupuncture, et cetera. But it's nice to have those additional arrows in your quiver, because the reality is none of the treatments that we have are a silver bullet for every patient with these symptom-based conditions. So having lots of arrows in your quiver increases the likelihood that you're going to find something that's effective by either in isolation or in combination for the patient sitting in front of you.
See, the other issue I think is that, like, we're guided a lot by guidelines, which means that you're looking at, well, we talked earlier about randomized controlled trials and the evidence, but the same with probiotics. A lot of the quality and the way the study design has been conducted, it doesn't meet what the guideline committee would say is high quality to recommend it. And CAM therapy is the same way. They're not conducted in the same rigorous fashion as medications that the FDA reviews. So the guideline may say there's not enough evidence. It's not, but it could be. It's just that we haven't met that threshold by which you can really grade the evidence. But it could be efficacious in particular individuals. But like Bill said, which I think is a really important point, is that for any of these conditions, not one treatment is not going to help every patient.
That's right.
Sure.
You really have to tailor to not only what the data shows or what you think will help the patient, what the patient is interested in.
Absolutely.
If they're not interested in it, then it's probably not worth pushing or discussing it more if you really think it's something they should use.
Absolutely. So please, I think the take home message is to talk to your healthcare provider about what CAM therapies might be good for you, and then also what you might be already looking into and participating in. So please, always have those open and honest conversations with your healthcare provider. So let's talk about Emily Holler's presentation on diet. She's so fantastic, and she covered so much. Like, she covered so many different areas that a dietitian is helpful. And so one of the questions that we had is talking about a diet for constipation specifically. So that's one that she really didn't mention that much. So is there some, foods that can help with the aid in constipation? I know that people have often said fiber, but then patients say that a lot of times with constipation, that's not very helpful. So do you have any things that you suggest to your patients in clinic?
Yeah, it's a really exciting area because we're starting to see evidence. We published a paper this past year on the use of kiwi fruit for chronic constipation, and we specifically compared 2 peeled kiwi fruit to 12 prunes per day, which is a lot of prunes, but it's a lot of prunes. But prunes work really well for constipation, interestingly, probably as well as many of the medical therapies that we use, but you have to take a lot. Like, taking a couple prunes a day is not gonna help much with your constipation. The interesting thing is that prunes, in our study, prunes were the most effective, more effective than kiwi, but kiwi was much better tolerated. So it didn't cause as much gas and bloating, because remember, the prunes are not low FODMAP, but kiwi is. So in terms of causing issues like abdominal cramping, gas, or bloating, kiwi essentially doesn't do that.
Fantastic. Yeah, so I actually saw the earlier data published in Europe on the kiwi. And so it's really exciting that you were able to do that and learn a little bit more. So there are some things that people can do with their constipation. And so that's great. And I believe in our later this year, we'll be publishing a special edition of our Digestive Health Matters magazine. And in there, Emily Holler has a recipe for a smoothie for constipation that helps with constipation. So be looking for that and make sure that you're signed up for the IFFGD newsletter so that you can make sure to get a copy of that magazine when it is available. So a lot of people want to use the registered dietitians, and they have some concerns about insurance and insurance not covering the dietitians. Are there websites or apps that might be beneficial if they are unable to see a dietitian? And before you answer that question, I want to let you know at home that we do realize that this is an issue here at IFFGD, and we do would be more than willing to send a letter with you to your insurance company, letting them know the importance of diet and GI health. Here at IFFGD, we have several of those nutritional letters that have been co-written by some dietitians, where we can try to convince your insurance company to help with that. No guarantees that it will work, but we're happy to do that. Please contact us if you would like some assistance with dietary therapy or any other therapy that your insurance is not covering. But let's say that that doesn't work and you aren't able to go see a registered dietitian, which would be the gold standard because they can really tailor the approach. Are there other ways that people can get this without just going out on Google, where there's a lot of information that's not correct, and a lot of people selling supplements and teas that are not helpful? So are there any suggestions? What do you suggest with your
Yeah, there's a ton of information out there, and like very much like we were talking about the digital therapeutic space, which is rapidly expanding. Also, the number of websites providing information about diet therapies for GI conditions is also rapidly expanding. Monash University really has the gold standard in terms of mobile applications called the Monash University Low FODMAP app, and it provides information about the FODMAP content in various foods. It also provides some recipes. There's a website that we put out called www.mygnutrition.com, which provides videos that explain how FODMAPs cause problems and the 3 phases to the low FODMAP program. There's some excellent websites put out by private dietitians. Kate Scarlatta and Patsy Katzos have really boundless information on their websites that I've looked at, and it's excellent. And then finally, for those that aren't computer savvy or don't want to go to the digital realm, there are a lot of books actually now, multiple books by Kate and Patsy, Rachel Pauls, as well as others that go into a lot of detail in terms of how to implement the low FODMAP diet specifically into their day-to-day regimen.
Fantastic. And so for those of you at home, if you would like more information, I know Bill Chey went through that really quickly, just contact us at IFFG and we're happy to share those resources with you again. So let's move on to our to next. What we are going to have is our very first and only actually break session for today. And again, like yesterday, we're going to be giving some great examples of some of the behavioral techniques that Lori Kiefer talked about this morning, and things that are used not only with the GI illness community, but all chronic health issues. And so during this session, which will be about 30 minutes, we will be doing breathing techniques with Dr. Claire Brandon, and then narrowing in on diaphragmatic breathing with Meredith Craven.
Hey guys, Dr. Claire Brandon here again. So glad to have you back for our third and final break time relaxation module. We've been learning how to take back control of our autonomic nervous system, that fight or flight response, and figuring out ways to utilize relaxation in our everyday life for stress, anxiety, sleep, and just being back in the moment. We've already talked a bit about grounding exercises, using our senses to get back in the moment and get back on track. We've talked about progressive muscle relaxation, a really great technique for helping yourself sleep or even calm down and bring your anxiety to a different level if you're in a stressful situation. So definitely jump back to those, get a little bit of a sense of what we talked about there, and my recommendations for apps that you might be able to utilize on an everyday basis to check out and to incorporate these techniques into your everyday life. Now, today we said we were going to talk about, in our third session, more about breathing techniques and breathing tactics in order to help us figure out ways to, again, take back control of that nervous system when we're in an especially stressful setting. So we're going to learn 2 different breathing techniques, but first, let's talk about what exactly would be the purpose of learning how to breathe better, in essence, right? Why would we want to be doing this? You know, people tell us this all the time: take a deep breath. Why don't you take a deep breath and relax? And it's easier said than done, especially if you're in the midst of a crisis type of feeling, you're in pain, you're very, very stressed. It can be a lot harder to do than it is to say to take a deep breath and try to calm down. That being said, there's a reason why our bodies choose to make us feel like we can't breathe that well. And that's because we're in that fight or flight response, in essence, running from the bear, or I guess evolutionarily, we were running from the saber-toothed tiger, potentially. You know, when you're running from danger, your whole body takes over and says, heart needs to pump faster in order for us to get more blood to the body, right? That's when you feel your heart racing. Breathing needs to be quicker. So we're, you know, taking in shorter inhales, but more frequently to try to get as much optimized oxygen as possible. And in other ways, our gut doesn't work as much, right? You might find yourself being more constipated when you're under higher stress levels, because I like to joke that we don't poop when we're running from the bear, right? So, you know, that can really be detrimental, that can be problematic. All these things get in the way of us feeling relaxed, of us sort of having that homeostasis that we would be searching for, that would allow for us to have a better control over our anxiety or mood symptoms, but also our gastrointestinal control. So all that being said, when we again take back control of our breathing, it's really powerful because it reminds our brain, well, wait a second, if I'm inhaling deeper, that equals that I'm able to I need to tell myself I'm not running from anything. There's no danger. The bear isn't there. It doesn't exist. So that's why breathing is an important thing to try to get better at taking control over. And the bottom line is that it just takes practice. You have to be super mindful about being really focused on getting better at breathing, making it a habitual practice, meaning that your brain just clicks right into it and says, hey, we need to breathe differently. Being more mindful and aware that you're not getting deep enough inhales. Some triggers to suggest that would be if you're feeling lightheaded, if you're feeling a little bit of dizziness, that could be that you're actually holding your breath. Now, that isn't to say if you have lightheadedness or dizziness, you shouldn't make sure you talk with your doctor about it. But if there's everything's been rolled out and it's more in the context of anxiety or stress, deep breathing can actually be really, really helpful if you're able to. These techniques can be used whenever you need them, and that could be before an interview, that could be before a doctor's appointment. Anytime you really want to get your mindset in a place where you're calm, you're confident, and your heart is not racing, you're breathing, getting good oxygen into your body and your brain, would be a good time to utilize these techniques. There's 2 that I'm going to tell you about. One is probably better for stress moments, and the other one is great for stress moments, but I also find it really helpful for getting to sleep. So maybe you can try them out and see what helps for you the most and what would be the best technique to use for you. The first one is called 4-7-8 breathing. It's exactly how it sounds. You're inhaling for 4, holding your breath for 7 counts, and then you're exhaling for 8 counts. So we're going to do that together, and you're going to get a sense of what that feels like. Take note of what your body feels like right now as compared to when we're done with the breathing technique. So you're going to inhale, counting for 4. So inhale, 2, 3, 4, holding your breath, 2, 3, 4, 5, 6, 7. Exhale, 2, 3, 4, 5, 6, 7, 8. Inhale, 2, 3, 4. Holding, 2, 3, 4, 5, 6, 7. Exhale, 2, 3, 4, 5, 6, 7, 8. You can do that over and over again. I find that it's very helpful it actually helps you take back control of your heart rate. And as we talked about in the progressive muscle relaxation and the grounding techniques, our vagus nerve actually helps to regulate all these fight or flight responses. And this deep breathing actually takes back control of that. So test that out, see how you feel on that. And you might find yourself experiencing a calmer sensation just because you are able to take back control of things like your heart rate. Now, the other alternative type of breathing, which you can use both of them, you can use just one of them. It's just good to have some different options. It's called diaphragmatic breathing. And sometimes it's also called belly breathing because we want to think about inhaling as much air as we can so that we can imagine our body expanding and taking in as much air as possible. Now, that expansion is not really your lungs necessarily, it's your diaphragm. And I want to share with you a diagram here that will be helpful in us identifying what exactly that looks like so that you can maybe have a bit better of a sense of what's going on in your body when we're talking about diaphragmatic breathing. So I'm going to share here and look at this diagram for a moment. When we're inhaling a deep breath is coming in. Let's see if I can use a pointer here. Breath is coming in and we are going to expand our diaphragm. So our diaphragm is probably one of the larger muscles in our body, and it goes all the way across the bottom of our lungs. We're breathing in, and the ribs expand a little bit because the diaphragm is allowing there to be some suction, some more room to expand our lungs. When we breathe out, our diaphragm is going up and it's relaxing. It's actually sort of springing back up, just like you would see in a pump that's moving up and down. So inhaling, your diaphragm goes down. Exhaling, your diaphragm is going up, and then your ribs are also contracting a little bit because of all those muscles that are connected. So that's diaphragmatic breathing. And when we think about this, it's really, really powerful because we actually, again, have control over our diaphragms. We can re-regulate that. And when you take a deep breath in, imagine your diaphragm expanding down. It's really helpful sometimes to put a hand on your heart and a hand on your belly so that you can experience how much expansion your stomach has when you're inhaling, and that's due to your diaphragm. When you're exhaling and squeezing all that air out, your diaphragm is moving up. And so you can imagine this sort of rhythmically going up and down, and it can be a form of meditation to do that. So I like to think about this in counts of 4. It can be really helpful to give yourself a number if you like some, sense of direction there. So inhaling, counting to 4, expanding as much as you possibly can, your belly, and then exhaling, thinking about the diaphragm scooting up, rebounding, having a spring back feeling, and letting all that oxygen get out of your system. So you can do that over and over again in counts of 4. So inhaling 2, 3, 4, exhaling 2, 3, 4. And doing that over and over again can be super helpful to decrease panic, to decrease stress, to help yourself just be calmer in the moment. Some of my favorite apps for that actually is the same one we talked about grounding. It's called Clear Fear. And again, it has actually a little bubble that you can watch go back and forth, expand and contract. It kind of represents the diaphragm. You can watch that go in and out and breathe along with it so that you don't have to count. You're just watching this, especially if you're a visual learner like me. That can be really helpful. And the same thing goes for Insight Timer, actually listening to breathing meditations, coaching you through breathing. Can be really, really powerful and helpful, especially when you don't feel like you quite have the ability to pull that out of your hat when you're not with the app. This can be a really great moment to take control with using the help of the apps. I hope these techniques have been helpful. I hope they've helped you calm down a little bit, especially if you're going through pain, physical sensations, any kind of anxiety, depression, mood symptoms. As always, consult with your doctor. I would encourage you guys all to check out mental health options in your area, especially if you've never been to a psychiatrist before. It might be really useful. I see a lot of patients with chronic illness and gastrointestinal illness. You can get more information from me on my website, which is www.clairebrandonmd.com. And you can send a message to my practice through that if you're looking for resources. I also have Instagram called with my name, Claire Brandon MD, or the podcast, The GI Psychiatrist, and its corresponding Instagram, The GI Psychiatrist. So hope to see you guys there soon. Thanks so much for letting me be part of your day. And I hope you've learned a lot and can take these into the rest of your day and week and go forward, teach other people some of these techniques too. Take care, everybody.
Hello, my name is Dr. Meredith Craven. I specialize in GI psychology, and today I will be leading you through a diaphragmatic breathing practice. Diaphragmatic breathing, or belly breathing, is a fundamental tool that I teach to all of my patients with digestive disorders. Diaphragmatic breathing is fundamental for several reasons. Primarily because it engages the parasympathetic nervous system. The parasympathetic nervous system is often called the rest and digest system. It allows our bodies and our brains to rest and restore. The parasympathetic nervous system is also in charge of digestion. Another way belly breathing is helpful for our GI tract is through the massaging sensation that the diaphragm creates in our abdomen. This sensation can help improve stomach discomfort, urgency, bloating, and constipation. Finally, as we intentionally focus our attention on our breath, our minds can quiet. The more that we practice diaphragmatic breathing, the easier it becomes, allowing us to engage our rest and digest system. We will be practicing this tool for just over 10 minutes. To begin, please find a comfortable position, either lying down or sitting in a chair. If sitting in a chair or on the ground, please allow yourself to be in a comfortable position. If you're in a chair, this means both feet flat on the ground. And if you're seated on the earth, allow your hips to be slightly raised. We want our backs to adopt an erect and comfortable posture with our head just above our spine. If it feels comfortable, you can close your eyes or allow them to softly gaze in front of you. So just take one more moment to settle in and get comfortable. Bring one hand to rest comfortably on your abdomen and place the other hand on your chest. You can also rest both hands on your abdomen with the middle fingers just touching. We will be breathing nice and easy, inhaling through the nose and exhaling out through the mouth. We will be taking a count of 4, 2, and 6. Inhaling through the nose for 4 seconds. Holding the breath for 2 seconds. And exhaling very slowly and steadily through the mouth for 6. As you finish your exhale, wait quietly, allowing your body to naturally take its next breath. Inhaling through the nose, holding for 2, and blowing out through the mouth for 6 seconds. As you continue to breathe, bring some attention to your hands. If you have one hand on your chest and one hand on your abdomen, the hand on your belly should be rising with the inhalation and falling with each exhalation. If both hands are on your abdomen, the middle fingers will spread slightly apart as you inhale and then touch as you exhale. If this is your first time practicing, you may notice a little bit of tension on that inhalation as our bellies expand, and that's pretty normal. If you notice that you're feeling a bit lightheaded, you can quicken your breath. We want to make sure that we're breathing at a comfortable rate for ourselves, making sure that the exhalation is longer than our inhalation, and that the belly is rising as we inhale and falling as we exhale, as if we're trying to inhale a fragrant flower and then exhale to blow, making a candle flicker. You could also think about this like a balloon is in your abdomen. As we inhale, the balloon expands, and as we exhale, the balloon deflates. Taking your time, there's no need to rush. We're practicing turning on our relaxation response as we slowly and gently inhale for 4, hold for 2, and exhale for 6. Continue to breathe in a slow and gentle way. Allowing your shoulders and jaw to relax while your chest remains still and the belly rises and falls. Now let's see if we can relax even further. We will be using a calming phrase or a mantra to see if we can sink even deeper in this relaxing state. On each in-breath, internally say the word be, and on each out-breath, internally say the word calm. So we're saying the phrase, be calm. Let's try another one. This time, again, on the inhale, internally say the word be, and on the out breath, internally say the word relax. Inhaling be, hold for 2, and exhaling, relax. Be relaxed. Let's try one more. This time, we'll say, be at peace. So on the in-breath, internally saying the word be, and on the out-breath, internally saying the words at peace. Now it's your turn to pick your own phrase or mantra, or repeat one of the ones we just practiced, trying it out for yourself for the next 5 breaths. Notice how you're feeling. You may feel more relaxed, or you may feel just the same. Whatever you feel is okay. See if you can allow your experience to simply be as it is in this moment with an open attitude. Continuing to take a few more rounds of diaphragmatic breathing, focusing on releasing any remaining tension. And begin to bring some gentle movement into your hands and your feet. Just knowing that you can take this feeling of peace with you into the rest of your day. You can try practicing diaphragmatic breathing or belly breathing for 10 minutes a day, And as you really get good at practicing, you'll be able to bring this tool out in a variety of settings, including those stressful moments. Thank you so much for taking the time to practice with me today. As you gently open your eyes, give yourself time to adjust to your surroundings, making sure that you do not stand up too quickly. Thank you again for your time.
Thank you so much for joining us for the Norton Educational Series 30th anniversary event. I hope you enjoyed those two breathing videos that we had with Claire Brandon and in that the diaphragmatic breathing as well. Those are great examples of things that you can do at home. And remember, those videos will be on our YouTube channel and on our website moving forward. So you're welcome to go back to those, rewatch them, and practice those techniques. We're going to go ahead and move on to our next session, which now we will be beginning our great panel sessions where we're going to hear the physician perspective followed by the patient perspective, and then we'll be discussing those in between the sessions. So really excited to do this and really thrilled with how these turned out. So.
Well, thanks. And we're going to have two presentations in this section, one by Dr. Braden Kuo, who's actually the head of neurogastroenterology and motility at Mass General Hospital in Boston. He's going to provide an introduction on nausea and vomiting. And then we're going to have a patient perspective by Dr. Tricia Bundy.
Yes, absolutely. And Tricia is actually a member of our patient advisory committee, and she is fantastic. Her story is very, very enriching. So please, we hope you enjoy this.
Good morning. Thank you for having me today. And I would like to thank the IFFGD for addressing this really important issue. I will be talking to you today about cyclic vomiting syndrome and cannabinoid hyperemesis syndrome, what a physician should know. These are my disclosures. Cyclic vomiting syndrome has actually been around for several years.
Hi, my name is Brad Kuo. I'm a GI doctor at the Center for Neurointestinal Health, the GI unit at Massachusetts General Hospital, Harvard Medical School in Boston. And today I'll be talking to you about nausea and vomiting with some insights into treatments. As a definition of nausea, people often describe it as an unpleasant, painless sensation that frequently, but not always, occurs before vomiting. Epigastric discomfort with the urge to vomit or changes in the autonomic nervous system, a nervous system that controls various organs in our body that can be characterized as dominated by heavy sympathetic load, which means nerve endings which control the fight or flight symptoms. Now, evolutionarily, nausea is thought to be this early warning body system, but it's evolved to occur frequently when we actually have acutely life-threatening events. And nausea, interestingly, is not pain. People can tell the difference between that, but it is frequently associated with that. So you can have nausea without pain and vice versa. And as we all know, nausea frequently occurs after motion sickness. So
Hello,
it's
and welcome
interesting,
back.
you know, we often associate nausea and vomiting together, but they actually are distinct events. So vomiting does not require you to be fully aware. It's a reflex that can happen, whereas nausea requires you to be consciously aware to know what's going on around you to give you nausea. So vomiting is a reflex, and nausea requires that conscious perception. You know, a lot of work has been done with vomiting because there's actually animal models to understand that, and so they have mapped out a lot of the circuits in the brain, which are actually not in the top part of the brain, but more in the old part of the brain that is hardwired with reflexes. Whereas nausea actually involves the nerve endings in the body as well as in the top portion of the brain where there's conscious perception and thinking occurring. There are neurotransmitters, which are chemicals that mediate the vomiting, and that's well known in vomiting, but completely not understood in nausea. And this is ultimately because there are animal models for vomiting, but actually because it requires conscious perception, there are no real animal models for nausea. And so only humans have been a way that you can understand what's going on with nausea in people. Ultimately, that results in that there are multiple medications called antiemetics that are good for vomiting, but they actually don't have as great efficacy in nausea. So this slide sort of shows you that there are different inputs from the heart and in the stomach. These feed through various nerves called cranial nerves, such as the vagus nerve, and as well as sympathetic and parasympathetic activity that eventually hit the vomiting center in the old part of the brain. And these are partly gated by things called the chemoreceptor trigger zone. And these are some of the hormones and neurotransmitters that are involved in that sort of stuff. And these filter through the parts of the old brain and eventually reach the cortex, the thinking part of the brain, where we can establish feelings about it, such as discomfort, whether there's anxiety associated with it, other sorts of things mediated by these parts of the brain. As we all know, there's the inner ear that if you get motion sickness or you get spin yourself around in rapid circles, that can also cause nausea and motion sickness, and that feeds from the inner ear to this portion of the reflexive area of the old part of the brain. Eventually, these things all go through an area called the nucleus tractus solitarius, which is the main gateway relay center to the brain for all these types of signals. Now, we did some interesting work to try to understand what's going on with nausea, because again, there are no great animal models. And so we were trying to figure out what parts of the brain are actually involved when you get nausea in human beings. And we were lucky to be the first to report taking human people that are motion sickness prone, subjecting them to this visual stimuli of alternating black and white stripes, sort of like what you would see in an amusement park ride, but sitting inside an MRI scanner. And as we started to make them nauseous inside the MRI scanner, not to the point that they were going to puke or vomit, we started to see areas of the brain light up. And these areas, such as the amygdala, putamen, and dorsal pons and locus coeruleus, these are sort of relay areas that are now starting to light up when you're starting to feel nausea coming on. And these are related to awareness centers in the brain, or almost the fight or flight areas in the brain. So it's telling you something is going on that's not right. Then when you actually do get nausea, other areas light up, such as the ACC, the anterior cingulate cortex, the insula, and the medial insula. And these are areas that start processing the sensation of nausea and telling you that, boy, this does not feel good. I think this is a bad sensation, and I might be feeling some extreme discomfort. And interestingly enough, these are the same areas that light up when you have pain. And so that even though nausea is not pain, we're starting to see this sort of circuitry that occurs in the brain when you get nausea that completely overlap with what is activated in the brain when a person has pain. Two distinct symptoms, but similar overlap of brain activity. This is important meaning because ultimately this might mean that some of the treatments that we have for nausea may not be just purely based on trying to decrease the vomiting, but maybe have overlap with the same medications that we might use for pain to change how the brain perceives the nausea. Because remember, nausea can only happen if you're awake and can perceive that sensation. Another interesting thing that we did was we took people who had chronic nausea, and we noticed over time, if you have chronic nausea, there are literally changes in the way your brain is wired after chronic exposure to nausea. And that also happens with chronic pain. There are changes that occur in your brain to the wiring that occurs when you have chronic pain. And in this case, this particular wiring tract between the front part of the brain, the anterior insula, and then the visual part of the area is altered in terms of some areas of the circuits compared to people that are less susceptible to motion sickness. So ultimately, we have here this path work that we've sort of mapped out in the brain that overlaps the pathways that are activated when you have a pain, so that nausea activates similar pathways that pain activates in the brain. And this can occur over time in chronic people, and that these give also feedback eventually to the vagus nerve and the sympathetic and parasympathetic system to different things that you can see in sweating, increased heart rate, stomach activation or function. Now, there are many ways that you can get nausea into the body. You can get it from the periphery below the brain. There can be mechanical or chemical irritants, like if you eat something bad or something's going on in your body that's not right, that can feed into the brainstem, giving you nausea. There are blood agents that, if you take a medication that may give you nausea, or chemotherapy. Motion sickness through the inner ear can cause nausea, and that feeds into this brainstem, the old part of the brain that eventually processes and relays it to the cerebral cortex, the thinking part of the brain, where with the nausea you can layer things like pain, emotion, and such. So as a result, we have a better understanding of nausea now in human beings, where there's a central nervous system part of the brain that figures out where the nausea, what the nausea sensation is, and attaches to it emotional response to that. In addition, we have nerve endings that course through the body, through the gut, and through other nerve endings such as the heart and lungs, and also the body bloodstream, which tells what's going on with the body. And if there's not something right, it will feed that signal eventually through this peripheral nervous system to the brain to tell you something's going on. Now, these can be modified through the sympathetic and parasympathetic system. This is an autonomic nervous system that sort of steps on the gas or slows things down in the body in response to something that may be going on. But this all leads to the idea that when patients have nausea, it's due to them crossing a certain threshold, where above that threshold, they have nausea, and below it, they do not. But that threshold can be dynamic. And so that in some patients, that threshold can be lower, making them more nauseous. In other people who don't get motion sickness at all, that threshold can be very high. And so ultimately, when we think about how to treat nausea, we can think about how are we going to change the dynamic threshold, either through medications or other sorts of things, to change how we think about that nausogenic stimulus and how the body ultimately will respond to that. And also from what we've learned, the nausea circuitries are similar to the pain circuitries within the brain. And so that gives us further ideas about how we can treat people who have chronic nausea. Now, when we talk about nausea, we oftentimes look at the evaluation. We ask a lot of things about the history. What happened? Did you have anything that occurred in your childhood that may give you increased nausea? A history of eating disorders? Do you get nausea all the time or early in the morning, or does it wake you up from sleep? How well do you sleep? And oftentimes people get nauseous when they have meals or when even with the smell of food. So all these can trigger nausea and may have relationships with pain, emotion, or memory. Sometimes sadness can give us nausea. Oftentimes we ask questions about medications because a lot of different medications can give nausea or vomiting. One of the common ones, an antibiotic called erythromycin, actually stimulates the gut, and that can cause nausea. And oftentimes interactions with different drugs, polypharmacy can give nausea. And certainly there are interesting drugs, narcotics and marijuana that can either make nausea worse or marijuana can actually make nausea better. Now, the doctors, because nausea can be caused from so many different things, the doctors usually do a broad search to make sure there's not anything life-threatening, such as checking your blood salts with electrolytes and checking to see about diabetes, thyroid disease, and other sorts of things. Then we try to check the gut with x-rays and with endoscopy to make sure there's no blockage and make sure there's nothing going on in the brain. One of the areas that will interpret the nausea with a CT scan if it's severe, or if there's changes or damage to the nerve endings that relay all the signals from the body up to the brain. We may also check the gut motility, because sometimes an abnormality in gut motility may cause nausea or indicate there's damage to the nerve endings in the gut, which may precipitate nausea. And certainly things like anxiety and depression can make nausea worse. So this list is a few things that we'd like to rule out for chronic nausea, things like blockage of the guts, irritation or inflammation that can be caused by infection or different types of medications or other sorts of inflammation or other body structures. Certainly, certain medications such as chemotherapy can cause nausea, or impaired gut motility, which means how stuff moves from one end to the other in the gut. Because if the gut has problems with moving stuff, the nerve endings can be dysfunctional, which can lead to sensory problems such as nausea. And ultimately, there is a criteria for nausea called functional idiopathic nausea. That's when there's bothersome nausea at least several times a week. That's associated with vomiting. It has to occur without any abnormalities, structural by endoscopy. It has to be for 3 months, for at least 6 months. And that is really a person that has chronic nausea all the time, and it can overlap with a number of other gut diagnoses. Now, the main classes for treating nausea and vomiting are the antiemetics, drugs that actually reduce vomiting, but to a lesser extent, nausea. And so these are plentiful. There's a lot of different drugs out there, but interestingly enough, they've been well targeted towards decreasing vomiting, but have less been successful for nausea. Prokinetic agents, medications that accelerate gastric emptying, might decrease nausea a little bit, but if you push the gut too hard, it may actually induce nausea. And then this concept of sensory modulators. Drugs, now that we understand that there's activation of circuits within the brain that are similar to pain, can we change the threshold within the brain and maybe even within the body of what the threshold will be for a stimulus to induce nausea? And maybe we could increase that threshold in patients where it may have been pushed artificially low, that may have given patients more nauseous symptoms. So some of these medications are listed here. They're fairly common, such as meclizine, promethazine. There are scopolamine patches and other things to push the gut and change some of the nerve endings. Common one is serotonin modulation, ondansetron, and neurokinin, such as apripitant, and certainly the marijuana-like medications called cannabinoids. Benzodiazepines help with nausea and with vomiting, because by decreasing the awareness of the brain with a benzodiazepine, you can actually decrease the nausea. But a lot of these medications work well with vomiting, but don't work well with nausea. And oftentimes, if you sedate the patient, make them less aware, make them go to sleep, it will reduce the nausea and may even reduce the vomiting. So really, what we learned from some of the brain work is that patients with chronic nausea may have changes to their brain similar to people who have chronic pain. And maybe we can use medications to change that process, such as tricyclic antidepressants. These are medications that are chronically used for pain, but they change the way the brain interprets signals, and as well as changing the way the gut interprets signals. And maybe that can be used to decrease nausea as well. And there are different types of agents, tricyclic antidepressants, anti-epileptic agents such as gabapentin and topiramate, which has less GI side effects, and maybe even some antipsychotics which affect dopamine and serotonin, like olanzapine, which has also been used for anxiety and depression. Now, nausea obviously affects one's appetite. And so stimulation of meals or meal composition can cause fears of eating and ultimately loss of weight. And so things such as cognitive behavioral therapy can be employed, and we have to be on the lookout for this issue. If nausea causes fear of eating, it can lead to significant behavioral changes and an entity called avoidant restrictive feeding intake disorder, ARFID. Also, we know there's this relationship between food and emotion and smell and memory. And ginger has ways of sort of relaxing the gut that can help with nausea. So there's actually a whole host of alternative treatments. Acupuncture, by pressing on your wrist, there is an acupuncture point that may decrease nausea and vomiting. And along those lines, there may be nerve stimulators that affect the nerve ending, the vagus nerve, which mediates a lot of the gut sensations, upper gut sensations in nausea and vomiting. I mentioned cognitive behavioral therapy, mindful meditation, and hypnosis are ways of altering the brain in terms of trying to control nausea symptoms by decreasing that or changing that dynamic threshold for nausea. So in summary, nausea vomiting may be elicited by stimulation of several sites in the brain as well as in the body nervous system. There's many different things that can cause chronic symptoms of nausea and vomiting, including gut motor and sensory disorder issues. Diagnostic testing, such as endoscopy, is important, but also history is very important. And there are a number of medications which are good for nausea, good for vomiting, such as antiemetics and prokinetics, but I think in evolving areas, this change of trying to improve the threshold of nausea, and that can be done with neuromodulators. Thank you very much.
Hello, my name is Trisha Bundy, and I'm here to share a little bit about my patient journey with gastroparesis. But before I share, I did want to thank IFFGD for all that they're doing to help raise awareness and increase research for gastroparesis and other GI disorders. I also want you to remember that this is my personal journey. Other people's experiences, reasons for gastroparesis, symptoms, treatments, outcomes will all vary depending on the person. So prior to becoming ill, I was a semi-normal person. I say semi-normal because I don't know that anybody is completely normal. But I was a scholar athlete in high school, went to college, married my husband as soon as I got out of college, started my dream career, which was teaching elementary students. And then, of course, I was an active teacher, but then became a very active mother as well as my children came along. However, in February of 2013, everything changed dramatically and unexpectedly. I went to bed that evening, just a couple days past my 35th birthday, after having a normal meal with my family and getting my kids ready for bed. I say normal meal because I haven't been able to have a normal meal since then, and it's been over 8.5 years now. I went to bed that evening, woke up around 1 o'clock in the morning, severely nauseated, cold sweats, vomiting, and didn't know what was going on. Severe, excruciating abdominal pain. This went on for a few days, and at first I thought, oh, okay, I caught the bug that's going around at the school or that my kids might have been carrying. But as I didn't get better, I started seeking out help with my doctor. My family doctor at first thought, okay, well, maybe this is diverticulitis. Or then when the pain continued and severity increased after trying to eat, then, oh, well, it might be appendicitis. You might need to go to the ER. So I was going back and forth with him. And then later in the month, I found myself at the ER numerous times in my local ER getting fluids for my hydration because I was unable to urinate anymore, and got to the point where I eventually became impacted, which was awful in itself. But then you add the fact that the doctors and nurses, some of them were blaming me in a way, saying that, hey, it's my fault that I wasn't getting enough fluids in. There's a way I could have fixed that, not realizing or taking in to affect how hard I really was trying and just unable to keep anything at all down. So that's when my disbelief and search for medical care began. I kept seeing my doctor for a while, and then after a month of not getting anywhere with my local ER, ER or local doctors, I started looking outside of my town. And I was driving 45 minutes one way to go see a GI in a nearby city, where he ran numerous tests and labs, colonoscopy, endoscopy, having gone up literally all the way to the doctor's office to prepare for this test, which led to no answers again. Eventually, he threw up his hands, wasn't sure what to do, so he sent me to my gynecologist, who ran tests to see if it was anything maybe female. And once again, there were no answers, but he thought it was very kind to remind me of how losing weight was looking good on me. Of course, that's not what I wanted to hear when losing weight was the fact of not being able to keep anything down. And I was feeling absolutely awful day in and day out. I was also sent to a urologist who searched and did a cystoscopy looking for possible kidney stones. Of course, that came back negative as well. Then he was ready to send me to get a laparoscopic, diagnostic laparoscopy, but that never came, as I ended up being hospitalized before we ever got to that point. As you might guess, this left me feeling very lost, misunderstood, disbelieved. I was trying everything on my end, but no matter what I did, I just kept getting worse, getting nowhere, and kind of felt like I was being tossed around. I was struggling to keep up with my responsibilities as a mother, wife, and teacher. Finally, months later, after continuing and missing tons of work, not being able to participate in the life of my kids, missing out on their school events and their ball games, my family had had enough. I was trying to get ready. I was getting up earlier in the mornings because I knew I was going to have vomiting to deal with. So one morning, getting ready for work, after spending an hour or so vomiting after trying to drink a little something just to give me some nourishment to get through the day with my students, my husband said, "You're not going to work." Instead, he took me an hour and a half to a university hospital where my family met us there. And when I was there, they gave me fluids because I was definitely dehydrated. And then they were ready to discharge me, stating that, hey, it might be just stress. Well, we knew that that was not the case. I mean, I was stressed, of course. I couldn't keep anything down. I couldn't be a mother like I wanted. I couldn't be the teacher that I wanted. But that was not the cause of all this. However, my family urged him to rethink it. He had me try to eat a cracker and a little bit of juice, and I was unable to hold that down as well. So after going through the heaving and vomiting that resulted, he finally decided that he would admit me. That's when things started to turn around as far as finding some medical help to at least that I could depend on. I had an absolutely wonderful hospitalist. He spent the week with me trying to figure out what was going on, to find some kind of treatment. We tried multiple medications. One of them at the end of the week was one I had been warned of at the beginning of the week from him, which was Raglan. My body did not do well with that. But we went home and I spent a week trying to get by on just a liquid diet, which was literally sipping Gatorade throughout the day in small sips. However, at the end of the week, that was a no-go. I was not able to keep enough down. I was not going to the bathroom. And I had to be readmitted, where they decided that a feeding tube would be the next step for me. The feeding tube gave me a chance to be able to vent my stomach and feed into my intestines. This was not an easy decision. I was very confused going into it because there was no one I knew that had feeding tubes and nothing online that I could find about it or about gastroparesis. It took a while, but we finally figured out that my rate would be around 35 to 45. And here, over 8 years later, I'm still in that range and multiple tries with different formulas. My GI care since then has been with that same system, even though my GI had changed. I have an excellent one now that I definitely depend and trust. Some of the medical tests that I've been through, you can see would be listed here. A lot of the common ones that you're probably familiar with. The strangest one was probably the defecography. If you know anything about digestive illnesses and about the diagnostic test for them, they are not fun. They seem to increase your symptoms and make you feel a lot worse, at least short term, while trying to figure out, hey, what could be the cause or treatment. as you can see, I couldn't handle a few ounces of liquid. And in that top picture, I had to get down that whole bottle. In the bottom right picture, you can see that was when I got down to my lowest weight, was on a feeding tube then, as well as getting IV hydration at home. But my weight kept plummeting because I could not get any nutrition in. Medical surgeries. In 2013, I had a GJ feeding tube placed. I still use that and depend on that for nutrition. Back and forth for pelvic sessions multiple times a week, all with for a few months, all within about an hour and a half drive. Dilations for my esophagus that did not want to relax. Had gallbladder removal due to the amount of weight loss and the speed, how fast it occurred, and not in a healthy fashion. 2016, had my colon removed and an ileostomy placed. One of the toughest decisions I've made, but definitely one I do not regret. Picks and ports were tried for hydration. But if you know anything about picks and ports, you carry the risk of infections. And some reason or another, my body seemed to continue to get infections over those 4 years. So now I get peripherals when needed for outpatient fluids. Iron infusions for being anemic now, iron deficient anemic, and hospital visits and inpatient stays became normal for me for the first numerous years. In fact, this past year was the first year I made it without an actual hospitalization. Most of the symptoms I've already discussed. One that I didn't mention was I have a lot of like the muscle pain, probably from the lack of nutrition that I need, the bloating, the mental fog is very bad. And you can see some of my diagnoses, one being that the gastroparesis is idiopathic, meaning we don't know a cause for it, but it is possible there could have been a post-bowel part to it. And then you can see in the pictures, the heating pad, which is about the only thing that works for regular pain relief, how it is sitting at tables while everybody else is eating, and holidays are very similar, and the difference of the food. Nausea treatment. You can see nausea medicines as well as other medicines are a lot of trial and error. And a lot of these might have worked for a little while. Some did not work at all. There were a couple that actually made me feel worse, but that doesn't mean that it won't work for others. A lot of times what works for one person does not work the same for another person. And I also listed a few over-the-counter type things. The most interesting one that actually does help for me is that smelling the alcohol pads when I get to the point of heaving. That kind of helps calm it down. I don't know why. And then last, the self-awareness and acceptance. Mental health can definitely be impacted when you are living with a chronic illness. It's not something that is expected, but when your life is flipped upside down and you have to give up a lot of things that you were doing, when you have to resign from a career that you loved, you miss out on things with your family, they go on vacations without you, it starts to wear you down, not to mention the looks and thoughts that you receive from other people and doctors. But coming to the realization that, hey, it's okay if can't do what I used to do. I have to be able to accept my limitations, whether that means my feeding tube, enjoying small different activities with my family, even riding a scooter to be able to participate. That's okay. And then giving myself the grace when I can't, and then continuing to keep my faith and trust in God that I will survive the bad days just like I have already, that eventually there will be better days ahead. Thank you.
Hello and welcome back. We hope you enjoyed that session with Dr. Brad Quo and Trisha Bundy on nausea and vomiting. We have some discussion points here, and with me today are Dr. Bill Chey from the University of Michigan and Dr. Lin Chang from UCLA. I am Ceciel Rooker, the President and Executive Director for IFFGD. So I want to start with Trisha's story because that was very moving for me. And she talked about waking up one morning with these severe nausea and vomiting episodes. How common is that with gastroparesis? How often do you see that in your patients? Is that normal for someone with gastroparesis?
It's unusual. I mean, the most common causes of gastroparesis are usually tied to chronic diseases like diabetes, for example. But we're increasingly learning that an important cause for gastroparesis are acute infections. Now, this story is not typical of that, but it might provide an explanation. For example, if there was some exposure to a pathogen, a bacteria, a virus, a parasite, that can actually, the vast majority of the time, the symptoms will quickly resolve. People will develop nausea, vomiting, abdominal pain, diarrhea that goes away within a period of 24, 48, maybe 72 hours. But what we're learning is that somewhere between 7 and 15% of individuals with an acute infection will go on to develop more chronic symptoms. Now, I don't know if that's the explanation for a case like this, but it's one of the only things that I can think of that might provide an explanation.
Wow. And she also ended up with nutritional support on a feeding tube. And how common is that for people with gastroparesis? Do you see that happening a lot in your practice of having to move them into some nutritional support?
Yeah, it's less common. You know, of course, we don't have great treatments for gastroparesis. And, you know, we heard from Dr. Camilleri, fortunately, there's a lot more treatments that are being developed for that. But currently, we don't really have that much. And so it's a lot of symptomatic management. But usually you have to think about the patient's nutritional status. And when it's very severe and they can't keep up a good nutritional status, sometimes they will require a feeding tube. If they can eat still orally, you want to do that and maintain that. But this is obviously much more of a severe situation, but her overall health is really important.
Absolutely. So obviously with Trisha, she woke up, she was violently ill, and she went to see her healthcare provider, which is, you know, obviously great course of action for her. But what about others? Maybe with a less dramatic case, maybe a milder case of gastroparesis, or someone who has nausea and vomiting. At what point should they consider going to see their healthcare provider?
You know, occasionally people will get food poisoning or a traveler's illness that can cause some vomiting. And certainly if somebody has a clearly identifiable source for the symptoms, waiting a day or even several days is perfectly fine. But vomiting is actually a special symptom. It's what we call a warning sign or alarm feature. And when vomiting extends certainly beyond probably 5 to 7 days, it's definitely time to go see your doctor. You'll want to get some testing done to make sure that your body chemistry is remaining intact. You know, you can imagine that if you're vomiting for days on end, that can easily mess with varying levels of chemicals like sodium, potassium, chloride, etc. And that can become dangerous if it becomes severely out of whack. In addition to that, doing an endoscopy is also going to be important for an individual that has persistent vomiting to make sure there's not a structural explanation or something that you can identify that might allow you to choose a more precise way to treat the patient in hand. So a day or two with a clearly identifiable source, stay at home, drink lots of fluids as much as you can tolerate, and give it a little time. But really, more than 5 to 7 days, you really need to go in and see your doctor.
Okay. I think the other important point to make here, although it's a complex discussion, is really differentiating of whether or not the delayed emptying of the stomach is really truly the cause of the symptoms. If it's severely delayed, it does correlate with having more severe nausea and then having vomiting. But we do see patients with functional dyspepsia where they have this upper gut discomfort, burning or pain, and they may, about 25–30% may have very mild delay in emptying. Nausea is not that predominant of a cause. And in those situations, really speeding up the gastric emptying, the stomach emptying may not be the treatment that's going to improve their symptoms, because it's not usually associated with symptoms. So that's something to think about and differentiate, but I know that's a longer discussion.
Right, absolutely. And one you should definitely be having with your healthcare provider. Like Bill said, you know, vomiting is not normal. And so therefore, if you don't know why,
this is happening to you, make sure that you go see your healthcare provider to find out why that might be happening. So this was a great introduction to nausea and vomiting by Dr. Brad Quo, and a wonderful patient story from Trisha Bundy. Next, we're gonna talk with about CVS and CHH, which is kind of a new thing on the horizon. And Lynn?
So we are going to hear from a wonderful speaker, Dr. Thangam Venkatesan. She's a professor of medicine. She was at Medical College of Wisconsin. She recently relocated to Ohio, and she really is an expert in cyclic vomiting syndrome, as well as cannabinoid hyperemesis syndrome, and that's what she's going to speak about. And then after, we're going to have a patient talk about cyclic vomiting syndrome, and that's James O'Reilly. So we'll hear his story.
Good morning. Thank you for having me today. And I would like to thank the IFFGD for addressing this really important issue. I will be talking to you today about cyclic vomiting syndrome and cannabinoid hyperemesis syndrome, what a physician should know. These are my disclosures. Cyclic vomiting syndrome has actually been around for several years, and in fact, centuries. This is one of the first few reports of CVS by a pediatrician. And this was first reported by this doctor by name Samuel G, who said that there were 14 children who had fitful or recurrent vomiting. These reports first appeared in the St. Bart's Hospital Reports Journal in 1882. It is also curious that there are several important prominent persons who had CVS, and CVS can actually afflict patients of all ages and socioeconomic strata. This is a picture of Charles Darwin, and this is actually a letter that he wrote to some officers, and he apparently was going to host some of these people, but he was unable to even come down to dinner because he had this violent episode of vomiting that lasted. And so this was a letter that he wrote to these 3 officers from the Beagle. And so CVS can really affect a lot of people. Why is CVS important? Now, CVS is common. Even though it's thought to be rare, it is mostly because it's either underdiagnosed or misdiagnosed. The prevalence of CVS in adults, based on a population-based study, is around 2%. The prevalence in children is also similar. CVS is also very expensive. The total cost of CVS is about $400 million from just inpatient hospitalizations over 2 years. And this was done based on what we call an NIS database, which looks at a national database of inpatient hospitalizations. And so you can clearly tell that there is a huge impact due to CVS. What about diagnosing CVS? Unfortunately, CVS does not have any biomarkers or blood tests to diagnose it, and we rely on something called the Rome criteria. So we have had 2 iterations of the Rome criteria. We now have what is called the Rome 4 criteria, which is a set of clinical criteria to diagnose CVS. So essentially, if you have stereotypical episodes of vomiting, which are acute in onset, lasting less than a week, and you have 3 or more discrete episodes in the prior year, and you are either completely normal in between episodes or have mild symptoms, you could have CVS. Obviously, your physician would conduct a few tests, such as like an upper endoscopy or a CT scan, to make sure that there are no other GI conditions that could be causing the vomiting. And if these criteria are fulfilled for the last 12 months with symptom onset at least 6 months before diagnosis, then one can establish this diagnosis of CVS. Again, there are some minor differences between Rome 3 and Rome 4 criteria that are not particularly important, but it is important to note that patients with CVS can have mild symptoms in between episodes. And now moving on to the clinical features. The clinical features are very characteristic. In general, CVS consists of 4 phases that have been characterized by Dr. Fleischer, who is sort of like the grandfather of CVS. You have the interepisodic phase where patients are typically either in normal health or can have mild symptoms. You have the prodromal phase where patients can experience multiple symptoms such as nausea, abdominal pain, abdominal pain, diarrhea, a sense of an impending sense of doom, etc. This is then followed by the emetic phase, where patients will have nausea, vomiting, retching, and multiple autonomic symptoms such as diarrhea. Now, this emetic phase can last from a few hours to many days in patients and can be quite variable. And then you have the recovery phase. The importance of knowing these various phases is that abortive medications can be administered during the prodromal phase to try and abort or stop an episode. What about hot showers? The hot shower bathing pattern is something that is talked about a lot with regards to CVS and cannabis use. Essentially, patients with CVS will take multiple hot showers or baths during a CVS episode. And sometimes there are some patients who can even run out of hot water and check themselves into a hotel to have ready access to hot water. While the hot water bathing pattern has been associated very strongly with cannabis use, it's important to note that almost half the patients of CVS without cannabis also will report this hot water bathing pattern. What about the management of CVS? The management of CVS we finally published the guidelines on the management of CVS in adults last year. And so essentially, once a diagnosis of CVS is made, a physician should try and help the patient identify and avoid triggers. Good sleep hygiene is important. Stress management is also important. Patients with CVS can have several comorbid conditions such as anxiety or depression, cannabis use, autonomic dysfunction, and migraine. And these also need to be treated, and referrals need to be made. And one needs to assess the severity of CVS before determining what kind of treatment the patient needs. And essentially, this is an arbitrary definition of the severity of CVS. And in general, mild CVS is noted when patients have less than 4 episodes a year, when the episodes are very brief, lasting less than 2 days. There's a quick recovery from episodes, and patients in general have no ED visits or hospitalizations. And CVS is considered as moderate to severe when there are multiple episodes or greater than 4 episodes a year. The episodes generally tend to be longer, and there's a long recovery from episodes, and there are multiple ED visits and hospitalizations. In general, abortive treatment is offered to all patients. Abortive treatment generally consists of triptans or intranasal sumatriptan, antiemetics like ondansetron, phenothiazine, and antihistaminics. And in addition to abortive treatment, prophylactic therapy should be offered to patients with moderate to severe CVS. Now, this is a consensus of the recommendations for the treatment of CVS. In general, if you have moderate to severe CVS, your physician should be prescribing or offering you medications like tricyclic antidepressants or amitriptyline, which is considered first-line prophylactic medication. Unfortunately, there are no randomized controlled trials in CVS, and the quality of evidence is low, but be as it may, this is effective therapy. Other alternative medications for CVS include topiramate as prophylaxis and also aprepitant. Aprepitant or Emin is a newer medication and can be used for both prophylaxis and aborting CVS episodes. However, the cost can be quite prohibitive, as many insurance companies may not cover this. There are other anti-epileptic agents such as zonisamide and such that can be offered to patients. There are mitochondrial supplements, including CoQ10 and riboflavin as well, which can be used. And as I mentioned earlier, the abortive medications such as sumatriptan or intranasally is very helpful. I think most people would use ondansetron, and then aprepitant is also a newer medication that can be used to abort symptoms of a CVS episode. Very often, we will have patients take all of these medications together. It is also very important that physicians screen and treat for comorbid conditions like anxiety and depression, migraine headaches, sleep disorders, autonomic dysfunction, and substance use. And finally, a note about other techniques. Complementary therapies like meditation, relaxation, and biofeedback can be very helpful, particularly with stress management and improving the overall quality of life of CVS patients. And one pointer here that it is very, very important to take the rescue medications as early as possible in a CVS episode to abort symptoms. Now, switching gears a little bit, what about cannabis? Cannabis in CVS is very common, and almost 40% of patients with cyclic vomiting syndrome use cannabis. And so I think we need to discuss this a little bit. What about cannabinoid hyperemesis syndrome? CHS is a condition that is similar to CVS. So it is characterized for the same stereotypical episodic vomiting that we see in CVS. However, there is an association with prolonged excessive cannabis use, and there should be relief of vomiting episodes by sustained cessation of cannabis use. And so while the Rome criteria doesn't quite define what sustained cessation means, most experts would recommend that you need to be off cannabis for at least 6 months to a year to see if there is any change in your symptoms. Again, CHS can be associated with this pathological hot water bathing behavior that we discussed. And before talking a little more about the risks and possible benefits of cannabinoids or cannabis, we need to know what are cannabinoids. So cannabinoids are compounds that have an affinity of what we call cannabinoid receptors that we have in the body. These are densely distributed in various areas in the body, including the brain and the nausea and vomiting and the vomiting center in the brain. There are 3 types of cannabinoids. We have phytocannabinoids and endocannabinoids and synthetic cannabinoids. Phytocannabinoids are derived from plants. Endocannabinoids are actually synthesized in humans. So we produce substances like marijuana in our body. What about phytocannabinoids? Typically, the marijuana cannabis that is consumed in the market is derived from 2 plant species, Cannabis sativa and less often Cannabis indica. And while they can contain many compounds, the most important compounds that are found or of importance are tetrahydrocannabinol or THC and cannabinoid or CBD. And I think there is a lot of interest in CBD, and the reason for that is that it is not psychoactive. So it does not give you the high that THC gives. And it also actually is not technically a cannabinoid because it acts on 5-HT1A receptors and not the cannabinoid receptors. Cannabis concentrates can be particularly harmful. The risks of physical dependence and addiction increase with exposure to high concentrations of THC. Higher concentrations of THC can actually produce anxiety, agitation, paranoia, and psychosis. And it is thought that it has a biphasic effect. So low doses of cannabis may be okay, but higher doses may result in hyperemesis. This is an important slide that I would like both patients and physicians to focus on. And this looks actually at the percentage of THC and CBD in cannabis samples that were seized by the DEA. And here you have in the 1990s. So in 1995, the concentration of THC was around 4%. And as you can see, there is a dramatic increase, and we are now at around 15%. And this is just the percentage of THC that you would see, say, in a joint. If you look at cannabis concentrate, because of the way cannabis products are produced these days, the amount of THC or the concentration of THC in these products can be very high. And it can be upwards of 70%, at times even greater than 80%. So it's really important to know what you are using and what the concentration of THC would be. For example, dabbers can inhale an entire amount in a single breath. And this delivers really large amounts of THC to the body very quickly. In contrast, the THC, as I said, in a marijuana, say joint or a cigarette, is 15%. But again, this is so much higher than what it was in the 90s. And so I think it's a very different beast that we have out there today. So we really need to know, is this good or bad, right? And what are the problems with cannabis? Unfortunately, this is a study that looks at ED-related ED-related visits, and this is related to marijuana tourism in Colorado. And so this is around the time that marijuana got legalized in Colorado. And if you look at out-of-state patients, a lot of patients actually go to Colorado, and this is part of the marijuana tourism. And so there was a significant increase in ED visits by out-of-state residents. And so I think it's important to understand this a little better. Is this because people are using more cannabis, or is it because CBS is being recognized more? Is not clear. And now we also looked at cyclic vomiting presentations following marijuana liberalization in Colorado, and the ED visits clearly increased and doubled over this time. Again, it's hard to understand if these were patients previously diagnosed with gastroparesis. Was there an increased recognition of this vomiting pattern by ED physicians who didn't really know much about CBS before marijuana came around? Or is it because of increased reporting of cannabis use by patients because it's been legalized? Again, it's probably a combination of all of these factors. And so we looked at patterns of cannabis use in patients with CBS. This was a study that we did. And as you can see, this part of the pie, around 60% of patients don't use cannabis at all. And 22% of patients, so 1 in 5 patients reported that they use cannabis more than 4 times a week. And in general, these are the chronic users or the chronic heavy users, daily or near daily cannabis use, which can be problematic. However, when you ask them about their cannabis use, the patients actually reported that it improved their symptoms. So this actually is a figure that looks at the percentage improvement in symptoms with cannabis use. And a significant proportion of patients reported that there was a reduction in vomiting episodes, severity of vomiting, abdominal pain, appetite, and some people even said that they were able to avoid ED visits and hospitalizations, and they were able to continue working and also studying. Again, it is important to note that this is a patient report. And coming back to the other study I spoke about, we did look at some of our patients. And then when we looked at patients who were cannabis users who abstained from cannabis for at least a month, there was only 1 patient who reported resolution of symptoms following cannabis cessation, but this patient actually subsequently resumed his use with higher CBD content and remained symptom-free. And so the rest of them really said that they didn't find any major improvement. But however, I think a longer follow-up is needed because the patients in the study had been off cannabis for only a month. And it's really important to be off cannabis for a longer period of time. And we looked at the role of cannabis in cyclic vomiting syndrome and CHS, and we actually looked at 105 individual cases and 25 case series. And when we looked at this is an important slide. Though these cases said that these patients had CHS, there was no significant follow-up, and there was actually a lack of detail in these studies in the literature. So I think there are some limitations. For example, if you look at how many people were followed for greater than 4 weeks following abstinence, only a small proportion of these case reports and case series had this particular follow-up. And then if you look at the number of people who actually met Rome criteria, again, I want to point out that these cases and case series were reported before the Rome criteria. And so there was only a very small proportion, 14 and 20%, who actually met diagnostic criteria for CHS. So it's really not clear if all these people who were reported as having CHS in the literature really had cannabinoid hyperemesis syndrome. And so I think it's a little difficult to know. We do not have enough good understanding. I think it's important to know that the cannabis products that are out there can be very potent. There are also studies showing that some people are genetically predisposed to the adverse effects from cannabis. And I spoke about endocannabinoids in the body. And endocannabinoids are compounds actually that are very important. They are marijuana-like substances that we produce in the body and are very important in the regulation of nausea and vomiting. So there could be an endocannabinoid deficiency. And finally, as I said, the potency of cannabis products is also a problem. So I think it is really important to keep these things in mind. There is certainly a big debate that rages about whether it's good or bad. We need more funding and research. In the meantime, the takeaway point is if you're going to use cannabis, it's probably best not to use cannabis if you have cyclic vomiting. And if you are, certainly occasional use may be okay, but near daily or chronic use is really going to be detrimental. And finally, I'd like to acknowledge all of these people. Some of these are my mentors. This is B. Lee, who is sort of the guru in pediatric CVS. Some of the other researchers who've done studies with me, and my nursing team who really take care of these patients, and it would not be possible without them to do this work that I do. And Kathleen Adams is actually the former president and founder of the Cyclic Vomiting Syndrome Association. Again, thank you for listening.
Hi, so my name is James O'Reilly. I'm 50 years old. I was born in Dublin, Ireland, and I deal with cyclic vomiting syndrome. Had it as a child. My mom would say that I would get sick to the yellow of my stomach, and that I wouldn't get better until I get all of that bile and yellow acid out of my stomach. And so I remember as a child here and there being sick, really sick at times, but didn't really pay much attention to it. Always kind of had an inner feeling that something was a little different, but that's okay. Different is good. So anyway, as a young child, then I moved to the States as an 8-year-old and didn't really get sick much then. Then when I was a teenager, and certainly when I go back to visit my cousins in Ireland, I would get sick for 2 or 3 days. Figured I just wasn't a drinker like they are, and was able to just, deal with it, and figured I'm not a drinker. So throughout high school and college, no issues. Played hockey all the time, played sports, worked outside in the heat of the golf course. None of those were really problems. Again, every now and then it would happen where I'd go out partying with friends and, feel miserable for a day or two. Then when I was 28, it started to happen. We were at a party, we were out late, got back, 5 in the morning, and woke up the next day at 2 in the afternoon and was sick for 2 days, and it was really bad. And then that kind of started it where it was happening 3-4 times a year. And again, I wasn't drinking, so I didn't think that was it. Knew something wasn't right. And probably after about 2 or 3 years of going to the ER, I try and ride it out at home. I would get very dehydrated, vomit blood because I'd rip my esophagus, dehydrated, just feeling the worst. I mean, the worst. I've shattered my elbow. That wasn't even half as bad as what I go through with cyclic vomiting syndrome. Anyway, so went to the ER a bunch of times. No one could figure it out. No tests to prove what it is. Everything was coming back negative. We still knew something wasn't right. So my ex-wife, probably after about 2 years of this, and one morning at 4 in the morning, the doctor saying, "We know what's wrong with him. He vomits. Everybody vomits." Well, that wasn't acceptable to her. She went to the office. Within 15 minutes, she found cyclic vomiting syndrome, and literally word for word, I was going through what that described. So I was probably diagnosed at around 28, 29, and went to a bunch of doctors, got that confirmed. I went out to see Dr. Fleischer in Missouri. He kind of confirmed that was it. I believe I was patient 432, if I remember correctly. Anyway, he made me feel, boy, the relief of just knowing what's wrong with you helps, because, like G.I. Joe said, knowing is half the battle. And if you know what's going on, then maybe you can deal with it a little bit more. So it got to the point where I was having anywhere from 20 episodes to 40 episodes in a year. My worst years were 38 episodes, 38 hospitalizations one year, 40 the next, and then like 38 the next after that. And so those were some tough years, needless to say. And I was able to get through all of that. And yeah, so I still tried to play hockey when I could. It wasn't, when I'm sick, I'm really sick. Like I said, ripped esophagus, Mallory Weiss tear, vomiting acid, vomiting bile. It doesn't go away until I get that stuff out of my stomach. Nothing digests. Anyway, so when I usually go to the hospital now, I walk in into the ER. James, come on in, room number 11. The IV team's been called. The pharmacy's getting the O'Reilly cocktail together. And so that really helps. It helps in the wear and tear of my body. It helps just in the recovery afterwards. Getting plenty of fluids and plenty of meds is just tremendous relief, both physically and also mentally. The comfort of the fact that I know that I can walk into a hospital, that A, they know me, and B, that they're taking me serious about this. Because I've been in many situations where doctors are telling me, oh, there's nothing wrong with you, or, you know, are you drinking? I once had a 6'4" nurse ask me if I was a heroin addict. I weigh comfortably over 250 pounds. I'm definitely not a heroin addict. So anyway, it's just a lot of misinformation out there. I'm finding that more and more of the younger doctors are certainly aware of it and have a better understanding of what's going on. I've certainly run across enough doctors, both in the ER and other doctors, telling me, oh, it's, you know, because of marijuana use, or it's because, you know, it's all in your head. Just people that either don't understand, don't want to understand. Just that I don't get. I don't understand how doctors don't want to learn more about things that people don't know about. Anyway, so for the last 22 years as an adult, I've been dealing with it. This year, I've already been in the hospital, I will say about 15 times. No, sorry, 15 episodes. I've probably written 3 or 4 of them out at home. I'm not going to do that anymore. I had one last week, and it took me 3 days after I stopped vomiting to recover. And so just get to the hospital, get the right stuff done, get the right, you know, meds in me. And then my, you know, 20 to 30 hours of vomiting then is, you know, once I get out of the hospital, I'm in great shape. I feel rested. I'm well hydrated. That definitely doesn't happen at home. It got to the point where I got a port in my chest because I just couldn't find veins in my arms anymore. That was the best thing that I've done. It's just been phenomenal. It's again, another relief. I'm certainly very, very lucky that I can go to a hospital, like I said, and walk in and they take care of me. They know me. I know all the nurses on the floors. So, you know, we've become brothers and sisters to some degree, you know, talk about family and this and that. So that is tremendous. Like I said, getting back to the illness, if I don't get that acid or that yellow bile out of my stomach, then it just continues on. I don't feel well. As for the future, I understand what I have. I think in the last couple of months, I've realized that probably the biggest part for me with cyclic vomiting syndrome is what brings it on is that if I don't eat, I'm in the swimming pool business, and it's, you know, you're just fully in gear, galloping all the time, getting stuff done in the summertime. And so I'm finding that if I skip a lunch and I don't eat until, you know, late afternoon, then the next day I tend to have episodes. And those ones aren't half as bad as some of the other ones, but I've just kind of noticed that correlation, and that's a problem. So, and then also for the daily meds I take amitriptyline. I was on a really high dose. I gained a lot of weight. I've lowered it. I've dropped maybe 15 pounds. So that's been a big help. Maybe lower it again. I'm at 50 milligrams right now. I take 1 milligram of Ativan every night just to help sleep. Again, with my shattered elbow, I have a lot of problems sleeping the last couple of years. That at least knocks me out for 5 or 6 hours, and that's a tremendous help. If I'm rested, then I'm feeling pretty good. And then I take Prevacet 30 milligrams every day just for the antacid and the acid production. And if I miss a couple of days there, I'll start to feel not well. So yeah, that's pretty much it. As far as my life goes, so I run and I own my own swimming pool construction and service company. We're up in Westchester County, north of New York City. Days can be long. The hours can be long. The stress is certainly there if you let it get to you. I don't feel stress anymore. If you have cyclic vomiting syndrome, your dirty pool isn't as important sometimes. And I also let all my clients know what I have and what I deal with. I also have some good guys that I've worked with for 15 or 20 years, 25 years, that I can depend on. And we all know my situation and we all act accordingly off of that. I have a 11-year-old son, and I can tell you that that's what gets me through every single episode, every single day. That I just want to see him on the other side of that episode. I want to see him get big. I see him to be healthy, and I want him to have a great life, and I want to be a part of it. And if it wasn't for him, certainly I probably wouldn't be here sitting here talking to you guys. It's like I said, being sick as often as I had, I can, and not that I ever would, but I can certainly understand why people would just want to get it all over with. And being as miserable as that, I feel like I'm lucky because I only get sick for 30, 40 hours, and then I'm done with it, and then I'm, back to being my normal self. Certainly I've heard tons of stories and spoken to tons of people that have it and they're nauseous for 15, 20, 30 days at a time. And I just don't know how they do that. I get it anyway. So unfortunately, over the years, I've heard of some people that just didn't want to deal with it anymore, and they took the that way out. But you got to be strong, got to hang in there. I got to say, and I know what a miserable day's all about, and today's not one of them. And that's how I go. That's just how I get through it all. Tomorrow's gonna be better, no doubt about it. If I am sick, and if today's a great day. Doesn't matter what happens. Today's a great day. I've got my help. I can stand up. So it's all good on that end. But I think the biggest advice or words of encouragement are: tomorrow's another day. You'll be able to get through it. You're certainly strong enough. You've fought through it this long. There's a certain toughness in a lot of us that you can. My feeling is that I can handle anything thrown at me. If I'm dealing with this, I can handle anything else that's being thrown with me. And I think that that's just what you have to do. Today's not a good day. Tomorrow's going to be better. Got to just live in the hope and the desire that tomorrow's going to be a better day. And if you can try and figure out what triggers you, then it's going to be a better day because you can do at least something about it. And if you do get sick like I do, you start learning, and even after 22 years of this, I'm still learning what some of my triggers are, what brings it on, how it happens. So anyway, all I can say is hang in there if you're dealing with it. Someone's always got it worse. That's my feeling. And, I guess I'm just an optimist. Glass is always half full with me, that's for sure. Anyway, I hope everybody stays well and have a great day.
Hello and welcome back. Thank you for joining us today for the Norton Educational Series 30th Anniversary Edition. My name is Ceciel Rooker. I'm the President and Executive Director of IFFGD. With me today is Dr. William Chey from the University of Michigan and Dr. Lin Chang from UCLA. We have just finished a session on nausea and vomiting. And so now we've actually gone through 2 sessions, right, on nausea and vomiting. So we heard from Brad Quo earlier, which was fantastic. And then just now we finished Dr. Van Kanteson's presentation on cyclic vomiting syndrome and cannabis hypernemesis syndrome, which is a lot less familiar to people. And had a great patient story on CBS as well. So let me just start with, Dr. Van Kanteson talked about cyclic vomiting syndrome, and she talked about cannabis hypernemesis syndrome. They seem very similar, except for the cannabis part. Is there any other difference between the 2 of those?
Not really. I mean, the major distinction is the presence of chronic, oftentimes high dose cannabis use that defines the presence of cannabinoid hyperemesis syndrome. Otherwise, clinically, they can be indistinguishable. In fact, people have talked about hot showers as a mechanism by which to relieve the intense nausea that these patients experience. And while that is more common the relief with hot showers, the hot showering activity in cannabinoid hyperemesis syndrome. Patients with CVS or cyclical vomiting syndrome can also report the same behavior.
Right.
You know, a lot of times people will use cannabis to actually relieve nausea because it has at lower doses been shown to reduce nausea. But it's not necessary. So when you see a patient like that, you're in a dilemma. Do they have cannabis hyperemesis syndrome, or do they have CVS and they're just using cannabis to relieve their symptoms? But people who have cannabinoid hyperemesis syndrome really are on prolonged high doses for a long period of time, really daily use. And Dr. Venkatesan actually recommends that the way you can differentiate the two is you have to stop cannabis for at least 3 of the cycles of the episodes. So if you have them every month, you have to stop it for at least 4 months to know, does my vomiting stop because I have stopped cannabis? If it hasn't, then then it's probably CVS. So that's one way to differentiate. But otherwise, they look very similar.
And remember that cannabis is fat soluble. So it'll stay in the body for a long time, which is exactly why, Lynn made the recommendation that she did. So stopping smoking marijuana for a week or 2 is not an adequate trial to determine whether or not you'll benefit from cessation of smoking or consuming cannabis.
So we've heard a lot about functional dyspepsia and gastroparesis, CVS and CHS. What about other vomiting disorders? So I think that, honestly, there are many people that have nausea and vomiting. And what are some other things that doctors might be looking for? What are some other things to think about?
Well, one differentiation that should be made is whether this is true vomiting or is this a regurgitation, or we call it could be rumination syndrome. So vomiting is really where you have contraction of your abdominal wall muscles. You're moving, you're bending forward. It's a retching of contents coming out. And regurgitation is more what I think like babies. It's kind of this effortless movement of food and fluid up, and it comes out, you spit it out. Because there is an entity called rumination syndrome, where patients or people will eat and the food doesn't even get into the stomach, comes right back up, and they chew it, it goes back down, and they repeatedly do it. It's called rumination syndrome. And then they'll eventually, spit it out, but that's not really vomiting. But if it's not CVS, then it could be something called functional nausea and vomiting. I'm sure we're going to change the name to chronic nausea and vomiting syndrome. But instead of having these really acute episodes like cyclic vomiting syndrome, like a few times a year, well, in between these episodes, you're feeling okay. Functional nausea and vomiting is really lower intensity, but it's chronic. It's just something that you have almost daily or multiple times. And that is considered one of the functional GI disorders, but it's different than cyclic vomiting syndrome.
So that's something to talk to your healthcare provider about. If it's chronic, even if it's not at high intensity, if you're still having that, something to talk to your healthcare provider about. So we're going to go ahead and we're going to move on from nausea and vomiting and move to constipation and diarrhea, something that I know both of you guys do a lot of research on and have a great session set up for us next. Bill, do you want to introduce?
Yeah, I'd love to. So we're first going to have a discussion by,
That's right.
oh, that's the right one. Oh, great, by Dr. Lembo on physician introduction on constipation. We're next going to have the patient perspective by Aaron Slater. And then thirdly, we're going to have the physician introduction on diarrhea by Dr. Brooks Cash. And then finally, a patient perspective on diarrhea by Ann Sirota.
Hello, my name is Dr. Anthony Lembo. I'm a professor of medicine at Harvard Medical School, and I practice at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. My talk, which is part of the Nancy and Bill Norton Patient Education Series, is entitled Physician Introduction on Constipation. Chronic constipation carries a heavy burden on patients as well as society. It's estimated that 1 in 7 people suffer from chronic constipation. It affects the elderly more so than younger people, women more than men, and it's the 4th most common GI symptom prompting outpatient clinic visits, resulting in greater than 3 million outpatient clinic visits. And the estimated costs in 2013 alone ranged from $1,900 to $7,500 per year per patient. In 2011, national costs for ER visits exceeded $1.6 billion. So you can see from this information that constipation is very common. It affects a large group of the population and has a heavy toll on the medical system as far as costs. This slide shows you the worldwide prevalence of constipation. It's not only a problem in the United States, but it's a problem that affects people throughout the world, independent of their race, or their diet that they consume. As you can see, both in the United States and Canada, there's a fairly high incidence of it, but it also affects people in China, Australia, and South America, and throughout Europe as well. Now, when we think of constipation, there are many symptoms that can be comprised of that. So when a patient comes to see me and says that they complain of constipation, I have to ask them, what do you mean by that? And here's a study that was done in Canada a few years ago, where they asked people in the public, not necessarily patients, if they reported constipation, and if they said yes, what type of symptoms they experience. And this shows you that data. And you can see the most common symptom associated with constipation was straining, or hard or lumpy stools, incomplete evacuation or emptying, stools cannot be passed, abdominal fullness, infrequent stools, interestingly enough, that is less than 3 bowel movements per week, which is outside the 95% confidence interval for what a normal person would have in the United States, represented only just under 40% of people who reported themselves to be constipated. So it's not the #1 symptom when someone refers to themselves as being constipated. Now, a few years ago, the Rome Committee came up with a definition for constipation. They called it functional constipation. Other people call it chronic idiopathic constipation. And because we know that there are a number of symptoms associated with it, the Rome criteria includes a total of 6 different symptoms. And for most of them, they need to be present for at least a quarter of the bowel movements. And those include the symptoms that we just saw: straining, hard lumpy stools, sensation of incomplete evacuation, anorectal obstruction, manual maneuvers, or the infrequent stools of less than 3 bowel movements per week. And loose stools should be rarely present without laxative use, and they shouldn't be able to meet the criteria for irritable bowel syndrome, because otherwise they'd fit into the IBS with constipation category. And in order to be chronic, patients have to fulfill these symptoms for at least 3 months, with an onset of at least 6 months prior to the diagnosis. Now, when you have experienced constipation, and when it is chronic, there are a number of things that we should rule out before we consider it to be functional constipation or chronic idiopathic constipation. The slides lists out some of them. Now, most of the time it is functional or chronic idiopathic. The secondaries are less common, but these are some of the ones to consider. Now, the #1 cause is, in my experience, is medications. We see a number of different medications that are associated with constipation. We all know that narcotics or opioids can slow down the gut and invariably cause constipation. Calcium channel blockers are also very common. Calcium supplements, anticholinergics, just to go down the list, there's a number of different medications. So anybody who's on a number of medications should really look at the package insert to make sure that that's not the trigger for it. And usually it's temporally related. Less likely there be mechanical obstruction, such as a cancer or something blocking it, particularly if it's chronic. Metabolic or endocrine disorders are rare. I've listed some of them here. Neurological disorders are very commonly associated with constipation, but again, these are pretty obvious when they're present. Psychiatric disorders, people who are depressed tend to be constipated, and constipation can improve when the depression improves. Cardiovascular and pregnancy are all things to consider. But let's focus in on functional constipation because this is really the most common disorder. We think of 3 different subtypes of constipation, which are shown on the right: normal transit, slow transit, or defecatory disorder. And defecatory disorder can overlap with both normal transit and slow transit constipation. As you can see on the left-hand slide, there are a number of disorders that are associated with these subtypes. There's diminished colonic propulsion, or the way the colon contracts and moves, which is associated with slow transit constipation. In a defecatory disorder, there's inability to relax the anal sphincter and relax the pelvic floor muscles in association with bowel movements. And normal transit really overlaps the most with irritable bowel syndrome with constipation. This slide shows you some of the overlap that can exist. And we think of these 2 disorders, that is IBS with constipation and functional constipation, is really overlapping a continuum. So the more that the patient is in pain, experiencing pain frequently and regularly and associated with bowel movements, the more likely it is to be IBS with constipation. If someone has more severe constipation, the more likely it is to be functional constipation. So this slide just shows you the initial diagnosis that we do when we see someone with chronic constipation. We do a thorough medical history, physical exam, and importantly, we do a digital rectal examination. And this is really to look at the pelvic floor muscles, the way they relax when we ask someone to bear down like they're having a bowel movement. The pelvic floor should be able to relax several centimeters, and the puborectalis muscle, which is a muscle that makes the rectum go at an angle, should be able to relax as well. So that's a very helpful part of the examination. We look for alarm features, and those include weight loss, blood in the stools, or someone with a new onset of constipation over the age of 50 or 60 years, progressively worsening constipation, or family history of colorectal cancer would all be considered alarm features. And in those people, we would want to investigate further. We want to consider doing a colonoscopy, for example, to make sure that we didn't miss a cancer or a polyp or other causes for it, then treat appropriately. But if alarm features are absent, then we really want to look at lifestyle factors. So we want to look at the amount of fiber that someone's taking, the fluid intake, and physical activity, because these 3 things can really help people move their bowels better. And if they haven't been maximized, they really should before going on to the next step, which is osmotic laxative, stimulant laxative, or other medications like prosecretory or prokinetic agents. Okay, so and then on the far right, we look for secondary causes for constipation. And as we listed some of those in the previous slide, and when those are present, we'll treat those first. For example, removing the offending medication when that's present for that. So it is important to look at the subtypes of constipation as we just discussed. So when a rectal evacuation disorder is present, and that we would do either based on our digital exam, or when available, we may do some additional testing. And this would be testing of the anal rectal structure and function. Most common test would be like an anal rectal motility study, which measures the pressures on the anal sphincter and the ability to evacuate a balloon, or doing a defecography, which is an X-ray of someone having with a contrast in the rectum to see how well the rectum moves when trying to push that contrast out. And when those are abnormal, then someone may be diagnosed with the rectal evacuation or a defecatory disorder, and those patients are best treated with biofeedback therapy. And this oftentimes is done in conjunction with medications, but really it is the biofeedback therapy that can really change their long-term course. So if the anal rectal structure and function tests are normal, then we would consider doing a colon transit test, and that's to see if they have normal transit versus abnormal or slow transit constipation. And really, as you can see, that the treatments are fairly similar. For both, we would consider prosecretory agents. We also consider prokinetic agents, prescription medications, which are available through your physician. We may also be giving some stimulant, adding stimulant laxatives or even enemas. And the patients with very severe slow transit constipation. This is very rare in our practice, but it happens several times per year. They may end up having to have surgery to remove their colon because it's so refractory. The other group with normal transit, we consider it usually treating with medications. We almost never take out their colon in those cases. So in summary, constipation is a common problem that impacts patients' lives and has a significant economic impact on our health system. Functional constipation is the most common cause for constipation, but we must consider secondary causes as well. Subtypes of functional constipation include slow transit, normal transit, and defecatory disorder. And the defecatory disorder is very important to diagnose because the treatment is biofeedback therapy. Treatments in general for constipation include lifestyle modifications, diet, is particularly fiber, exercise, and fluids, as we mentioned. Laxatives can be used, including osmotic and stimulant laxatives. Prescription medications such as prosecretory and prokinetic agents are also available through your physician. And as I already mentioned, biofeedback can be helpful for people with a defecatory disorder, so we really do want to identify them when present. Thank you very much for your attention.
Hi everyone, my name is Erin and I'm going to talk about constipation, or more specifically, constipation, belly pain, and my life. It seems like every other commercial on TV is for some new medication, and the number one side effect, constipation or diarrhea. And having worked in a hospital for almost 10 years as a dietitian, I can tell you the number one topic when I visit patients, constipation or diarrhea. But what if you were born that way? If you saw my previous presentation, you know that I was born with a stomach ache. And come to my house some afternoon and my mom will tell you stories about how she chased me around the living room trying to give me medication as a 2-year-old. And how I would make her late for work almost every day because I was stuck in the bathroom. And during elementary school, we would all line up in 2 rows during bathroom break. And I would inevitably make us late for class because I was stuck in the bathroom then too. My bowels would spasm without relief, sometimes in middle school, and I would miss parts of English or math class because my belly would hurt and I just couldn't get any relief. But to be honest with you, I never thought any of this was related to constipation. Actually, I didn't really think about it at all. It was a nuisance, a disruption in my day. And even today, I don't really think about my diagnosis of IBS-C until I'm in the thick of it and constipated for over a week. I was 17 years old when I returned from a day trip to the beach with a terrible stomach ache, worse than normal. And let me pause here and say that when I was writing down my thoughts for this presentation and thinking about that time in my life, I always get a little sad. My constipation was nothing new. And again, it wasn't really even something I thought about, but this was something completely different. A stomach ache that would change my life forever. My GI problems that had kept me from class and other activities were about to turn into a 5-year period where increasingly I was no longer able to function. I ended up going to my primary care doctor 6 times that year, and I saw 2 gastroenterologists before being diagnosed with IBS-C and provided very little medical or psychological help. I went to college the next year and became increasingly withdrawn. Who could enjoy ice cream socials, college meal plans, or McDonald's at 1 a.m. when you're afraid to eat? And that's what happened to me. I would later be diagnosed with severe functional abdominal pain syndrome, later renamed centrally mediated abdominal pain syndrome, which I guess because nobody was very functional when they had it. At that time, when I was 17 years old, I was diagnosed with IBS-C, or IBS with constipation, and the only medication I was prescribed for the abdominal pain was an anticholinergic medication called Levsin. The purpose of this medication was to decrease the spasms and the pain I was feeling which of course made the constipation worse, and in turn, the abdominal pain worse. I started my career in pharmacy school, but switched to nutritional science because the pain was causing me to eat less and less. And if you are a patient or a caregiver of a patient watching this right now, you'll know that the daily pain, that besides the daily pain, the only thing worse is the social isolation of having a chronic GI disorder, which leads to this endless cycle. You have pain, you're afraid to eat, which is normally what most social situations are around. You don't want to eat, you don't want to go out with friends, you become more isolated, and the pain gets worse, and which makes you not want to eat. That was my life. I missed out on all my college experiences. I missed out on Dunkin' runs and late night cram sessions. I spent 4 years in the bathroom or curled up in bed. I was 105 pounds when I graduated with my bachelor's in nutrition, depressed and not sure if I would ever be able to hold down a job. It was in 2009, 1 month short of 5 years since that day at the beach, that I found my fourth and last gastroenterologist. I was diagnosed with functional abdominal pain syndrome and was able to break that vicious cycle. I remember very clearly starting a new medication about a week later, realizing that I was pain-free for the first time in 5 years, which of course didn't last, but it took a good amount of time to rebuild my life again. And I still have IBS-C. But now I have better tools to handle it and continue to take prescription medications, Miralax daily, and eat different types of fruits and vegetables that work best for my GI tract and my constipation. Constipation happens for a lot of reasons. Sometimes it's a side effect of medication. Sometimes, like me, you're just born that way. Whatever the cause or the treatment, it's important to listen to your body and never give up fighting for your own medical needs. Thank you for listening, and thank you, Ceciel and IFFGD, for inviting me here today.
Hi, my name is Brooks Cash. I am the Dan and Lily Sterling Professor of Medicine and Division Chief of Gastroenterology, Hepatology, and Nutrition at the University of Texas Health Science Center at Houston, at the Houston, Texas Medical Center. And it's my privilege to be able to give you an introduction today on diarrhea. Now, in terms of diarrhea, this can mean many things to many people. So what patients will typically describe as diarrhea are loose stools, or increased stool frequency, or both, or a sense of fecal urgency. It's important for clinicians to actually ask patients what they mean by the term diarrhea. And usually, as I mentioned, it implies loose or watery stool, but there are some patients who actually do equate the increase in frequency, even if they're having normal stool form, as diarrhea. And that's really not. That's something that we call pseudodiarrhea. This is a very common condition. Diarrhea is. Acute diarrhea accounts for about 180 million cases per year in the US, and chronic diarrhea is a little less known in terms of its prevalence, but it's thought to be present in about 1 to 5% of the population in developed countries. So important topics. Now, in terms of how we define diarrhea, it is based on the Bristol Stool Form Scale. I often will consider type 5 along with diarrhea. Classically, it's type 6 and type 7. This is a way that patients and clinicians can characterize the water content of stool. And it goes all the way from the classic skibbolus or rabbit pellet-like stools and hard lumpy stools, type 1 and 2. Those are constipated stools. 3 through 5 considered normal. As I mentioned, 5 can be associated with some diarrhea as well, and then 6 and 7 with diarrhea. Now, we have a couple of classifications of diarrhea, and when we talk to patients about this, and even to each other as clinicians, this really sets the tone in terms of our nomenclature. So acute diarrhea is diarrhea that lasts less than 2 weeks, and that almost always is infectious, whether it's viral or bacterial. Usually runs its course and goes away as the body fights off the infection. Persistent diarrhea is greater than 14 days, but less than 4 weeks. And then chronic diarrhea is greater than 4 weeks. Now, persistent diarrhea is most often also infectious, although non-infectious causes can certainly play a role there. And then chronic diarrhea is mostly non-infection. Non-infectious diarrhea rarely lasts more than 4 weeks. There can be some, specifically things like Giardia or Clostridium difficile. And I also had a fourth category there. This is intermittent diarrhea. This is diarrhea that comes and goes with asymptomatic intervals. This could be infection. It could also be consistent with irritable bowel syndrome with either diarrhea or a mixed IBS pattern. So a little tougher to tease out. Now, there's other ways that we can characterize diarrhea. It's not just the symptoms of increasing frequency and decreasing stool consistency, but also stool weight. And by definition, the criteria for diarrhea in terms of increasing fecal output is more than 200 grams per 24 hours. And that equates to at least 200 mLs of water per 24 hours. A very broad differential diagnosis exists for diarrhea. You know, most people want to blame their diarrhea on their diet, and sometimes that can play a role. Excessive caffeine, excessive fiber, excessive alcohol, all of those things can be associated with diarrhea. The malabsorption or maldigestion of sugars such as lactose or sucrose, as well as starches, can play a role. Maldigestion of of gluten can play a role. That's commonly seen in celiac disease. So, you know, lots of different causes. Some are very benign, some are more serious. Crohn's disease, chronic pancreatic insufficiency. So things like that. And so this is not meant to be an all-inclusive list, but these are the things that should be going through clinicians' heads and thoughts when they are confronted with a patient with chronic diarrhea. Now, I want to come back to a couple of different classifications. What I'll typically do in my practice, and I encourage my trainees to do this, is try and determine whether or not patients are having secretory diarrhea or osmotic diarrhea. Osmotic diarrhea gets better when people don't take in food. Still take in fluid, but not food. And the whole concept here is that there is an osmotic gradient. There's a solute in the gut that's trapping water or actually bringing water in and leading to the diarrhea. So if you eliminate those solutes, and an example of this would be like lactose maldigestion, or perhaps celiac disease would be another one, or maldigestion of sucrose. All of those will get broken down by bacteria in our gut, those sugars and carbohydrates and proteins. That can lead to some inflammation microscopically, but more importantly, the creation of a high osmotic gradient, which traps water, almost like a bowel prep would do. And that's why people get diarrhea with an osmotic diarrhea. Now, that's to contrast that, moving to the left of the slide, with what's called a secretory diarrhea. An example of this would be something like cholera. You can have a patient fast or starve them for a day, and they will continue to have diarrhea because they're actively secreting fluid into the GI tract. This is most commonly seen with infection and very rarely some tumors that can secrete hormones that lead to active secretion, but also ingestion of laxatives and other things. It's one of the basis of our laxative therapy for constipation. Now, another classification, which is a little bit more intuitive, would be trying to figure out whether the diarrhea is inflammatory or non-inflammatory. Non-inflammatory pretty much speaks for itself. There's an absence of blood, there's no fevers, no fecal leukocytes when we look under the microscope, which is a test that we don't do that much anymore, but not a huge urgency or feeling like patients have to go all the time. Whereas inflammatory diarrhea, there's going to be blood and mucus in the stool, fevers, a high degree of tenesmus, having that sense of having to go all the time, abdominal pain. It's usually small volume, frequent bowel movements. Dehydration is not typical with inflammatory diarrhea. And then when we take biopsies or look with an endoscopy, the lining of the colon is often inflamed or abnormal. Now, most patients with chronic diarrhea, greater than 4 weeks in duration, are going to end up having what's called functional diarrhea. Some of these patients may have irritable bowel syndrome if abdominal pain is present. Another large group of patients has this condition, functional diarrhea. And it's defined simply as loose or watery stools without abdominal pain or bothersome bloating, at least 25% of the time with defecation. And there's some criteria that are listed here in terms of how long patients should have symptoms. But this would be the majority of people who show up with chronic diarrhea. It's either irritable bowel syndrome with diarrhea or a mixed pattern of irritable bowel syndrome, diarrhea and constipation, or perhaps functional diarrhea. That being said, because of the very broad differential diagnosis of diarrhea, we do end up doing a pretty extensive diagnostic evaluation in these patients. In terms of evaluation, we absolutely want to take a good dietary history. We want to make sure that patients meet that minimal criteria for diarrhea. We want to ask them what their diarrhea symptoms are. There are some alarm features that we ask about: unintentional weight loss, a family history of gastrointestinal disease, recent travel, recent antibiotic use, physical exam that may show something. If we find those alarm features, those patients should have a more directed, more in-depth diagnostic evaluation. This is a very busy slide, but this is what the Rome Committee recommends be the part of the process with regards to diagnosing patients with chronic diarrhea. And it goes over many of the things I've just said. There are some diagnostic tests that are listed here. And these diagnostic tests are designed to look for inflammation in the GI tract, to assess for anemia, to test the thyroid function, to look for infection in the gut. There are some other tests that are listed that we may end up doing that are suggested, but not necessarily the law of the land. Most of the time, these will be normal, and we will end up treating patients empirically, which simply means that we try them on antidiarrheal agents. And usually that's will take the form of over-the-counter antidiarrheal agents, but may actually end up being prescription therapies. We may end up doing colonoscopy in patients, especially if they're older and they have new onset diarrhea. That's a good excuse for us also to accomplish their colon cancer screening. If they have any markers suggesting organic disease, then more than likely we'll end up doing a colonoscopy with biopsies as well. But this, even though it looks a bit complicated, it is a relatively simple pathway that we should follow for patients with diarrhea. Now, if we move over and talk about the treatment, there's a number of goals that we have. We want to improve stool consistency. We want to harden up the stool. That should give our patients enough time to feel that stool burden and get to a toilet with a socially acceptable venue and not have them have accidents. We want to reduce the stool frequency, and we wanted to reduce the stool weight. And there's 4 major ways that the medications that we use for diarrhea work. They either slow down gastrointestinal motility or movement. They increase absorption of solutes and fluid from the GI tract into the blood of the body. They block intestinal secretion of fluid or inflammatory mediators, and they modify enteric contents. And the example of those last would be something like probiotics or perhaps even antibiotics. So they affect the bacterial environment of the gut. And there's a long list of therapies that we can use as antidiarrheal drugs. What I've done with this list is I've highlighted the most commonly used and most widely accepted and studied therapies. Now, some of these are FDA approved therapies for diarrhea, especially in the form of irritable bowel syndrome. Some of these are over-the-counter therapies. So an example of opioid receptor agonists or modulators would include something like loperamide, which is Imodium, or diphenoxylate atropine, which is Lamodal, or perhaps even eloxatiline, which is Viberzi. The last is an FDA-approved therapy for IBS with diarrhea. A 5-HT3 receptor antagonist is a serotonin type 3 antagonist. An example of that would be something like allosetron or Lotranex, another FDA-approved therapy for diarrhea. Most of the time, it's very appropriate to start with over-the-counter therapy. What I'll usually recommend my patients do, if I haven't found a cause for their diarrhea, is have them start on 1 or 2 Imodium every day, and then we'll ramp that up and try to get control of their diarrhea. If they have abdominal pain, significant bloating, then I may use another agent along the lines of the FDA-approved therapies. So let me just bring this home and summarize everything that we talked about. Diarrhea is very, very common. It has a substantial burden on patients with the condition, but also their caregivers and the healthcare system. It's important to classify and characterize the diarrhea. Is it acute or chronic? Is it persistent? Is it an osmotic versus secretory form? Is it inflammatory versus non-inflammatory? We evaluate diarrhea by taking a good history, doing a good physical exam, and then using cognitive and directed testing when appropriate. First-line therapies, diet modifications, lifestyle modifications, and over-the-counter therapies. The first two are more difficult and they're less successful, but they can help people. Changing your diet or changing your lifestyle can be very effective for diarrhea in some people, but more often than not, we will end up having to use some form of therapy. Over-the-counter therapies with anti-diarrheal drugs like loperamide or diphenoxylate atropine are very appropriate, and then escalating to FDA-approved prescription therapies such as rifaximin, which is an antibiotic, elaxadiline, or elocitron is appropriate for many patients. And those do have the best clinical trial evidence. But as I said, there's many different ways to manage this. The key is to get patients to talk to us about it and recognize that there are effective therapies for this condition. Thank you very much for your time. And I look forward to hopefully seeing you again soon and being able to share more with regards to functional gastrointestinal disorders or disorders of gut-brain interaction. Thank you.
Hi, my name is Ann Sirota, and I live in the Los Angeles, California area. One day in the summer of 1990, after going out to lunch with my family, I had a sudden urge to go to the bathroom. From that began my 30-year journey with irritable bowel syndrome and diarrhea. At that time, I had had several different issues with my GI for the previous 17 years, but it wasn't major and I could live with it. It just had an occasional upset stomach, occasional diarrhea, even occasional incontinence at that time. But after that lunch in 1990, I started having diarrhea every single day, and that was unusual. So I eventually went to my doctor, who took a stool culture, which turned out to be negative mostly, but there was blood in the stool. She referred me to a gastroenterologist. The GI did all of the blood tests, testing for thyroid use, testing for infection, and eventually my first colonoscopy. All the tests, including the colonoscopy, turned out to be negative. He then diagnosed me as having irritable bowel syndrome. And he prescribed Xanax and told me it was all due to stress. He also restricted my diet. So for about 1.5 years, all I had was grilled meat, grilled chicken, rice, potatoes, bread, and an occasional coffee or Coca-Cola. I lost 20 pounds. I was eating no vegetables, no salads, no other starches, nothing that might aggravate my GI. I was starting to becoming addicted to Xanax. So I talked to my doctor about getting off of it or getting a substitute med. He would not hear of it. He basically dismissed my concern, at which point then I started to see a different doctor who helped me to get off the Xanax. But the diarrhea continued, the upset stomach continues. I had some days when I was in a lot of pain, and a couple of times I had to turn down invitations of going anywhere because I was either in pain or I was dreading having another diarrhea episode. I remember one night coming home from a late night coffee and snack with some friends that I had to stop on the way to get to a bathroom. And that happened several times, that I have to stop whatever I'm doing to make sure that I get to a bathroom on time. I started to seeing new doctors since I wasn't happy with the one I was seeing. And he weaned me, he helped me to wean myself off the Xanax, and I started taking Imodium. Again, this was the beginning of a 30-year use of Imodium every single day of my life. At the time, the Imodium was a prescription drug, so I had to get it renewed every month or so to be able to take 2 a day. The new doctor also put me on Bentyl. At that time, the generic for Bentyl was probanthine. Now it's dicyclamine, but it was a different name then, but it was Bentyl. And for a long time, I was taking 2 Imodium and 1 Bentyl every day to control the diarrhea. Finally, about a year and a half into this, I started to try alternative medicine. I saw an acupuncture, chiropractic, psychologist, homeopathic doctor. I tried everything and nothing was working. The acupuncturist referred me to an herbalist or Chinese herbalist, and I started cooking and drinking the hot teas made out of these raw herbs. It was pretty disgusting, but it actually worked better than anything else I had tried at that time. So I kept using the herbs for a while. Unfortunately, my insurance with my work changed and they were no longer covering alternative medicine practitioners. So I had to stop going to the herbalist. In during that time, I was taking, besides the Imodium, I was also taking psyllium, or I tried psyllium, Citracel, Donatal, continued restricting my diet. Once I had been on the Chinese herb, I was able to eat some vegetables and salad, but even so, I was limiting the amount. The other drugs I tried at that point, amitriptyline, Lefsin, Flagyl, Dicipramine, Welchol, Lomotil, antidepressants, Gas-X, Gaviscon, and several other supplements that are not necessarily recognized by the allopathic medicine doctors. So 1 year, I also have ectopic beats, heartbeats, so or palpitations. 1 year, my cardiologist gave me verapamil, which is a calcium channel blocker for the palpitation. And lo and behold, the verapamil really helped the IBS as well. I had normal stools and almost no diarrhea. It still had some breakthrough, but it was very rare. Unfortunately, the verapamil affected my heart in a negative way, and it slowed it down too much. And so I had to get off the verapamil. And as soon as I was off the verapamil, the diarrhea came back. I joined several support groups that taught meditation, they taught mindfulness. I went to a psychologist. I think I tried everything that was available at the time, and nothing was really changing it. The Imodium and the Bentyl controlled it, but I would still have diarrhea a lot of times. I had tried several different providers, regular GIs as well as the alternative medicine. But again, nothing really worked long-term or consistently. In 2013, I believe, I actually had a consultation with a doctor at Johns Hopkins University in Baltimore, and he prescribed Pepto-Bismol. He says, that's all I needed. Well, that obviously had not worked either. So that wasn't good enough for me. And I started seeing a naturopath. I saw the naturopath for almost a year. And she gave me lots. She did all kinds of stool testing, which are not done by in Western medicine. And she prescribed all kinds of supplements. I also went on a low FODMAP diet at the time, but those things just didn't work. I kept on having problems. I kept on having diarrhea. Finally, I heard about the Cedars-Sinai motility clinic and the work Dr. Pimentel was doing. So I was able to get an appointment with one of the doctors in the clinic. It did take 6 months to get to see him. Meanwhile, my regular GI at Cedars did a breath test and prescribed rifaximin or Cefaxan, which was now the go-to antibiotic for people who had IBS with diarrhea. And who tested positive on the breath test, which I did. And I tried to wean myself off the Imodium because it was not really working anymore. When I finally got the appointment with somebody at this motility clinic, and he had the results of the test, he prescribed rifaximin, which helped a little bit. It cut down on the the constant diarrhea I had. But my doctor also prescribed Zofran, which is not necessarily meant for IBS per se, but it's anti-nausea medicine, and it does, and one of the side effects is constipation. So the Zofran works for a while, and I was free of diarrhea for like a year and a half or so. And then the Zofran, like the Imodium before that, the Zofran stopped working. The doctor at the Cedars Clinic tried a couple of times to, we tried different things at that time. We tried digestive enzymes. We tried antihistamines. We tried, I forget all of the, specifically what we did. We tried antidepressants. I was on, at one point, I tried out 4 different antidepressants over the years. We tried antifungal medication. Nothing really worked. When after the Zofran stopped working, I started again taking Imodium every single day and an occasional Bentyl. But even that wasn't enough, and I've had breakthrough cases of diarrhea. I've had fecal incontinence. I've had stomach pains, some nausea. Nothing has really worked consistently or permanently. So where am I right now? I am on 4 medications that help to control the diarrhea: Imodium, Bentyl or dicyclamin, Ibegard, which is peppermint capsule, and immunoglobulin. I started with the immunoglobulin back in about 6-8 months ago in December, taking something called Anteragam, and that did control the diarrhea, but because it's kind of difficult to swallow, I switched to an immunoglobulin capsule. Of all those 4 medicines, I have no idea which one works and which one doesn't. But I know that if I stop taking one of them, everything comes back. All of the loose, watery diarrhea comes back. I've had fecal incontinence maybe a dozen times in the last 10 years. And this past 2 years has been worse, even worse than before. I was in an event where I was responsible to take care of an issue. And unfortunately, I wound up having to run to the bathroom and stay there for a while because I couldn't come out. The anxiety of having an accident is overwhelming at times. I've had panic attacks. I break out in a cold sweat or a hot sweat. I get chills. I feel unable to really live a normal life. It has taken over my mind and my life. I have to always watch what I eat, and now I'm back on the low-fat diet much more strictly than I was before. I'm really following it, so that also has helped. But I'm very limited in what I eat, and there's many different things I cannot eat at all. I certainly cannot have any dairy products. I cannot have garlic and onions. I cannot have a lot of different vegetables. I'm limited. I cannot have any beans. And still the same staple food that I had, that I ate 20 years ago or 30 years ago, are still the ones that are my safe foods. Grilled meat, grilled chicken, rice, potatoes. But I do eat limited vegetables and limited salads, raw food. Going out to eat is a real problem because it's not just the main food that's the problem. It's however they're cooked, what is put, the spices or flavorings that are put in the food. I have tried, besides the low FODMAP diet, I have tried low fermentation diet as well, the one from Cedars, but it almost doesn't make any difference. Some foods make things worse, but even when I'm very careful with the foods, I can have a breakthrough diarrhea episode, or I have this terrible gas pains, or this burning feeling. There's so many symptoms that go with it, but the diarrhea, which is unpredictable, erratic, uncontrollable, urgent, is really the worst of the problems. It impacts my life. It has impacted my life for 30 years now, and possibly before that, some 47 years. I have over the years, I have seen 25 or 30 providers, both gastroenterologists and alternative medicine providers, and I have tried over 50 different meds or supplements. And still the Imodium is the one that works the best.
And diarrhea. And we've had some questions from the audience that have come in on chat and some discussion that we are going to have here with Dr. Bill Chey from the University of Michigan and Dr. Lin Chang from UCLA. So to start with, we had a great question from the audience, and that is Dr. Limbo. Tony mentioned the rectal exam. And that I know is something that makes a lot of people uncomfortable. So is it really necessary? How important is it?
Yeah, I think it's potentially very important. Let me just say that to some extent, when you do it is highly variable, will depend on the provider. So for example, if you have a patient that comes in with typical constipation symptoms on the first visit, I may very well try some over-the-counter laxative therapies. And if the patient gets better, I'm not necessarily going to worry about doing a rectal exam. On the other hand, if they come back and they haven't gotten better, or if they have really severe symptoms to start, I'm probably going to want to do a rectal exam. And I think the big thing for people that are listening to understand is that this is embarrassing for you, but it's not for us at all. You know, I'll always say things like it's a little bit of a joke, but it's not. And that is that to us, a rectal exam is our bread and butter. You know, it really is something that's part and parcel of our usual physical examination. We don't think anything of it, and nor should you. Okay, don't be embarrassed about getting a rectal examination done. In fact, I would argue to you this: if you've seen a gastroenterologist multiple times for constipation or fecal incontinence and you've never gotten a rectal exam, there's something wrong there.
Which is entirely possible because
Yes.
people are doing less of it, but it is important.
Absolutely.
And it's really important, particularly because in constipation, because you're looking for a sign that the anal sphincter or the muscle and the pelvic floor muscles are not relaxing appropriately when a patient is on the toilet and pushing out. And if that's the case, they could have a functional outlet disorder, which we term dyssynergic defecation. It's not a great term for patients, but it just means there's not good relaxation of the pelvic floor to straighten out the rectum and evacuate, because the treatment's different. And the treatment is more of anal rectal biofeedback than just giving patients laxatives or other constipation medications. But I will say that many doctors who do digital rectal examinations, they check for, a mass in the rectum, the tone of the anal sphincter, but they actually don't test for the evacuation process. Actually asking a patient to push out like they're sitting on the toilet to test for that. So I think that's important. The other thing I think is really important is to explain to your patient why you're doing it and what you're going to do so that they can expect that, especially young patients. And I think that if you just pull it on them without really explaining, it could be a traumatic experience actually. So it's really important to explain to patients what you're going to do and why you're going to do it.
Right. And for those of you at home, if you are in a visit with your healthcare provider and they say they want to do a digital rectal exam, you can ask them the question, exactly why are you doing it? And can you explain to me exactly what you're going to do? And then they can tell you the steps and they'll be able to tell you, well, first of all, I'm going to ask you to bear down, or I'm going to check for a mass in your rectum, that sort of thing. So feel free to ask those questions so that you're comfortable before you actually have that exam.
Another thing too is that if you are uncomfortable, first of all, at all large medical centers, they're going to have a chaperone that accompanies the physician, male or female. But if that isn't the case in a community setting where a patient's being seen, you can ask for a chaperone if that makes you feel more comfortable. And there's absolutely nothing wrong with doing that. Don't be hesitant or shy about doing that if you want somebody else in the room just to help you to feel more comfortable.
I've had patients actually refuse that, you know, they're not comfortable doing it, even when you talk about it, and that's fine.
Absolutely. Yeah, absolutely.
Fantastic. Okay, so that's a great topic to talk about, or especially talking about constipation. So moving on to if someone has both constipation and diarrhea, how does that happen, and what is that?
Well, often patients can, well, first of all, it can't be from taking medications that they're alternating, just spontaneously. It is a sign of irritable bowel syndrome if the patient has pain and they have constipation, diarrhea, which typically Bill and I have talked about this a lot. Typically what you see is like 3 to 5 days of constipation where you have hard stools or no stool, and then you get a day or two of diarrhea. And they go into this cycle. And it's really important to know what the cycle is, and the daily, this is where daily diarrhea is helpful. But often if you can try to get on top of the constipation, treat it proactively, you can reduce the symptoms and reduce the diarrhea days, reduce the frequency and intensity, so that's good. The other thing to think about is it's called overflow, like a fecal loading. So where patients can have a lot of stool, particularly on the right side of the colon, which you can actually palpate on abdominal exam. And when you're trying to treat the constipation, the loose stool gets around the harder stool and it comes out as diarrhea. And often you have to really try to clean out their bowels. And so you could start again so that they don't have this overflow type of diarrhea. And some people will actually get an abdominal x-ray to see if there's a lot of stool, and that if that's the case, when they're having constipation diarrhea, they'll actually do more of a cleansing and then start on the treatment.
You know, there are some really cool mobile apps that are available now that can help patients to sort through this. So for example, there's a couple that allow you to take pictures of your stool on a daily basis, and then it will track the consistency and other features of your bowel movements over time. So it can help you to sort through exactly what Lynn's talked about, which is that I oftentimes talk to patients about order in the chaos. So people feel that their stools are actually really chaotic and unpredictable, but then when you actually track them over time, there's actually a pattern there. You know, they'll have those small, hard, lumpy, or no stools for several days, and then you know, diarrhea. So a couple apps to think about. One is called Dieta, D-I-E-T-A. The other one is called Carta, and those are actually both apps that allow you to track your stools over time by taking photos of it.
Fantastic, and we'll put that information in the chat for you at home. So we're going to move to our next session of the day, which is heartburn and reflux, and that will be another patient and physician combo.
So the first talk is going to be by Dr. John Pandolfino, who you all know. He's one of the moderators of this program and is the division chief of gastroenterology at Northwestern University. And he's going to speak on the physician introduction on heartburn and reflux. And then we're going to have the patient perspective on gastroesophageal reflux disease. And that's going to be given by Luis Yamashita, Jr. And then the third video is a physician introduction on eosinophilic esophagitis, and it's going to be given by Dr. Evan Dillon at the University of North Carolina in Chapel Hill, and he is really a world expert on eosinophilic esophagitis. So we're in for a real treat. And then the last video is the patient perspective on eosinophilic esophagitis, and that's going to be presented by Eric Taylor. So I hope you enjoy all of the sessions.
My name is John Pandolfino, and I'm a professor of medicine at the Feinberg School of Medicine, Northwestern University, and chief of the Division of Gastroenterology and Hepatology, Northwestern Memorial Hospital. And it's really my pleasure today to talk to you about a physician introduction to heartburn and reflux, and really what you can glean from how we approach patients who present with substernal burning in the chest, which is heartburn, and of course reflux and the various symptoms and complications that can occur with reflux. Now, the definition of GERD is considered to be a condition where you develop troublesome symptoms or complications related to reflux of gastric juice from the stomach into the esophagus and the throat. And this can actually lead to a whole heterogeneous symptom and complication profile, as you can see from this particular slide. You can present with the classic symptoms like heartburn, regurgitation, chest pain, but you can also have these other complaints like cough, laryngitis, pulmonary fibrosis, a sore throat. And then, of course, there are the extreme complications, inflammation and esophagitis, stricture, Barrett's esophagus, which is a premalignant condition, and cancer. And when you look at this slide, what I really want you to take away from this is that it would be illogical to think that we would work people up and treat people the same, regardless of what the symptoms are. We would not treat everybody. It's not one size fits all, because there are different types of disease presentations. So I'm not going to treat the patient with cough the same way I might treat the patient with heartburn. So it's just something to keep in the back of your mind. Well, what is the mechanism that drives GERD? Well, we know that we are focused on gastric acid and the gastric juice, and certainly that is an important component of this. But it is important to realize that the gastroesophageal reflux disease pathogenesis is not related to people having too much acid or making too much acid. In fact, if you look at normal people and GERD patients, they make about the same acid. There are some hypersecretory diseases, but for the most part, they have similar gastric acid profiles. Really what differentiates GERD patients from people who don't have GERD is how much of that gastric juice moves up into the esophagus and the throat. And really the things that promote that are obesity, delayed gastric emptying, increased volume, and these physiologic events that happen at the lower esophageal sphincter, which is really part of the protective barrier preventing reflux. And then, of course, once you do reflux, there are other things that help you or protect you, like saliva production and motility in the esophagus, moving the bolus and the liquid down back into the stomach. And then, of course, hiatus hernia is another important part, because this really causes a disruption of that anti-reflux protective barrier. Now, as I mentioned, though, even though GERD is not a disease of abnormal amounts of acid in the stomach, the target of our PPI, or proton pump inhibitor therapy, is really focused as a compensatory treatment and not curative. Really what we do is we just reduce the acidity of the gastric juice so that when you actually have it in your esophagus, it's not as irritating or noxious. The problem with that is that a lot of people do fail proton pump inhibitors. And the reason why they fail the proton pump inhibitors is that maybe their symptoms are not related so much to the acid as it is to the reflux of the gastric juice. Because even if you reduce the acidity of the gastric juice, the refluxate is still pretty nasty, and it certainly can still injure the throat and the lungs. The other reason why people may fail PPIs is that they actually don't have reflux. And it's really important for us to think about this, because many people come in with heartburn or chest pain, and they actually have a completely different disease state. So in the back of our mind, when people are not getting better on good, effective PPI therapy, we have to think that maybe we're barking up the wrong tree. Now, GERD can injure the esophagus, as we saw on that slide on the definition. You can see it can have various degrees. So there can be some mild injury, moderate injury, and severe, where you see these deep ulcerations all around the end of the esophagus. And then, as we mentioned, Barrett's esophagus, where although it is a premalignant lesion, the risk of cancer is low, but you really need to make sure that you follow with your doctor. Because if we diagnose Barrett's esophagus, you're not going to die of esophageal cancer, because we're going to keep an eye on you, and we're going to do surveillance endoscopy. If we ever see anything that's bad, we're going to take care of it. So really important to remember that even if you get that diagnosis, don't be disheartened, because we can really survey you and protect you from getting esophageal cancer. So what are the key messages around this? Well, I think some of the key messages here is that GERD can be associated with a lot of symptoms, but heartburn and regurgitation are usually the most common. But we have to remember that reflux can be made worse by a lot of things, like trigger foods, weight gain, bad anatomy, and physiology. But with that being said, we can actually treat these particular problems by focusing on some of these lifestyle modifications that will reduce the triggers by reducing trigger foods, reduce the gradient in terms of weight gain, and address some of the issues with bad anatomy and physiology, with maybe how we're positioned when we're sleeping and how we're eating. And that's really where we focus. The treatment is focused on the problems that are driving reflux. So we'll modify diet and encourage weight loss. We'll look at medical therapy to suppress or buffer acid. Antacids and H2 blockers, which are famotidine and ranitidine, are very effective on-demand therapies. So usually for people with mild disease, pretty erratic symptoms, maybe less than once or twice a week, those patients can get away with on-demand therapy. But if you're having symptoms every day or more than 3 times a week, it's probably reasonable to take something like a proton pump inhibitor, which is a medicine that actually can suppress acid for the entire day. And you take it once a day and it's very effective. Now, there are certainly some more aggressive approaches that would require surgery and endoscopy that could effectively treat the anti-reflux barrier and prevent you from getting reflux, where you can maybe stop your proton pump inhibitors. But as I mentioned, sometimes reflux symptoms may be caused by something other than GERD, and you should definitely see your healthcare provider if these medications or medical therapies are not working. Now, as I mentioned, antacids buffer acid in the stomach. They're predominantly on demand, just like H2 blockers. They can suppress acid and work quickly, but they're not as strong as proton pump inhibitors. So I like to use antacids for my patients who have, maybe a little bit of reflux after a dietary indiscretion. H2 blockers, which suppress acid, they don't just buffer acid like antacids, a little bit stronger than antacids. I use for people who probably have a little bit more severe symptoms. They know when they eat late, they're going to have symptoms. That's another on-demand medicine that I'll use. But if someone has pretty significant disease, that's where I use proton pump inhibitors, which are omeprazole, lansoprazole, pantoprazole, rabeprazole, dexlansoprazole, and esomeprazole. So what are proton pump inhibitors? Well, they're exactly what they say they are. They block the proton pump in the parietal cell. The parietal cell is the cell in the stomach that makes acid. And when it is activated, the proton pump can actually block that. Now, this is a little bit of a simplification of the slide because you really need to have that actual proton pump in your system about 30 to 60 minutes before it can actually block the acid pump. And it actually has to come in through the parietal cell. So once again, a very important component of this is the timing with meals. And how do they compare with H2 blockers? Well, certainly if you look at this graph, the purple color representing the H2 blockers and the yellow and the gray color representing PPIs or proton pump inhibitors, you can see that the relapse of esophagitis, meaning the inflammation, is much lower in the patients who are on the proton pump inhibitors, whether they're using a healing dose or a maintenance dose. Now, in terms of our algorithm on how we approach this, well, if we see people who are failing compliant PPI therapy, these are the patients that we do refer for further evaluation. That being said, though, we got to realize that there is a difference in the potency of some of the PPIs. So some PPIs are stronger than the others. And this is the actual hierarchy. So pantoprazole at 20 or 40 milligrams is the weakest PPI. So if you're on that particular dose and not responding, you may benefit by going to a higher potency PPI like rabeprazole or esomeprazole. So that is really the point of this particular slide. Now, as I mentioned before, PPIs work best when they're timed with your meal. They need to work or block activated pumps. So patients are instructed to take their PPIs 30 to 60 minutes before meals so it can be absorbed in the small intestine, get delivered through the blood to the parietal cell, and then within the parietal cell, it gets secreted into what we call the canaliculi, where they can actually block the acid pumps. So really important to remember that this particular timing gives you the best bang for your buck when you're trying to suppress acid with reflux disease. Now, there is one combination of omeprazole called Zegerid that can be taken on an empty stomach at night that can work very similarly to the timing with a meal because it tricks the stomach into thinking there's a meal because it has a little sodium bicarbonate. Now, it's really important too to make sure that patients follow up, or you follow up with your healthcare provider in 4 weeks, because most people will notice an improvement in their symptoms. And if they're not really improving in 4 weeks, you can use that opportunity to kind of stratify or augment them in terms of their PPI dose and try to improve their compliance and adherence to that dose. But once again, we always want you to consult with your healthcare provider if you were thinking of stopping your medications, because stopping your medications can cause complication, especially if you have chronic reflux with severe injury like erosive esophagitis, the kind of Los Angeles C&D that we saw on those slides, Barrett's esophagus, and certainly strictures. So as I mentioned, the PPIs are very effective, but they do require this delicate interplay between the timing of the meals. But, you know, all of reflux is not related to acid. And remember that even though you might improve the acid level or reduce the acid level in the gastric refluxate, this gastric refluxate still has bile and it still has digestive enzymes, and that can still injure the esophagus. Now, PPIs, although they're effective medicines, do have some things we need to consider: side effects and reactions, theoretical consequences of acid inhibition, and some drug-drug interactions, and this is some of them. The most common side effects and reactions with PPIs are headache and diarrhea, but you can pretty much see anything. If someone has a distinct symptom after they start a PPI and it goes away when they stop their PPI, then it's probably a side effect of the medicine. There are some theoretical consequences of acid inhibition that are related to potentially changing the pH in the GI tract that may lead to specific problems. And we'll talk a little bit more about this as we walk through the PPI safety issues. And then, of course, there's some drug-drug interactions where your doctor will probably make sure that you either change your medicine or alter your dosage of Dilantin, warfarin, diazepam, and clopidogrel. So once again, I think your doctor is going to be keyed in on that. Now, that being said, as I mentioned, there is a lot of anxiety regarding PPI use in the lay press, and we believe that the risk-benefit ratio is in favor of PPI therapy in patients with GERD complications, and those who have GERD documented who are unable to stop PPI therapy to continued GERD symptoms or the risk of GI bleeding. Now, PPI therapy has been associated with a risk of C. difficile or Clostridium difficile colitis, and patients should be advised. So if you do develop diarrhea, you certainly should think about this and talk to your doctor about that. PPI therapy does not need to be altered, though, in certain other indications, like people with osteoporosis or even people on some medications like clopidogrel. Once again, talking with your doctor. But in the end, long-term PPI use is considered safe, and the risks of these adverse events that are theoretical in nature and really only found in retrospective, poorly done studies, such as dementia, chronic kidney disease, bone disease, cardiovascular disease, gastrointestinal cancer, and nutrition or nutrient deficiencies, have really not been proven. And once again, we think that the risk-benefit ratio in the right patients is really highly in favor of continuing PPI. Now, in the end, when we discuss PPI safety, we still have to realize that lifestyle modifications to reduce PPI requirement is still very important, especially in patients with uncomplicated GERD, because our ultimate goal is to get you on the lowest effective dose of medication. And these recommendations would include weight loss for patients who are overweight, head of the bed elevation and avoidance of meals 2 to 3 hours prior to bedtime in people with nocturnal symptoms, and then of course smoking cessation, because this is something that we should be doing for everybody. But that being said, smoking can make reflux worse, and we should look for that. And then of course, avoidance of excess intake of caffeine, fatty foods, large meals, and acidic foods that trigger your reflux. I will tell you that I do not expect all of my patients to avoid all of these particular foods, because I don't want to destroy their quality of life by making them too focused on all the foods that can cause reflux, and they really only target the actual foods that trigger their symptoms. So in the end, this is a very global approach to reflux, focused primarily on our medical approach, and then the potential utilization and issues with utilization of PPIs, and how you can make yourself and self-manage reflux throughout your life. So thank you very much for your attention, and I hope you have a healthy meal without reflux by using these particular hints and facts that I've provided. Thank you.
Hi, my name is Luis Yamashita. I'm 39 years old, and I'm here to talk about my experience with acid reflux. A little background, I was born and raised in Brazil, São Paulo, Brazil. My mom, she's living, and most of her adult life, she has had acid reflux. So I think I get a little bit of that from her side. And, growing up, I always saw her having terrible pain. And, as part of what she had to do to fix that, she had to go through a surgery because the valve that keeps her, acid in her stomach was not functioning properly. So she had to go through surgery to fix that. And once she did that, that problem was pretty much gone. But this was almost 20 years of her having pain and having to deal with acid reflux on a daily basis. I pretty much started to experience this as well in my early 20s. I would say more severely. In my teenage years, I did have a little bit here and there. I grew up pretty much eating vegetarian, not because of any options other than I used to get really sick. So I don't know if that has to do with any of that. But my parents are, eat meat. They eat meat every day. They love to do the Brazilian, steak. We call it churrasco, and that's very popular in our country. And but for me, for some reason, I never really had a good experience with any kind of animal protein related, food. So I would say that maybe, I wonder that has something to do. Maybe my stomach is somewhat sensitive, but I never got down to, really link that to the acid reflux situation. So again, in my teenage years, I used to maybe have a little bit of heartburn. As I got close to my early 20s, it got a little worse, not bad, but I remember one day just kind of, I get very nauseous sometimes if I eat something that doesn't really go well, and it could be related to the dairy, history, or the animal protein history that I have explained. And one day I noticed that I was vomiting and it had a little bit of blood in it. And I went to the doctor, and they did an endoscopy. This was when I was about 21, I think. And they found out that I had small little ulcers in my stomach. They were gastritis. That's how they had explained to me. So I just took a little bit of omeprazole, control my diet, and over the years, it got fine. But as I got into my 30s, then my acid reflux got a little bit worse again. So as a young adult, you don't think this is anything that you need to worry about, and I just kind of let it be. Try to control it with diet, maybe avoid certain foods. Unfortunately, I like very, very spicy food, and that can be, I guess, another problem. But even though some doctors said sometimes it's not really the cause of it. But in any case, I started to have this acid reflux and heartburn pretty bad. I would say almost 3 to 4 times a week, which was bothersome and something that you just don't want to be living with, right? So I would say for about 5 years, I dealt with this situation as best as I could. And I finally decided to go see a doctor. And when I went to see a doctor, they did an endoscopy, and they found that I had a polyp on the base of my esophagus where the junction is with my stomach. And that polyp was pretty big. And it was almost to the point that was blocking about 75% of that kind of a hole where the food goes through into your stomach. And that was pretty much caused by the acid. In addition to that, because the acid was going up, sometimes coming up to your throat, to my throat, the doctor also noticed that the results of the endoscopy indicated that there was a sort of a count that indicated I was pretty close to having ENO, which is an inflammation of my esophagus. And at that time, he prescribed to me omeprazole 40 micrograms on a daily basis for 6 months, and see how that would do, and come back in 6 months to do another endoscopy. So I did do the omeprazole. It was for about 6 months, went back, did another endoscopy. That was, a good thing because it showed that my stomach polyp plus the esophagus had calmed down quite a bit, but the polyp was still there. So they actually sent me to, we are in Charleston, South Carolina. So we have a very good hospital called MUSC, And the expert, Dr. Hoffman there, she did another endoscopy as well, just to check on it and confirm that I didn't have to remove anything, that would be somewhat worrisome. So with this other endoscopy with Dr. Hoffman, she, confirmed that the polyp had gone down, and pretty much, as long as I stayed on medicine, and I could go down to omeprazole 20 at this time, I would be fine going forward. And she said, as long as you stay on your medicine, watch what you're eating, that will help you stay pretty much, in a good condition and not experience heartburn. So this has been probably 2 years to 3 years now, I want to say. And since I have stayed on the medicine, it has helped me, not experience that. And if I forget to take the medicine, or if I take the medicine for whatever reason, I had to eat right after that, in less than 30 minutes after I take my medicine, then I could sometimes experience a little bit of a heartburn. And I had a day actually that I don't know what it was. I probably forgot to take it, and it was pretty bad again. So it doesn't happen again. Maybe it will happen twice a year now. And it's just something that it's a lot more manageable than before, when I had to deal with this from, eating anything and experience that almost on a daily basis. And I feel that, staying on this medicine has really changed my lifestyle. I can enjoy going out to eat. I don't have to worry too much about what I'm going to eat. I can eat some of the things that perhaps maybe before I was a little bit more worrisome, because I knew it was going to give me heartburn. Anything fried usually did that to me. And in addition to that, I try to be more mindful about what I was eating. So in general, I try to eat healthier, not as heavy. I'm again vegetarian, so I try to eat more of steamed vegetables instead of fried vegetables. So I try to focus more on healthy options if I can find them. Of course, if you travel, sometimes it's a little harder to find what you're looking for. But because of this condition, you kind of learn, what kind of options you have. You go, for example, like we go to Outback Steakhouse, and it's a steakhouse, but they have great veggies there. So I try to stay with that kind of option. If it is something that I can ask, get a baked potato, kind of stay within a menu that makes me feel comfortable. And in addition to that, I became more conscious about eating in general. And I think that improving my eating habits also led me to become more mindful about, exercising. So I have exercised more often. And I think as a package, the eating and the exercising plus the medicine has helped me to control this and not have this as a worry that I used to have, in the past from, feeling sick and having a lot of side effects. So in general, I would say that, if anybody's experiencing any sort of heartburn, sometimes, yes, it does, it can happen to anybody, but if it is becoming more recurring in your life, I would advise, anybody to see a doctor, go get an endoscopy, look, and see what's going on, and try to address this, because I hear that your stomach and your, whole gastro, system is very sensitive. And if you get cancer or something like that, it can be really harmful. And that can be an issue for, for something that you cannot really fix. So I'm glad that I got to do this. I'm glad that I can share this story. I'm very excited that this is going out to a lot of people that perhaps will be experiencing similar, problems that I had. And hopefully this will give them the, the nudge in the right direction to have a better lifestyle. Because at the end of the day, I think what you want to do is just have a good, living experience, and not experience this kind of, side effects that can be very harmful to your body, and to the point that, sometimes it can be a pretty severe situation.
Hi, my name is Evan Della. I'm one of the adult gastroenterologists at University of North Carolina School of Medicine in North Carolina. Today, it's a pleasure to speak with you and provide a physician introduction on eosinophilic esophagitis. These are my disclosures. And for the talk today, this is the overview. I'd like to help define what is eosinophilic esophagitis and specifically talk about symptoms, the endoscopic findings, and the histology that lets us put it all together to make a diagnosis, then discuss some common EOE treatments and review the long-term approach to EOE. So before we talk about the condition, I'd like to talk about what is an eosinophil. So an eosinophil is a white blood cell, and this is a smear of all the white blood cells in the blood, and there's the eosinophil in the top right. And it's one of the kinds of white blood cells that is normally detected in low levels in the blood, and it has a main role of fighting infections. Now, importantly, we never see the eosinophils normally in the esophagus, though you can see them in other parts of the GI system. When we think about the functions of the eosinophils, here they are, the schematic, they have a central function where they not only respond to different stimulations like infections and tissue injury, but also have a role in allergy. And they can talk to other immune cells like things called T cells and mast cells, and they can secrete or release a number of factors that cause inflammation. And that's where they can lead into both a normal response and into allergic troubles. So what is eosinophilic esophagitis? Well, we have this conceptual definition that EOE represents a chronic immune-mediated esophageal disease characterized clinically by symptoms related to esophageal dysfunction and histologically by eosinophil predominant inflammation. And let me just unpack that. It's chronic, which means we don't have a cure, and it is a long-term condition that's not self-resolving right now. It's immune or antigen mediated, which means it's an allergic process in most people. On the clinical side, you have symptoms that I'm going to talk about. And then when we do an endoscopy and take biopsies to confirm a diagnosis, we can see under histology or examination under the microscope that there's a lot of eosinophils there that shouldn't be there. When we think about the clinical presentation of EOE, we think about symptoms primarily. And in adults and adolescents, dysphagia, which is the medical word for trouble swallowing, is the most common that we see. And in fact, if people have a lot of troubles with this to the point where food actually gets stuck in the esophagus and they have to go to the emergency room, more than half of the time in that situation, EOE is the cause. But it isn't just a sensation of food sticking or choking. It can be a sensation of food going down slowly or something that's subtle where people might modify the way they eat by eating slowly, avoiding certain foods, taking small bites or chewing foods to mush, or drinking lots of liquids to help clear the food from the esophagus, or even just worrying about symptoms when they go out to eat. Some people can have heartburn or even chest pain with EOE, and this is sometimes a cause of what would be refractory reflux that isn't getting better with standard antiacid treatments. And rarely in adults would you have abdominal pain, nausea, or vomiting. But in children, symptoms are quite different, and they could range from failure to thrive, to feeding intolerance, to heartburn or reflux, abdominal pain, nausea, vomiting, or regurgitation. So much more non-specific symptoms. Now, when you do have those symptoms, it tends that we need to do an endoscopy to evaluate what's going on. And this is the view of a normal esophagus on endoscopy. So we're looking down into the esophagus with a light and a camera. And you can see here, it's a very smooth, healthy pink color with lots of little fine blood vessels. And this is the normal appearance. In contrast, in EOE, there's a lot of endoscopic findings. The top left picture here is actually of a food bolus, a piece of food that's stuck in the esophagus, and an emergency endoscopy is needed to clear it out. These are some esophageal rings and signs of scar tissue. This is a very narrow, scarred down esophagus with scar tissue. And then here you can see a much more inflamed and swollen esophagus. You don't see those normal blood vessels, and you see these furrows, which are almost these train tracks that go up and down the esophagus. And then these are exudates or white plaques that can coat the esophagus. And here you also see rings and some furrows and some swelling as well. The lining of the esophagus also tends to be a little delicate in this condition, and sometimes passing just the scope can cause a small tear or fragility of the lining of the esophagus. Then once you have those findings, we have to take biopsies. And this is what it looks like. This is a small biopsy forceps that's advanced through the scope. It takes a small piece of tissue and just leaves a little indentation here where the biopsies were taken in this patient with EOE. And you can see that these are very small, just a millimeter or two in size, and they heal quite quickly. Some people can be sore from biopsies. And then when you look at those biopsies under the microscope, this is what you might see. This is a small piece of the esophagus. and it shows EOE. This is the surface of the esophagus, so inside the tube, and this part of the esophagus is inside the body. And first of all, you can see all of these bright red eosinophil cells that really jump out at you. But you can also see lots of deep purple cells. This is called basal zone hyperplasia, where there's an expansion of additional cells. You can see space around the cells, indicating impaired barrier function. And you can see some scar tissue here at the bottom, underneath the top layer of the esophagus. Now, if we zoom in on this circle area, here's a close-up of all of these clusters of eosinophils called microabscesses. And you can see that some of the cells here have actually even released all of those granules, those pro-inflammatory granules. And so they're causing a lot of inflammation and trouble in this particular biopsy specimen. So when we think about the diagnosis, we put all of that together. We have the clinical symptoms here that are suggestive of EOE. We do the endoscopy with the findings. We see the biopsies and have to count at least 15 eosinophils to think about the diagnosis. And then we make sure that there's nothing else going on that could be responsible for an EOE for eosinophils in the esophagus, and then we can make the diagnosis. We also think about EOE as an evolving or potentially progressing disease, where it starts with a lot of inflammation with the eosinophils and other cells, and then over time that might lead to scarring. It's otherwise called fibrosis. And the fibrosis is really what gives you the trouble swallowing symptoms in adults, as opposed to the inflammation giving those other symptoms that I mentioned in children. And this may indicate that you have to do more stretching or dilation of the esophagus in adults. Well, why do we treat EOE? Well, we do this to maximize nutrition, help with normal growth and development, minimize symptoms and improve quality of life, help the esophagus look normal and healthy, help the biopsies look normal, and then to prevent complications that are due to this kind of scar tissue like strictures, food getting stuck, or even esophageal perforation where the esophagus can tear. Right now, we do not believe that that EOE is a risk factor for esophageal cancer. We don't think that it progresses to a cancer, which is good news. Now, switching tacks for the last few minutes just to the current EOE treatments. We have both treatments that are non-pharmacologic that don't involve medications. This is diet modifications or stretching the esophagus, and some treatments that involve medications. And there's a long list of different medications that you can use. Unfortunately, we still don't have any medicines that are approved for EOE treatment in the US by the FDA, but there is a topical steroid medication that is approved in Europe and Canada. And I'm going to talk briefly about some of the medications, including the proton pump inhibitors, the topical steroids, and then some of the non-medicine options, including the diet elimination and dilation. So proton pump inhibitors, or PPIs, are medications that you may have heard about. Some names include omeprazole or lansoprazole or pantoprazole, among others. These are typically thought to be heartburn and reflux medications because these meds have a strong anti-acid effect. Well, why do we use them in EOE? Well, it turns out they have good response rates, maybe 40 to 50% of the time. They will decrease the inflammation with the eosinophils and make people feel better. And it's important to realize that if these are prescribed for EOE, it's not really for their anti-acid function. They have an anti-allergy effect that works differently in EOE. They block an allergic factor that seems to bring the eosinophils to the esophagus, and they help improve the esophageal barrier and make it less leaky. So these are often one of the initial medicines that are used. Topical steroids. So what's the concept here? The goal is to coat the esophagus with an anti-inflammatory medication. It's sort of like putting an anti-inflammatory steroid like hydrocortisone onto a bug bite. You rub it and take away the redness and irritation. And since we don't have any approved medications right now, we're adapting asthma medicines and asking patients to swallow rather than inhale them to coat the esophagus. And some medications that are used may be fluticasone, where you puff an inhaler into your mouth and swallow it, or budesonide, where you may mix a liquid into a syrup and swallow it. These are taken every day and are quite effective for decreasing eosinophils in the esophagus, improving symptoms, and improving the endoscopic appearance. And within the next couple of years, if not sooner, hopefully there will be approved esophageal specific medicines. So medicines designed for the esophagus, not for asthma. And in fact, one of these medicines is what's approved in Europe and Canada. Next would be dietary elimination therapy for EOE. Why do we think about this? Well, in most people, EOE is a type of food allergy. And if the food triggers can be found and avoided, this is a very nice treatment. There are generally 3 overall strategies. There's for very ill patients or for babies, you can use an elemental formula, which has no allergens in it at all. And that can be very helpful, but it's not very practical for longer term use, particularly in older kids, adolescents, and adults. You can use what's called the 6-food elimination diet or another empiric elimination diet. That removes the foods, the top 6 or so that are seen here: dairy, wheat, eggs, soy, nuts, and seafood, and that can also be effective. There's different varieties on this, so not as many foods would be eliminated. And then there's what's called the targeted elimination diet, which isn't used very commonly anymore, where you eliminate foods based on allergy tests. And that's because our current allergy tests aren't very accurate to identify food triggers in EOE. So that's one of the real downsides of this kind of therapy, and it can be difficult to stick with the diet. But the overall goal is to eliminate a number of foods, and then with endoscopies and with the care of your doctor, add one back at a time and assess whether that individual food is a trigger. And then serially add back all of those foods until you know what the set of triggers would be. Last, I'd like to talk about esophageal dilation. Now, this was used if you do have a stricture or narrowing in the esophagus, and the esophagus has to be stretched. You can see here in these pictures a very narrow esophagus. This is a balloon catheter that's placed through the camera. The balloon is blown up, and you can see this dilation effect where the esophagus is stretched. And this is the goal. This is not an adverse effect or a worrisome tear or perforation, but this is the stretch of the esophagus that allows it to be a larger caliber. From my standpoint, it's important to use the dilation in conjunction with other treatments that are getting rid of the eosinophils, because this is just a mechanical treatment, and you need to do something to treat the inflammation as well. Now, there are a lot of new treatments on the horizon, and actually, if you look on the clinicaltrials.gov website, there were more than 35 active or planned clinical trials that are ongoing. These involve things like the custom-made topical steroids for the esophagus, a number of biologic agents that are targeted at factors that we think cause EOE, and some small molecules that also may be targeting factors that we think cause EOE. So it's a very exciting time, and a lot of new treatments are on the horizon. When we think about monitoring EOE, because it is chronic, we have to check you out over time and keep an eye on the condition. And we monitor in 3 different areas. As you might guess, since I've talked about them: the symptoms, the histology and how the biopsies look, and how the endoscopic activity is. And so these are reflected on these scales. And each one of these can be independent of the others. So you might feel better, but the esophagus and biopsies may not look as good. Because of that, we can't monitor symptoms alone. We do rely now on monitoring symptoms and an endoscopy with biopsy at the same time. Over the long term, ongoing care and follow-up are needed. The condition does not go away by itself. Treatments should usually be continued in most patients because we know if they're stopped, the EOE will flare. But treatments can change or be adapted over time. So a single treatment now is not a forever treatment for you. And then we monitor treatments with clinic visits and endoscopies. So in summary, EOE is a chronic allergic condition that causes a wide range of symptoms that are due to both inflammation with eosinophils in the esophagus and scar tissue deposited in the esophagus from the inflammation. There are multiple effective treatment approaches, so talk to your doctor about which one might be right for you at the current time in your life. Long-term treatment is required for nearly everyone, and the condition needs to be monitored long-term, but multiple new treatments are being developed. Now, I'd just like to end by pointing out this patient registry website that I've helped to found with both researchers and patient groups. This is a global patient registry that focuses on patient-centered research, and so please check it out and join if you're interested. Thank you so much for the opportunity to speak today.
My name is Eric Taylor, and I'm here on behalf of St. Francis University and myself. I was contacted to share my experiences as far as my esophageal issues are concerned. So I would like to start off to say I was always one who tried to fight through some things, you know, if I thought things were a little bit menial or minimal, to try to brush it off to the side and not really go get checked out. And I wanted to share my story because I thought that it could be helpful for those who may be having some of the same issues, but really don't know what's going on. So over the last, I'll make a long story short with how I got here, but then I'll get into some comprehensive information about my surgery and how I'm able to be here today to give this interview. So between 2001 until 2017. So let's just do a span of like 16 to 17 years. One time per year, I would have choking issues. And I thought it was because I didn't listen to mom and dad, where you didn't chew your food up 1,000 times, you know, the traditional mastication of food and swallow it and be okay with everything, because you said, okay, we have to chew our food 1,000 times, and then that is you chew your food correctly and then you swallow. And so that was like the whole common knowledge growing up. But I was having issues in Europe once or twice per year. And then I would choke on maybe, and which I thought was like a large cucumber that was sliced up in a salad, or maybe a large piece of chicken, or maybe a cube of steak that I thought I cut up small enough in order for me to swallow it. So one time per year choking, and this choking would lead to regurgitation of the lodged food. And then that would only happen one or two times a year. And so those 363 other days, I would say, okay, I think I'm okay. Until about 4 years ago, September 2017, where I was on a recruiting trip with my head coach, my former teammate here at St. Francis, Rob Krimmel, and we were at Panera Bread, and I was having a breakfast sandwich before we went out to recruit. And this breakfast sandwich would not go down. So I took a bite, it wouldn't go down. And then I told Rob I had to be excused from the table. Now, me being excused from the table, this is my maybe 20th time to be excused from the table, because one or two times per year, I would have to be excused from the table, whether I'm with a large group, and I would be afraid to say something in front of the group. So I would just remove myself from the group, and I would go into the bathroom, and then I would try to dislodge whatever food particles or bolus that I would have in my esophagus. And so this one time in July 2017, I was in the bathroom for 30 minutes. And after about 10 minutes, Rob came in. He said, "Eric, you're going to be okay." And I told Rob that I would be okay. And so this was probably the most severe time. This was the most time that I had in the bathroom. And I told Rob that I wouldn't be able to recruit. I was sweating profusely. This piece of food was still stuck in there. Even after 30 minutes, I still felt like it was there. And after about an hour or two after we left Panera, I couldn't go recruiting. I had to go back to the hotel and just relax and become relatively normal as far as body temperature, and thinking that I could be able to swallow again. I mean, not even swallow food, but just drink some water. So that was in July 2017. And I never recruited anymore that weekend. So 2 months later, to fast forward. So we have my issues for 10 to 15 years. Never went to a doctor to get checked out. Had a feeling that I would want to get checked out, but never really made it paramount to go and get checked out by a doctor. I didn't even know I needed to see an esophageal expert, just to go see a general practitioner and say, like, look, I'm having some issues swallowing. maybe I need some whatever. Maybe I need some chewing classes, or maybe I need some something that's going to alleviate my food tube so that I can swallow better. So anyways, fast forward to September 2017, 6 a.m. in the morning on September the 17th, 2017. I was eating normal breakfast, you know, eggs, sausage, biscuits, some fruit. And I swallowed a couple times, and then it went down okay. Mind you, 2 months ago, I had the issue in Panera Bread. Fast forward now, I'm 2 months later, I'm eating food completely normal. And then I swallow this food and it went down totally okay. But then I felt a pop in my my upper stomach area. Within seconds, I felt faint. So 6 a.m. eating, 6:05, pain in my upper stomach area. 6:06, I feel like lightheaded. 6:07, I get up. 6:08, the waitress says, "Hey, are you doing okay?" Within 10 minutes, I feel like the left side of my head is going numb. The left side of my arm is going numb. I started to feel my fingers, and they went numb. And then I started to get short of breath. And it's 6:10 a.m. I'm on the ground, and I'm bleeding for my life. So at this time, I actually thought I was dying. So felt like I was having a heart attack. My breaths were getting shorter. I started to think back of like, all right, what was I eating? What was I doing wrong? Like, was I eating something within the last like 2 to 3 years that caused my maybe blood pressure to elevate, or maybe cholesterol elevated, or because I eat relatively healthy up until that point. So anyways, so I tell the waitress, get some nitroglycerin. She didn't have any. I told her to go get some. Within like seconds, someone is on the ground praying with me, and we said the Our Father, preparing me for potential afterlife. And so me being a believer, I prayed. And I didn't know that this was going to be my last second on earth. And fast forward to present day, what happened between the time that I fell on the ground praying, saying the Our Father, to now, I found out that I'm allergic to 10 types of food elements: soy milk, cow's milk, eggs, whites, 3 types of tree nuts, and a list of some fruits. And this was by way of food sensitivity tests with a prick on my skin. And found out, like I said, found out I had those elemental allergies. And also I was diagnosed with the condition of eosinophilic esophagitis. So this is a condition where, in my case, when you eat certain foods that you don't know that you're allergic to, these foods send these allergenic foods, in my case, what I'm allergic to, send eosinophils to the esophagus to fight off these allergens that you intake, creating an inflammatory situation in your esophagus. So your esophagus goes from what's supposed to be like a diameter of a quarter, but over time becomes the diameter of that right there, basically non-existent. a non-existent diameter, which causes the choking. And so that is in a nutshell of the issues that I have, that I had over years, untreated, unchecked. And so to anyone that may be having issues with their gastrointestinal tract that may resemble things that they may have heard during my testimony, I really, really recommend that you see a general practitioner or someone of the sort to just really get a check over, get an EDG, get maybe a potential check of maybe your tract, your gastrointestinal tract, just to see like, okay, what is going on? Maybe get an allergy, maybe get a baseline allergy test for if you feel like there could be something going on, just because I will say that I am a living witness that I was 1 second away from going away from the earth or not living a second more on the real time earth because of taking for granted a potential issue that I had with my body. So listen to your body. If you feel like things are severe enough, go get checked. Right now, I have modified my diet. I am a paleo diet. I have a paleo diet. I stay away from and very minimize my allergic elementals that I know that could potentially cause the eosinophilic triggers. Think about eosinophilic esophagitis, look it up, research it. It's a real thing. I will come out of the taboo and say, like, it is something that a lot of people deal with, especially taller, skinnier, skinny, tall people, whether you're male, female, no matter what. These are issues that are more prevalent in that population than other populations. And I really hope that someone, if you're listening, that it could help you in your journey as you try to become a little bit more healthy, or try to diagnose some things, or try to get some help in potential issues that you may be having as far as gastrointestinal issues that could be present in your body. So I really appreciate it. I wish everyone well, and thank you so much.
Thank you so much for joining us today for the IFFGD Norton Educational Series 30th Anniversary Edition. You just finished watching our very last session of this 2-day program on heartburn and reflux, and we heard from 2 fantastic, well-known physicians and then 2 amazing patients who shared their stories with us today. From this, we do have some questions that we are going to direct to Dr. Chey and Dr. Chang. And the first really and truly is in the GERD section. So we get a lot of questions, and we had some questions today about PPIs and the staying on them long term. Is that safe? And then if you have GERD for a very long time, are there risk factors of leaving that untreated or not treated well? So maybe, Lin, do you want to talk a little bit about PPIs and their safety?
Yeah, so PPIs are proton pump inhibitors, and I don't know, we'll see how Bill describes this because it's described differently. These are highly effective medications for esophagitis, GERD, ulcer disease, but there are a series of large database type trials where they get a lot of information that's stored, and PPIs are very commonly taken, and there have been some associations that have been described that are statistically significant. The question always is, are they really clinically meaningful differences with PPIs and a number of different effects, like on the kidney or on cognition. But the real point, I think, of PPI use is that they're probably overused in the population. Many people may need it, but they stay on it and they don't know if they really need to stay on it. They just continue it. It keeps getting refilled. So the important point is that if a patient really doesn't need it, or they can be on another agent like a
histamine 2 blocker like famotidine, then they should really do that or just try to get off the PPI. Because I just think that if they need it though, and their symptoms are not resolved unless they are on a PPI, then they should stay on it because the benefit outweighs any risk that's small. But if they can get off it, they should.
And what are those risks?
So a couple comments. First, there are a lot of potential risks. So Lynn touched on chronic kidney disease, bone disease, heart disease. Literally, virtually anything you can think of has been associated with PPIs, but this is the really critical thing for everybody to be aware of. These are associations. They don't prove cause and effect. So for example, if a population of people taking PPIs happens to be older or more obese or have diabetes, they're going to be more likely to have a lot of those other complications, kidney disease, heart disease, bone disease, etc. And it's from those things, not from the PPI. The one thing that has been proven to be associated with PPI use are enteric infections, so gastroenteritis. So for example, if you go to a country where the water isn't clean or the sanitation system isn't up to par, there's a greater likelihood of developing gastroenteritis if you're on a PPI than not. And that makes sense because if you think about it, one of the main purposes of acid in your stomach is to help sterilize your food. So if you inhibit the production of the acid, the bacteria that you ingest with your food or the water you drink in an unclean environment is going to have a much greater likelihood of getting into the intestine where it can take root and cause, in some cases, even a serious infection. So that's true. The rest of it is much more smoke than it is fire. You know, what Lynn said is absolutely the bottom line. If you have a clear indication or symptomatically you need to take PPI, then take PPI. Is it safe over the long haul? Yes, it is. But there are many, many patients on PPIs that don't need to be on PPIs. And those patients shouldn't be on PPIs. And so who needs to be on a PPI? Well, if your symptoms only get better on a PPI, there you go. But if you have a known history of erosive esophagitis, so if somebody's done an endoscopy and finds ulceration in your esophagus, you need to stay on the PPI, because if you go off the PPI and you take less potent medications, that esophagitis is likely to come back. If you have Barrett's esophagus, you should stay on a PPI. And if you have eosinophilic esophagitis with difficulty swallowing that gets better on a PPI, you need to stay on a PPI.
Very good. Wonderful. And so what about people who have acid reflux and they have these GERD symptoms, and so they keep the Rolaids or the Tums in their pocket, they're taking a lot of these self-medications, but they're really having a lot of symptoms, but they feel like it's normal for them, they have it controlled. You know, I know that we always at IFFG encourage people to go see a healthcare professional and at least have it checked out. And what are some of the risks that might come if they don't do that, if they just sort of deal with it on their own? What are some things that, is it imperative that they see a healthcare provider? Are there risks to not seeing a doctor?
Yeah, particularly within specific demographics or groups of individuals. So for example, if you're an obese white man and you're having chronic acid reflux symptoms, there's a much higher likelihood of developing long-term consequences, potentially serious consequences, like a precancerous change in the esophagus called Barrett's esophagus, and then in the worst case, actually esophageal cancer. So certainly if you're an obese white man and you're having chronic acid reflux symptoms, you definitely want to make sure you see a doctor. I would even argue that really anybody that's having frequent, and by frequent we typically talk about more than 3 times per week, for years at a time, of heartburn, you should seek the advice of a physician who is going to take a careful history, help you to be on the most effective therapy for you, and also decide on whether additional diagnostic testing like an endoscopy is necessary. So you don't want to leave this to chance, because here's the other interesting tidbit. One of the fastest rising cancers in the United States is actually esophageal cancer. So it used to be one of the rarest cancers in the United States. It's still rare, fortunately. I don't want to scare people too much, but I do want to make this point, which is that of the various cancers that attract, esophageal adenocarcinoma which is the one associated with acid reflux, is one of the fastest rising cancers in the United States.
I think the more common effects though from heartburn and acid reflux is getting inflammation. You can get ulcers, bleeding, and then also when the inflammation is trying to heal, you can get strictures, which is a narrowing in the esophagus, and food can sometimes get stuck.
Fantastic. Thank you so much. And not trying to scare you guys at home. However, it is imperative and is so important that you do talk to your healthcare provider. Like Bill said, if you're having symptoms of heartburn or any sort of esophageal symptoms that are more than 3 times a week and are ongoing, please go see a healthcare provider to see if there might be something more going on or if there's something that can be done to help you and get rid of those symptoms for you. So let's talk a little bit, few other questions we received, especially around our patient story. So Louis mentioned that there was a connection between his GERD symptoms, his reflux, and meat. And that's not one of the things that we hear commonly. It's spicy foods, tomato-based foods, highly acidic foods. Is that common? Do you see that in your practice, meat?
Well, 2 thoughts that come in my mind. I'm hoping it's not dry meat that he's swallowing and it gets stuck, because there's some narrowing or stricture. So that's one that you hear often, a piece of chicken or a piece of steak and it gets stuck. And I don't know, if that was really what he was referring to. But also, meat has more fat in it. And when people have reflux disease, foods that contain fat are emptied out of the stomach slower. They also cause more relaxation of the muscle, the sphincter that connects the esophagus from the stomach and allows acid to reflux from the stomach into the esophagus. So that might be part of the reason as well. So patients really should try to follow some of the recommendations, dietary recommendations and other lifestyle recommendations to help their GERD symptoms. So maybe they don't need the PPI, the high dose. Maybe they could use, famotidine or something else to treat their symptoms.
Awesome. He also mentioned something about the polyp. So we heard him talk about the polyp that the doctor wasn't concerned about. They waited some time, it did shrink, and things got better. I know that for so many people, you hear the word polyp and it really scares you. So a polyp in the esophagus or stomach area, that's not something to be alarmed if your physician tells you that?
So first, just realize that there polyps in the colon can be either precancerous or just completely benign, and we get concerned because of those precancerous polyps can lead to the development of colon cancer. In the stomach, it's very unlikely for people to develop precancerous polyps. They're almost always entirely benign. They're specifically called fundic gland polyps. Now, fundic gland polyps are associated with chronic PPI use. So chronic use of proton pump inhibitors creates an environment in which these fundic gland polyps can grow. And they can come and go. So I bet almost assuredly what Louise was talking about was a fundic gland polyp in the stomach associated with PPI use. And if you follow these things over time, they come and go. And fundic gland polyps are entirely benign. They hold no precancerous predisposition.
So again, that's something to have a really strong conversation with your physician or your healthcare provider to make sure that you understand what types of polyps that you have, and that is definitely a good conversation. So let's move on to, actually there was one other question about dilation, and how is that done? Is that something that you're put to sleep? You have a anesthesia? Is that local, or are you asleep for the procedure, and does it hurt with the dilation?
There's different ways of doing dilation. Most often, it seems now that it's done during the upper endoscopy, during the upper endoscopy procedure. If they see so often they will get a consent just anticipating that maybe there's going to be a stricture, that I'm going to dilate it if I see it. And they do it often like with a balloon, where they open a balloon. And do it very safely, just incrementally increasing it so they can dilate any stricture. And the patient is asleep during that time, during upper endoscopy. There's the other ways that people used to do it, where they would actually be wide awake and pass the dilator
into their esophagus and do it even at home. That's not really done that much anymore, but that used to be done, and the patient would know when they would need to do it.
Wow.
But that keeps food from getting stuck, and
Right,
they'll
right.
be so much more comfortable. Because, as we were talking before, got to be one of the most uncomfortable, experiences is feeling like food is stuck and you
Really
can't
quite-
breathe. I mean,
Right.
it's scary.
Absolutely. And so let's go ahead and move on to the EOE questions that we received. And some of that is around when you're in that moment and you feel that you have that food stuck in your esophagus. And what can you do at that moment?
So there's probably no more frightening feeling than choking, and so the first thing is just realize that the more anxious and upset you get, the less likely the food is going to be to pass. Now that's really easy to say. That's much harder to control. But sitting up straight and taking a few deep breaths, maybe even closing your eyes and really trying as best you can to relax, may help your esophagus to relax and allow the food to go through. You can certainly try a small sip of fluid to see if that might lubricate things and help it to go through. But what you don't want to do is start eating a lot more food or drinking a lot more fluid in the hopes that it'll push it through. The reason why I say that is because if it doesn't push it through, then what's going to happen is it's going to accumulate or back up in your esophagus, and when enough food or liquid gets there, it's going to increase the likelihood that it aspirates into your lungs. Okay, so it also makes it much more difficult for the endoscopist, if you need an urgent endoscopy, to dislodge the food, to be able to fish through and weed out all that food that's now stuck in your esophagus. So what you should do is give it a few moments, try to relax, close your eyes, take a deep breath, maybe a sip or two of fluid. If that resolves it, great. If it doesn't resolve it, within some set period of time, then you probably need to come into the emergency room. And there are medications that the emergency room staff can give you to try to relax your esophagus. And if those don't work, you're going to need an endoscopy to dislodge that food that's stuck in the esophagus.
And so definitely something that if you have been diagnosed with EOE, or if you suspect that you might after listening to today's talk, please, talk to your healthcare provider about these things that you can do in the moment, and make sure that you're prepared for that. Even if you haven't had one of the severe episodes yet, make sure that you are well prepared with your physician to know, the severity of your EOE and what is a set amount of time that you should be waiting before you actually do go to the emergency room. Not something that you want to be taking a chance with, for sure.
Ceciel, let me just say one thing too, which is that the key takeaway point for the audience is don't let it get to the point where the food gets stuck like that. Like sometimes the first time this happens, that's what happens. There's nothing you can do about that. But many times, in fact, most of the time, patients will tell you, oh yeah, I've been having some subtle problems for a long time, but it always just goes away on its own. I've just ignored it. And what you want to do is make sure you don't ignore that. Actually, that's dysphagia, or difficulty swallowing, is what we consider a warning sign or alarm feature. And it's an indication to get an endoscopy to understand why you're having that symptom. Okay, so it's better to be proactive rather than at a point where you're really getting into trouble.
And I think that, Eric really brought that message home, I hope, to all of you in the audience. As he did say, he had issues in the beginning, just like most patients do, and it wasn't until he was laying on the floor in the restaurant and ended up in the emergency room. So please, 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 absolutely, don't let it get to that point. Go see your healthcare provider if you're having any difficulties at all. A lot of times, I think most of us don't take that sort of esophageal disorders as seriously. Everyone has heartburn, right? Everyone has issues, but really and truly, if you have any suspicion at all that you should, do it. It's better to hear that everything is normal and fine than to have issues later.
It's definitely treatable. A lot of esophageal diseases are treatable and, preventable.
Absolutely. So thank you. All right. So I believe that's about all that we had on the questions for this session. So that is rounding up our entire program. This has been a fantastic weekend, and we really thank all of you who have joined us. This event has been very, I think, educational. I've learned a lot personally listening to all of these wonderful talks and had such great discussions. Thank you, Lynn and Bill, for coming into Charleston this weekend and sharing this experience and doing this. And again, many thanks, of course, foundationally to Nancy and Bill Norton, who were the founders of IFFGD, who are just amazing advocates for all of us with GI disorders, who've done so much over the last 30 years to improve the lives of all of us and in the GI illness community, and to create this wonderful organization. And then, of course, to all of the staff here at IFFGD. I have to say, Jamie Dumont, our Director of Operations, really stepped up to the plate, and without her, none of this would have happened. So everybody just, if you want to send an email and say, way to go, Jamie, that'd be fantastic. We also have Emily Taylor, who is our patient engagement manager, who's been very instrumental in a lot of the logistics for this weekend and the scheduling that has happened to get all of these recordings done. Alyssa Sutton, who is our web master, who has created all of our wonderful web pages and has really done a great job making that just so beautiful and up and ready for us. Please remember, everything will be live tomorrow morning on our website. If you missed any of the talks, or if you want to share a talk that you heard with a friend or a loved one, please, please, please do that. And then, of course, we have our social media team, Haley McCorkle, who is our manager of public relations, and then her sister Kelsey McCorkle, who has been such a great volunteer in helping us, and then our media intern Yoshi Rooker. Thank you to all of you for your hard work on this event. And then, of course, to, as I mentioned in the beginning of the day, are the supporters who financially helped us to make this program possible. We have AbbVie, Ironwood, and Takeda. Many thanks for their generous support of this program. Please remember that all the content will be available, and to visit our exhibit halls when you can. Just to let you know, our next Norton Educational Series event will be in April of 2022. We are anticipating a live event, this time in Chicago. It will be on irritable bowel syndrome in conjunction with Northwestern University. Darren Brenner, who we heard from yesterday morning, will be hosting that event and is the program coordinator for that. And so we're really, really excited. Registration is available now. And please, please go out, register for this event, share it with your friends and your loved ones. And we really, really hope that you'll be able to join us for that. And just to round out the day, in case you missed it yesterday, we like to do a honor and memorial wall for people in the GI illness community. And so we will play here at the end of the program a video that includes all the hearts and candles that we've received during this registration process. The hearts represent those of us that are in the GI illness community, and the candles are for those that we have lost that are in the GI community. We hope that you will just take a moment and join us in honoring these folks as we close out our day. Thank you again for being with us the last few days, and we hope that you've enjoyed our program.